Universitas Jenderal Ahmad Yani Cimahi akan menjadi hybrid university, di mana mempertahankan kegiatan konvensional belajar mengajar, namun pada saat bersamaan menjadi open university yang memanfaatkan information communication technology dukungan dari Telkom Indonesia.
Dengan ini saya resmikan penerimaan mahasiswa baru Universitas Jenderal Ahmad Yani.
Universitas Jenderal Ahmad Yani Cimahi akan menjadi hybrid university, di mana mempertahankan kegiatan konvensional belajar mengajar, namun pada saat bersamaan menjadi open university yang memanfaatkan information communication technology dukungan dari Telkom Indonesia.
Dengan ini saya resmikan penerimaan mahasiswa baru Universitas Jenderal Ahmad Yani.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Very good morning, everybody. We meet again in the second day webinar. Today, Sunday, 6 November 2022. I will be with you all in this webinar. I'm Amurti Ningsih. In this wonderful and precious chance for me to be your master of ceremony. Welcome to this webinar with topic today, early warning system, early warning score and code blue update in nursing services. First of all, let's pray and thanks to God, Allah Subhanahu wa Ta'ala, who has been giving us some blessing, happiness, healthfully, and mercy, so we can participate in this international nursing webinar. Ladies and gentlemen, of this webinar participant that I appreciate, I would like to thank you very much for spending some time with us yesterday and today. Our event today will certainly provide many lessons for our about early warning score and code blue update in nursing services because the speakers in this webinar are experts in this field. There are Donald S. Exacano, PhRN, SSDRN Man from Tarlac State University, Filipina. Second, Prof. Dr. Pratuma Ripto from Naresuan University, Thailand. Third, Fauziah Rudiati, Magister Keperawatan, Spesialis Keperawatan Anak from Faculty of Health Science and Technology, Jenderal Ahmad Yani University, West Java, Indonesia. Fourth, Profesor Rasidi Ahmad from University of Malaya Medical Center, Hospital, Malaysia. And the fifth, Dr. Aliana Dewi, Master of Nursing, Head of Hyper C from Binawan University, Jakarta. At this scientific moment, I would like to say welcome all speakers, Head of the Nursing Master Program, Faculty of Health Science and Technology, Jenderal Ahmad Yani University, Manager of Education and Training Madani Health Training Center, and Chairman of Commissariat Board, Indonesia National Nurse Association, Jenderal Ahmad Yani University. This webinar was organized by the Madani Health Training Center and was supported by the Faculty of Health Science and Technology, Jenderal Ahmad Yani University, and Rumah Peka Indonesia. The agenda for today's webinar is opening, second, sing a national anthem Indonesia Raya, and Mas Indonesia National Nurses Association. And third, welcoming remark, and fourth, main session webinar, and fifth, presentation of evidence-based nursing research from Magister of Nursing student. Ladies and gentlemen, please remain sitting up, strike for the Indonesia National Anthem and March of Indonesia National Nurses Association.
Perawat Nasional Indonesia, wujud ikatan profesi perawatan. tempat membina dan mengembangkan kemampuan diri dalam membuktikan keberadaannya. Menapaklah dengan keyakinan lebih pasti, sejajar dalam abdikan diri, bangkit berdiri dan langkahkan kakimu itu, menatap hari esok penuh asa. Wahai perawat Indonesia, bangkitlah dan majulah untuk menolong sekalian yang menderita. Kuatkanlah pribadimu, tingkatkan pengetahuan untuk memberikan asuhan keperawatan. Kita melangkah untuk mengisi pembangunan bangsa negara Indonesia, untuk mengantarkan bangsa menuju sehat semua dengan semangat jiwa Pancasila. Maju perawat, majulah dalam kancah pembangunan, tunjukkanlah pada sekalian orang. Jadilah perawat model kesehatan bangsa kita, jadilah teladan dalam hidup sehat. Bangkitlah perawat seluruh Indonesia dalam mengemban citra profesi, menjunjung tinggi kode etik keperawatan, laksanakan panggilan tugas mulia, mencapai derajat kesehatan seoptimal mungkin bagi warga negara Indonesia. Sebagai bukti kiprahnya mahkota putih suci dalam mendukung pembangunan kesehatan. Dengan organisasi PPNI yang kokoh, padu bersatu serta selaras, perawat Indonesia akan mampu angkat citranya di mata insan dunia.
Ladies and gentlemen, please sit back, relax, and enjoy of this webinar today. Now, let's continue to the next agenda. To kick off this morning webinar, we are delighted to have our own Chairman of Commissariat Board, Indonesia National Nurses Association, Jenderal Ahmad Yani University, Mr. Krishna Wisnu, Master of Nursing. This time is for you.
Assalamualaikum warahmatullahi wabarakatuh. Good morning.
Waalaikumsalam warahmatullahi
Greeting to all
wabarakatuh.
of. I respect the head of the Master of Nursing Study Program, the University Jenderal Ahmad Yani Cimahi, Mrs. Dr. Iin Inayah, SKP MKep. Respected Civil Health Training Manager, Mr. Dr. Mira Asmajanti, my respect speaker, and also I am proud of the participant of the webinar. Praise and gratitude we pray for the presence of God Almighty, for His blessing and grace we have been given healthy until now, even in this pandemic era. I really appreciate the nursing seminar organized by the Health Training Center in collaboration with the Master of Nursing Study Program in Unjani. Happily, the Civil Health Training Center will continue to innovate the field of nursing. And hopefully, the nursing webinar on EWS and Code Blue update can be carried out well and conducive. Amen. The theme that will be presented today is very important for us nursing in handling emergency situation. Emergency service are the professional service based on the science and methodology of emergency nursing in the form comprehensive bio, psycho, socio, spiritual service. I am the patient who have actual problem of raise the treated life. A cure suddenly or cannot be predicted and without or accompanied by uncontrollable environment conditional. The series of the activity carried out the development in such a way as to prevent death or disability that may occur. Early warning score are more focused on detecting emergencies before they happen. So I hope with early treatment, life-threatening condition can be treated more quickly or even so that a resulting output is better. Finally, I congratulate your own participation in the webinar. Hopefully, what we are doing today will be blessed by Allah Subhanahu wa Ta'ala. And I also hopefully useful for ourselves and for our patient. I am the chairman of DPK PPN Ifitkas Unjani. I apologize if in my speech there are words that are not pleasing. Wabillahi taufiq walhidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Mr. Krishna Vishnu, for the very energetic opening message. Ladies and gentlemen, before the webinar starts, we will take photos. Please open your camera, prepare best your smile. Okay, thank you for the committee. For information, you all webinar participant, the attendant link will be shared in the chat column after the last speaker has finished delivering the material and answering question. Okay, entering the main session of the webinar will be guided by moderator. Her name is Musri Kamdah, Magister of Nursing. She is a nursing doctoral student in Indonesia, Malaysia, with more than 30 years of experience as a lecturer in Indonesia and Malaysia. Currently, she is a senior lecturer at the Faculty of Science and Technology, Jenderal Ahmad Yani University. Ladies and gentlemen, hopefully this webinar event will improve your knowledge. Relax, enjoy with this webinar in the morning. Mrs. Musikamda, this time until 1:30 p.m. West Indonesia time is yours. Thank you.
Okay, thank you, Mrs. Murtiningsih. Okay, I will introduce myself to new audience. Good morning for everyone. Thank you all for finding time and joining today's webinar. Okay. My name is Musri Kamdah, and I'm a nursing lecturer at Faculty of Technology and Health Sciences, University Jenderal Ahmad Yani, Indonesia. Okay, I just remind again about the seminar. First, now I'm going to check with the audience if you can see and hear as well. I hope my voice clear for you. I will quickly go through some points to note so we all have a good webinar experience. If you have technical problem, please first check the following basic. Is your internet connection stable? Are your headphones properly connected? Is the volume level appropriate? Dear audience, as has been announced, today, Sunday, 6 November 2022, the International Nursing Webinar takes the big theme, Early Warning Score or EWS, and Code Blue Management in Nursing Services. Before presenting the subject, let me give a little introduction related to the article that will be delivered by the presenter. Basically, scientific forums like this are very important and interesting to follow because a lot of information will be obtained. However, it should be noted that the delivery of this information will be easier to understand if the discussion runs effectively. Therefore, it is hoped that all audience will pay attention and participate in the discussion as interactive as possible. All right. Then I will convey some of the provision of our core event as follows. Each speaker has 40 minutes to deliver the subject. As long as the presenter delivers the subject, participants are not allowed to interrupt. The question and answer session will be open after the presenter have delivered their subject. We advise you to type your question in the message box. Thus, a moderator will be able to select interesting questions. Such a system will also make it easier to keep order. Now we begin with the first speaker. The first speaker is Mr. Donald S. Escano. Mr. Donald, please add information about your career before you're presenting your subject, because I just have the old one.
All right.
Okay. Mr. Donald, scholastic and academic competency, his top notcher 14 placed on November 2015 nursing license examination with 83.60%, very high. Highest board rating in Tarlac State University College of Nursing batch 2015. June 2013 to April 2015, Vice President for External Affairs and Red Cross at Tarlac State University. And educational background, La Consolacion University Philippines, Master of Art in Nursing, major in Nursing Service Admission. Today, he will present about update early warning score atau EWS for adult and pediatric in nursing services. Please, Mr. Donald, it's your time.
All right. Before I start, I just want to confirm if my voice and video is clear.
It's clear, Mr. Donald. It's okay.
Okay. So again, thank you very much again for the organization, Dr. Ian, to everyone, to our participants and students. Thank you very much again for having me as your speaker. For those who are new today, because yesterday I discussed about triaging and color tagging and START method. I am Sir Don Kim Tan. I am a nurse here in the Philippines and a registered nurse in Abu Dhabi. I am also working as a professor in Tarlac State University, major for competency appraisal subjects. I also work here as a national lecturer for the review of Philippine Nursing Licensure Examination and international lecturer for nursing seminar. Okay, so today I'm going to discuss to you the EWS, or the Early Warning System, which is the updated one. So I hope everyone will listen. Just for the information, I will be focusing more on adult because we have a very limited time. Okay, so I will be focusing more on adult, but I will also send the video link for the pediatric. But then again, I will more focusing on the papers on how to fill up and how to use the early warning system for adult clients. So let me share my screen so that I can share my slides to you. For our moderator, please inform me if my voice is not clear and my internet is not clear anytime, so that I can.
Okay, Mr. Donald.
All right, so let me start my presentation slide. Okay, I do. Okay, so I'm going to discuss the essential of the early warning system, meaning to say the most important parts of the early warning system device. Okay, so what is early warning system device? So before anything else, for a while, I will just check the file. Okay. So what is early warning system? Okay, so what is early warning system device? So let's check here the map that I make. So the first thing that you can see, the brown one, there is an observation. Okay, if you can see the observation, the color brown. Okay, observation meaning to say there is an assessment. Okay, there is a nursing assessment, and as a nurses, as a healthcare provider, one of the characteristic that we should have is a clinical eye. Okay, clinical eye that is used for assessment, meaning to say if the observation is not done, if this observation is not done, there will be no early detection. So meaning to say if you did not assess someone, if you did not assess your patient, there will be no early detection. So if there is no early detection, there will be no timely response or no intervention. There will be no competent response. And if there is no competently response, that will not be escalated. Meaning to say, we will not going to communicate it to the higher positions or to your managers or to your physician. Therefore, there will be high number of hospital admission. Okay, or worst scenario, there will be result of death. Okay, in the other part, if there is no observation, there will be late recognition of the symptoms, or there will be late recognition of the situation of your clients. Therefore, there will be no response, and it may result into increased hospital day of admission or that. So meaning to say, nurses, if there is no assessment, if there is no proper assessment, there will be high risk of more complicated clients or death number. So what is the connection of the early warning system here? Okay, so what is the connection of the early warning system here? So if you can see here, let's appreciate the importance of an early warning system. So later on, you will know what is early warning system device. So basically, it's just a paper, but that paper is very important. So we will going to study later what is the composition of that paper. Okay, so here, this is a good side that we have now the paper. We have the new early warning system paper here. So, meaning to say, if you use the early warning system paper, if you use the assessment, okay, there will be an early detection of the sign and symptom. All right. So there will be an early detection. There will be an timely response because you detect already the sign and symptoms. If there an early timely response, there will be competent response. Therefore, the hospital stay of your client and the possibility of the death will be decreased. Why? Because there is an early assessment. Because if there an early assessment, there can be prevention or there can be a treatment. Okay, early treatment. Therefore, we will going to have a very good outcome. All right, so that is the beauty of early warning system. If we are using the paper, okay, for the assessment. So here, this is a bad side if we will not going to make a good assessment. Actually, we have a different type of assessment that we are using. You know, we have the ADPI, we have the SOPI, we have the APGAR scoring in pediatric client. We have a different type of papers that we are using in hospital. So this one, the early warning system, is a new one. Actually, this is used commonly in United Kingdom. Okay, almost of the hospital there are using the early warning system device. Here in the Philippines, when I'm working as a nurse, I did not encounter this one. And if you're planning to take the OSCE, the international exam, if you're going to work in United Kingdom, there will be a specific exam about this early warning system device. So if you're planning to go abroad, you have to listen to me today, because we're going to discuss everything and the most essential part. Are you still listening with me?
Yes.
Okay, so let's start. What is an early warning system? An early warning system is a chain of information. Okay, there's a chain of information, communication system and sensor, event detection and subsystem. Okay, so the big word here for early warning system, it may use a communication. Okay, this paper is a communication tool so that you can effectively escalate to your higher positions, to your manager. Okay, it's also serve as an early detection tool. You can detect if the patient is deteriorating. All right. Next one. Okay. Early warning system, okay, scores are tools used by hospital care team to recognize early signs. So meaning to say, there is a score. Later, we're going to talk about the score number. Okay, and those score have corresponding meaning that will tell you that if you need to escalate, you need to collaborate, or you need to do some urgent action. Okay, so this early warning system, there will be scoring later. We're going to do the scoring later, so that we're going to initiate early intervention and management, such as increasing nursing attention, or we have to increase the monitoring the patient, or maybe we need to notify the physician or the doctors or the other healthcare team. Okay. So early warning system device, what is the purpose is this one? To ensure timely and appropriate management of deteriorating patients in general hospital wards. Okay, what is the big word here? What is the big word here, nurses? The big word here is the word timely, meaning to say we are doing the early warning system device to assess early, okay, to detect early deteriorating sign and symptoms, so that we can have a good and timely management. Because you know what, in deteriorating clients, minutes, seconds, hours is very important. So if you have a late assessment, if you have a late detection, therefore there will be late action, and the late action would result into poor prognosis. When I say prognosis, the process of healing, there will be poor process of healing. Throughout the world, the EWS, or the early warning system, is based on the principle that clinical deterioration can be seen through changes in multiple physiological measurements. Meaning to say, when I say physiological measurements, it includes your respiration, it includes your temperature, your vital signs. Okay, so if there is a changes there is a sign and symptoms that the client condition is changing, maybe not good changes or a good changes. So we're using this, as well as a large changes within a single variable. However, the scale is calibrated to a different population, and sometimes it expand to include additional parameter specific to different parts of the world. So later on, maybe if you are working abroad, if you are working into an international hospital, you can see that maybe there is a difference of EWS system papers from other hospitals. So it's institutional per institutional policy. But the same thing about it is the physiological measure. Okay, the same about it is the purpose of the EWS, and the purpose of early warning system device is to detect early abnormal changes, so that we can have a swift and timely management for your clients. meaning to say that the scale is or can calibrated, meaning to say it can be changed from hospital to another hospital. They can include another parameters because we have only 6 parameters later. I will tell you what is the 6 parameters in using the early warning system device. Okay, there are 6 parameters. So maybe in other hospital, they can add. It depends on the expertise of the hospital. All right. So the EWS is supported by an online training module. So there will be a certification and completion on the training. So there is a link here. If you can see the link, that is the link if you want to get a certification training if you're working in your hospital, so that you can have this paper and you can use it accordingly inside your hospital. So this is the link. You can take a picture here so that you can attend the certification program on how to properly use. But today I am going to show you how to use the EWS paper. So may I ask everyone, ma'am, is there a hospital here or is there a member here that is use early warning system device as of the moment? Do you use early warning system device as of the moment?
Yes, actually in hospital.
Oh, I see. Okay, so again, the early warning system device can be calibrated, meaning to say the early warning system device can be modified. It depends on the expertise of the hospital. It depends on the institution policy. But what is the same principle again when we're using the EWS? The same principle is what? We are using this to have an early detection, so that we can have a timely management for our clients. Therefore, there will be good prognosis. Therefore, it will decrease the stay in hospital or even to decrease the chances of death. Okay, so that is the link. Next. So maybe you can identify that there is a NEWS score, which we are talking now. This is developed by the Royal College of the Physicians to provide a national standard in UK. So this is originally from United Kingdom, the National Early Warning Score. Okay, that's why they are using this in United Kingdom. There's also for pediatric, the PEWS. Okay, designed to support the use and track trigger. This paper is used under 16 years old, and we have also the early warning score in obstetric client in OB, in maternal. There is what we call MEOWS or the meows. Okay, this very cute meows. Okay, so that is your NEWS for adult, PEWS for pediatric, and MEOWS for your maternal. And I hope next seminar we're going to discuss more detailed about obstetric, but today we're going to focus on adult only because of the time limitation. So NEWS2, why there's a number 2 here? NEWS2, because this is the latest version. This is the updated version, because the first version, the first paper was produced last 2012, and they updated it last 2017 December, which advocate a system to standardize the assessment. Meaning to say, to standardize, we have to use these given parameters so that we have the standard paper all throughout the world. So they updated it to standardize the assessment and response to acute illness. Okay, so these are the 6. Okay, these are the 6 parameters that will be used in your early warning device. So it involves, number 1, your respiration. Okay, your respiration status. The next one is your blood pressure. The next assessment would be talk about your heart rate or pulse rate. Another will talk about your pulse oximeter or your oxygen saturation. Another is your temperature. Next one is the level of alertness or the GCS, the Glasgow Coma Scale. Is the client confused, oriented? Okay, and the last thing is about respiratory system. So these are the 6 parameters that we can observe later on the paper. Okay, so I will present you now the exact paper. All right, so please listen and watch the video about the paper. All right.
Hello. The National Early Warning Score, or NEWS, is a number that can be calculated from 6 observations or vital signs.
Okay, so this is my friend from NHS, National Hospital. So here first, he's discussing to you the 6 vital signs that is needed for the EWS that we discussed a while ago, which is the breathing, the oxygen, blood, and the heart rate. Please listen to my friend.
Heart rate, also known as pulse rate, blood pressure, level of alertness, and temperature. You must have all 6 vital signs to calculate a NEWS score. The total score is very accurate in predicting how unwell someone is. Each vital
So here, let me show you the standard paper of the EWS. Okay, this is the paper. Please check.
sign should be written down on a paper news chart or entered onto an electronic observation system. If you are using a paper chart, then it needs to be printed in color so that you can calculate the final score.
So first, let us appreciate the paper first. What you can see on the paper. Okay, the paper is number 1, color coded. There are colors. There are numbers here. Okay, there are numbers here. These are the parameters. You should know what is the normal parameter. So this is the respiration for the auto saturation here. The air and oxygen, the blood pressure, the pulse, and the column C. Column D is the consciousness. Column E is the temperature.
In NEWS, each vital sign is given a score. The score ranges between 0, which would be normal, and 3, which is very abnormal.
So here, nurses, these are the actual scoring. Okay, I cannot tell you everything here, but I'm just going to tell you this one. Check for the respiratory rate. Okay, check the respiratory rate, the upper part. So the normal is 12 to 20 for adult. Okay, therefore, if the respiration rate of your client is 12 to 20, you will mark it 0. Later, I will show you the exact marking or the exact scoring. Okay, so this is the scoring parameter. Okay, we will going to use the respiratory rate, the oxygen saturation. Okay, the scale 1 and scale 2. Okay, the scale 1 here, scale 1, we are using commonly this one. Okay, we are using commonly this one. The SpO2 scale 2, we are using only this under the instruction of the doctor, because there is a specific lung condition. That's why you are using the scale 2. But for normal individual or for respiratory problems only, if there's no lung problem, there will be use of scale 1. That's why there is scale 1 and scale 2 here. Okay, here for air oxygen, if the client is not using any oxygenation, it's just considered as 0 because air only. Okay, if the client is using oxygenation, okay, so you will put number 2 or grade 2. Okay, for the blood pressure, you will record only the systolic blood pressure. Again, for the blood pressure, you will record only the systolic blood pressure. Okay, and of course the pulse. If the pulse is within 51 to 90, that is normal. That is 0. Okay, for the consciousness, if alert, 0. Okay, if temperature is normal, 0. So we want a lower number here. We want lower scores here.
News charts are color-coded to help you add up the correct news. If you're using a paper chart, you must write the vital sign in the correct place. This is because the color shows you how many points to score. White is 0 points, yellow is 1 point, orange is 2 points, red is 3 points. The maximum news is 20 points. The higher the score, the more unwell the person is likely to be. Carefully add up the scores for each vital sign. If the individual is on oxygen, they score an additional 2 points. Take care when manually adding up the news. Always recheck your work. If possible, check it using a downloadable news app. There are 2 scales for blood oxygen level.
So this is what I'm talking a while ago about the scale 1 and scale 2. Listen carefully.
SpO2 scale 1 is used for most people. This includes people with respiratory conditions such as chronic obstructive pulmonary disease, unless you have been specifically instructed otherwise by a doctor. SpO2 scale 2 is for people with specific lung conditions. Only use this scale if you've been told to do so by a doctor or respiratory nurse specialist.
Okay, again, you will going to use this column, the SpO2, if that is instructed by your doctor, or it could be used by the respiratory therapist. Okay, but commonly the nurses using only the scale 1, this one, the A and B section here. Okay, the SpO2 scale 2 again is used only when there an specific doctor's instruction or used by the respiratory therapist. Or you check the chart. Okay, these dots, maybe the monitoring here is maybe about every 30 minutes or every 1 hour or every 2 hours. So you are recording so that you can track your patient here.
Make sure to cross through the scale that is not being used to avoid mistakes. Depending on your local arrangements, different scores will require you to take different actions to raise your concerns. You must know what is normal for an individual and be able to communicate when someone's news is higher than usual. A person with a score of 3 or 4 can probably be managed in the community by local health services. A score of 5 could mean the person is very ill. The person needs regular monitoring of vital signs whilst an urgent review by a doctor or nurse is arranged. If the score is above 7, the review needs to be very urgent. News supports you to raise a concern, but never ignore your gut feeling. If you feel a person is unwell, always tell your manager or a senior colleague.
Okay, so that is the normal national early warning system. Okay, so now we're going to make an scoring. Okay, the actual scoring, especially if you're going to take the IELTS soon. So here is the actual paper.
From IELTS Medical. Today we're going to talk about the National Early Warning Score 2, or NEWS 2. The NEWS 2 is a trigger system used to establish monitoring frequency in OSCE hospital scenarios. We're going to look at the news charts section by section based on the example from the NMB's Oxford Brookes Exam Centre. At the top of the chart, you can see the patient's full name, date of birth, and date of admission.
Okay, the name, the information of your clients.
You can also see a key at the top, and there are color codes 2 and 3 scores. White for 0, pale yellow for 1, orange for 2, and red for 3. Below this, using the very importance of each column being an observation date, today we're going to record the observations that we've got for our patient. Mr. Sample example. The first part of the column is the date, which we record as day-day/month-month. Underneath that, we've got the time, which we record using the 24-hour format. That way, we don't need to add AM or PM in this tiny box. Now, let's move into the tool itself. Sections A plus B, respiration. Our patient has a respiratory rate of 22 breaths.
For example, 22.
So, there's a dot in the column marked 21 to 24. As you can see, this box is orange and the patient has scored 2 for this parameter. Section A plus B. Oxygen saturations using SpO2 scale 1. For oxygen saturations, our patient has an O2 saturation rate of 90. So there's a dot in the column marked 94 to 95. As you can see, this box is pale yellow and the patient has scored 1 for this parameter. Please note that for the NMC OSCE, you won't use the SpO2 scale 2. Section Air, Oxygen.
Again, before continuation, why do we not use the SpO2 scale 2? Because the SpO2 scale 2 is used only for a specific lung problem under the supervision of your doctors, okay, under the instruction of your doctors, or it's used only by the respiratory therapist, okay? So we will not use that.
Air, oxygen. We need to know if the patient's on oxygen or not. If they are on room air, then we need to add an A to this section. If they are on oxygen, then we add the number of litres of oxygen. Our patient is on room air, so there's an A in this column. This has added 0 to the score. Section C, blood pressure. Now we're going to chart the blood pressure with both the systolic and the diastolic blood pressure readings. Our patient has a systolic blood pressure of 105 and a diastolic blood pressure of 85. So the top arrowhead is in the 101 to 110.
Okay, for the sake of the recording, you will get only the systolic. Okay, that will be the parameters, the systolic. But you will place here the arrow for the systolic and diastolic, but you will get only the systolic pressure for the recording.
And the bottom arrowhead is in the 81 to 90 box. We then join the arrowheads together with a straight or hashed line. Now, sometimes when doing this freehand, your line may be a bit wobbly. What I would recommend is that you use your cue card or any other straight edge to draw a straight line. Please note that even though we chart both, only the systolic top number affects the score. Our systolic blood pressure was 105,
Okay, the systolic
and
only.
this is in a pale yellow box, which adds 1 to our score. Section C, pulse. Let's take a look at the pulse rate. Our patient's pulse rate is 92 beats per minute. So there is a dot in the 91 to 100 box. As you can see, this box is a pale yellow box. Adds 1 to our score. Section D, consciousness. Now, let's consider level of alertness using a scale of A, B, P, U. Here, you'll consider if our patient is alert or if they are only responsive to our voice or pain, or if they are unresponsive. It is likely your OSCE patient will be alert, but you'll be guided by your patient or cue card. Our patient today is alert, so there is a dot in this box. An A is O2. The box is white, so there is 0 effect on the score. Section E, temperature. Our final section is the temperature. Our patient today has a temperature of 37.5. So we've popped a dot in the 37.1 to 38 box. As you can see, this box is white, which adds 0 to the current score. To ensure that our chart is complete, we have to ensure that we fill in all the boxes. News total is, as you know, 5. So there's a 5 in this box. Underneath this, we need to determine what our monitoring frequency will be. In your OSCE exam, you'll be given a sheet attached to your tool with example monitoring frequencies on it. I'll pop that on the screen now. As you can see, for a news total of 5, the monitoring frequency is 1 hourly. This patient's news score is on the high side, so we're going to indicate that we'll escalate care with a Y. Underneath, we're going to add our initials. So, for fictional nurse Sally Edwards, for example, we popped an SE in the box. Now, as I mentioned before, this is an example from the NMC's Oxford Brookes CTC. But there are other accepted versions too, with slightly different variations. For example, numbers instead of dots.
Okay, she said that it may be different from another hospital to other hospital. So other hospital uses number, they are using number, they are not using dot. So it depends on the practice of the hospital, but it's just the same concept. Okay, same concept.
Go into this example as well as further NMC OSCE scenarios during our 3, 4 and 5-day NMC OSCE courses. To find out when the next one will be, head over to www.
All right, so that is the actual paper. Okay, so that is your actual paper. Okay, so I hope you, how many time do I have left, ma'am? Hello?
I'm sorry.
Yes.
Your time, 5 minutes again.
5 minutes only.
Yeah.
Okay. Wait,
Maybe
wait.
you can use 10 minutes. Is it okay?
Okay. Yeah, okay.
Okay,
So if you can see a while ago, after the getting of the score, okay, maybe you want to escalate it or you want to communicate it to your manager, to your supervisor. I know that you know about the SBAR, okay, on how to communicate, okay. So you have to tell them the situation, what is happening now, what is your assessment. Okay, you have to tell them the background, what has happened in the past, that is relevant only. The assessment, what is the problem, the issue in your view, okay, and recommendation, what do you think needs to happen now, what's the receiver want you to do. For example, okay, good morning. Good morning, doctor. This is Nurse Dawn regarding our patient 7317, patient Escanio, okay. The client now is having severe respiratory depression. The oxygen saturation is 95 as 8 a.m. in the morning, and today 10 a.m. the oxygen saturation is 89 only, and the blood pressure is also increasing. I think we have to, my recommendation is to shift from the normal normal face mask. We have to change it into non-facial rebreather mask, and I think you want to see this patient immediately because the patient condition is not improving. Okay, so that's how will you communicate your patient. But again, nurses, before communicating to your doctors, before communicating to your supervisor, make sure that you did something already. Maybe you position your client already. Maybe you check the equipments because maybe the problem is the equipments only, not the patient. So you have to assess everything before you notify your doctor so that when they ask you what is this, what is that, you have the answer already, because remember, time is very important here. Okay, so this is the scoring for the EWS a while ago. When the patient is only 0 to 4, the patient has 0 to 4 a while ago. It's just a low risk, therefore ward-based response, okay, meaning to say it's only monitoring. But if there is a score of 3 in any individual parameter, for example, for the respiration, okay, that is urgent ward-based response. You have to call immediately the attention of your doctors, okay? If it is aggregate, score of 5 or 6, okay, there is a key threshold for urgent response, meaning to say you have to perform immediately. And if it is high, that is emergent, okay? If that score is more than 7, okay, that is emergency. You have to, maybe there is a code blue or something. Okay, so what is the conclusion here? The conclusion here is use and predicting patient at risk for cardiac arrest. Okay, anticipated intensive care unit admission or death within 24 hours. So what is the good here in EWS, when we're using the early warning scoring, we can check the early signs and symptoms of cardiac arrest. Therefore, we can prevent the code blue, or we can prevent the cardiac arrest, or anticipated intensive care unit. Maybe you can observe that this client is really deteriorating, and maybe you want to prepare the intensive care unit for new admission, or maybe you can predict here if the client is dying, if the client is in the process of dying. Okay, the new updated S2 is a supplement and not substitute for clinical assessment. Let me repeat that. The early warning system device is not a supplement or not a change for other assessment. Okay, it's just a it's just a supplement. Sorry, correction. And NEWS2 is just a supplement, meaning to say you can still use the SOPI, the ADPI process, and you can use other papers for assessment. Okay, so it's very crucial for us to develop the critical thinking and the clinical eye in assessment, so that we can have the early detection. When I say early detection, that will cause prevention, and if there is a prevention, there will be early treatment and good prognosis. I think we are done. Let me check for your EWS. Okay, did you learn something today?
So much.
Thank you so much.
I thank so much. We are your presentation is very interesting.
Yeah, thank you.
Okay. Yeah, is it finished your presentation?
Yes, ma'am. I think I'm done.
Oh,
But
okay.
I don't know how to open the Zoom. I can't see you for a while.
Okay. You have a problem with your internet?
No, ma'am. I am looking. I can't see you here for a while.
Oh, okay. But still hear my voice?
Okay, now it's good.
Okay. No, I can see you again, Mr. Donald. Okay, for you, many questions in here. Are you ready?
Yes,
for
ma'am.
a question or Q&A?
Yes, ma'am.
Okay. The first one. How effective is this EWS to prevent deaths? Are there differences in result in different countries?
Can you please repeat the question, ma'am?
Okay. How effective is this EWS to prevent deaths? Are there differences in result in different countries?
Okay, thank you. Yeah, I understand. The question is how effective the EWS to prevent death. Okay, number one, the very easy, the good answer here is it cannot prevent death. Okay, the EWS cannot prevent death scenario, but we can monitor if the client is on the process of dying, meaning to say we can check the signs of dying. Maybe the oxygen saturation is deteriorating, the pulse rate is deteriorating, the blood pressure is deteriorating. Therefore, if you have this early sign, if you have the clue, okay, if you have the clue, you can easily communicate the needed treatment. Hello, doctor. The oxygen saturation of patient is decreasing. The blood pressure is still increasing. What is the management that we can do? Okay, we cannot prevent the death, but at least we can decrease the chance because you have the early assessment. Did you get me? Do you get the point on that? Because you have an early detection, therefore there will be an early treatment. Okay, so there is a good chance to survive the death. Because another question is there a difference from country to another country? Yes, okay. It depends on the institution per institution policy. It depends on the hospital, okay. Maybe I can add another vital signs, or maybe I can modify. It depends on the specialty of the hospital.
Okay, thank you. I think it's your answer is very clear. Now we go next question. Can the news can apply in ICU room or in emergency room?
Okay. ICU room or emergency room? Actually, it depends on the hospital if you want to apply in ICU room or emergency room. But you know what? In emergency room, it's very a short time where the patient will stay. Okay? It's very... can you see me, ma'am? Is there a video of me? Do I have camera?
Camera. Can you stop sharing?
Can you see me?
Yeah.
Okay,
I just hear your voice. Maybe you can stop sharing the PPT and we can see again face to face maybe.
Oh, wait. I don't know how to do it. But can you see me and hear me, ma'am? Can you see me?
Yeah. Yeah.
Okay. Yeah. So the question is where I can use the EWS, in the emergency room or in the ICU room or in the ward. Okay. Remember, in emergency room, the patients only stayed for a very short of time. Sometimes within 1 hour or 2 hours, they will send to ward or they will send to ICU. So the monitor is very a short time. Okay, the purpose of the EWS is to monitor over the time. So if I am the medical director, I am the chief nurse, I will use it that is commonly used in ICU or in the ward because the patient is staying for a very long time. So therefore, they can see, they can monitor it. Okay, unlike in the emergency room, the patient will only stay for how many hours only. Okay, so it's better for the long monitoring inside the ward or the ICU.
Okay. Okay, thank you. Still one again, the question, is it okay?
Yes, sure.
Okay.
Yes, ma'am.
Okay, if we would like to training or to train the nurse or doctor or student, how long we need the time? And the certificate may be expired for how many years?
Oh, I'm so sorry about it for the certificate. I am not really into the information about the expiration of that license, but I think it's not per individual only. Okay, you can have a trainee in your hospital and use it as a guide, but there is no specific licensing. It's not just like an ACLS or BLS. It's not something like that. It's not like the license of ACLS and BLS. It's just a paper, you know. It's just like a SOPA. If you're familiar with the assessment tool, it's just a tool. Okay, you don't need the license to apply it inside your hospital. So you can have your training like this we're doing today. We are having a training and you are familiar, you know the assessment tool already. So you can review now the assessment tool that I present a while ago. You can check in other sources the materials, okay? And then you can modify it, okay, into your hospital if what is the method for easier for you to make an easier version of the EWS, because the paper is not strictly as it is, meaning to say you can modify it, depends on your hospital, depends on the need of the clients. Okay, so you can devise, you can make a new tool guided by the EWS.
Okay. Okay, thank you, Mr. Donald. I think today is Q&A finished, but many question is still here, but we have limited time. Thank
Yeah.
you.
For follow-up question, you can check me on my, wait, there. Where is that? This is my Instagram. Okay. You can follow me there so that we can see each other. Okay, it's flash on your,
Wait a moment, I will take the photo your
yes.
Instagram.
Yeah, so that I can have more followers.
Okay, thank you.
Thank you very much again, once again, for our participants.
Okay.
I hope you learned a lot. I don't know where to see the comments of these students. Where here? The comment chat of the students, the messaging chat. Okay, so if there's no question, thank you very much for inviting me. Hopefully, next time we can have a face-to-face seminar so that we can do the actual paper, we can do the actual making or devising of your EWS, your own EWS. That's better, no? If we can have face-to-face, hopefully, because here in the Philippines, actually the wearing mask is not mandatory anymore, except if you are inside your hospital, and travel restriction is not that very difficult. We're starting also to have a full face-to-face class here in the Philippines. So hopefully we can have a face-to-face seminar in Indonesia soon.
Okay. Okay. Thank you, Mr. Donald, and have a nice day and goodbye.
Thank you. Thank you.
See you next
Goodbye.
time. Bye. Okay. I will read a summary, the subject from Mr. Donald. Early detection warning system device. Content of observation is the meaning assessment from nursing. If not done, is to be a problem for the patient. Because causal recognition intervention and that to be happen. And EWS is to detect abnormal changing the patient, and 6 simple parameter for news: content of respiration, oxygen saturation, blood pressure, consciousness the patient, pulse and temperature, and escalation for report to the another team, maybe doctor.
Ma'am, sorry. Sorry, can you please just give me 1 minute, 1 minute only?
Okay.
Okay. Because I saw it in the comment box. She said, or he said in the comment box, how can we use the EWS in ICU? Because the monitoring there is 5 minutes, 10 minutes, 30 minutes. Nurses, remember, it doesn't mean that in the EWS, it says that the monitoring is every 1 hour, the monitoring is every 30 minutes. Don't forget the word minimum. Okay, when we say minimum observation every 1 hour, it doesn't mean that you have to wait another 1 hour or another 30 minutes before the observation or before the assessment. Okay, it's just mean that it's encouraged, okay, that is the minimum observation only. It's a minimum observation every 1 hour or every 30 minutes. But the full discretion in the assessment is still yours. It depends on the estimate of your, it depends on the situation of your client. So if you think that the assessment needed every 5 minutes, or needed every 30 minutes, needed every 1 hour, it depends on your assessment. It's not a change paper. The EWS will not change the other papers. The EWS is only a supplement. And at the end of the day, we nurses have the power to make an assessment in every time that we want. So don't take the word every 1 hour for the assessment only. It's just a minimum. So it still depends on your clinical eye and your observation, the assessment. So it will not tell you just 1 hour only. So it depends on your discretion. It depends on your assessment. If the client needs every hour, every 30 minutes, every 5 minutes. So if you're very, very good nurse, all on you. Okay? Do not get into the idea of every 1 hour only, every 30 minutes only. It depends on your assessment. Thank you very much, ma'am. Thank you, thank you. I'm saying goodbye because I just read it in the comment box.
Okay.
Thank you.
Okay, welcome. Okay, escalation is to report the doctor or senior nurse, content of situation, background, assessment, and recommendation. Ya, saya rasa kawan-kawan sudah mengetahui sebenarnya bukan hal yang baru tentang EWS atau early warning system ini, karena ini mungkin sudah diterapkan juga di kita ya. Early warning system itu adalah untuk observasi ya. Jika tidak dilakukan dengan baik, berarti kita tidak melakukan assessment dengan baik, maka tidak ada intervensi tentunya ya. Jika terjadi keterlambatan dalam pengkajian, maka akan terjadi keterlambatan dalam intervensi sehingga meningkatkan terjadinya angka kematian ya. Biasanya EWS ini yang dikatakan tadi bahwa dikembangkan oleh The Royal College and UK ya. Kemudian diupdate pada tahun 2017 dan di sana ada 6 simple parameter ya atau 6 vital sign yang dilihat adalah 6. Kalau kita biasanya mengenal 4 atau 5 ya termasuk pain. Tetapi di sini vital sign-nya adalah tentang respirasi, saturasi oksigen, blood pressure, pulse ya, kemudian kesadaran pasien dan temperatur. Itu yang menjadi ukuran dengan 6 vital sign. Saya rasa itu adalah, kalau diteruskan sebenarnya ini sangat menarik, tapi bagaimanapun ada keterbatasan waktu, sehingga kita untuk sesi atau pembicara pertama ini kita akhiri di sini. Dan kita berlanjut and we will continue with another presenter. Hello, Prof. Pratuma. Hello, Prof. Pratuma. Are you there? The second speaker is Prof. Dr.
Good
Pratuma.
morning. I'm sorry.
Good morning. I love your voice.
Thank you
Okay.
so much. I'm sorry.
Okay.
Yeah.
Firstly, I will read your CV for new audience here, Prof. Okay, I will introduce the second speaker, Professor Dr. Ratuma Ripo, from Division of Maternal and Newborn Nursing, Department of Nursing, Faculty of Nursing, Naresuan University, Thailand. Okay, background education from Bachelor of Nursing from Faculty of Nursing, Naresuan, Master and PhD from Faculty of Nursing, Chiang Mai University, Thailand. And she have experience to be staff nurse in patient department, Ramchat Hospital, Thailand, and now to be lecturer, sub-department of adult nursing and sub-department of maternal and newborn nursing, Department of Nursing, Faculty of Nursing, Naresuan University. Field of interest, HIV/AIDS, women's health nursing, maternal and fetal health, sexually transmitted disease, vulnerable population and midwifery nursing. Today, Prof. Pratuma, my apologize.
Pratuma,
Prof.
yes.
Pratuma Ritvo. The topic today is update early warning score or AWS for pregnant women and neonatal and nursing services. Okay, Prof. This is your time. Please.
Okay. Thank you very much. Did you see my PowerPoint? Yeah. Yeah. Oh, sorry.
Still not yet.
Not yet. I'm sorry. Okay. Wait a minute. Okay. Yes. Wait a minute. Okay. What happened? Okay, please wait a minute, my friend. I'm waiting time to visit your country. I really love Indonesia.
Okay, we miss you too.
Yeah. Okay.
And sometime I hope you can visit Unjani.
Yeah.
I hope.
Did you see my PowerPoint? Yeah. Now. Did you see?
Still not yet, Prof.
Really? What problem? Yeah, I'm sorry. At my screen.
And here I see. Is it?
Okay. Thank you very much. Okay. Sorry for this problem. At the present morning to everyone, my name Pratuma Ritvo. Today, my responsibility, I will present maternal and neonatal early warning score update. You know, I know that some people don't familiar about maternal and neonatal in this conference, but maybe you will apply in your organization about this knowledge. Personally, maybe many people pass away from MMR cause. Our country, yes, we are green and yellow. Indonesia need to improve quality of services for pregnant women and maternal and newborn. I understand your country, you have 10,000 islands, and you are the big country, and you have many islands. That's why maybe you need to improve quality of services. This slide presents infant mortality rate in our country also. You have done the wonderful job. Okay, the green color. Many 3/4 of all newborn deaths occur in the last week of life. In developing countries as Indonesia and Thailand, nearly half of the mother and newborn do not receive skilled care during and immediately after birth. Up to 2/3 of newborn deaths can be prevented if no effective health and measurable provided at the birth and during of the first week of life. About the MMR rate in around the world also, the deaths, the cause of death can prevent. That's why today we should know about the instrument that can evaluate and prevent maternal pass away. This is the birth attendance by skilled health personnel. You are the right green. In Thailand, we are the green. That's why in Thailand, more than 60% of pregnant women give birth in the hospital. That's why we have the green color, and we need more to improve quality of care for pregnant women also. Hemorrhage is the leading worldwide cause of maternal death. This slide presents the cause of maternal death. The big five causes of direct obstetric death include hemorrhage, infection, hypertensive disorder, obstructive labor, and unsafe include abortion. I think early warning sign can evaluate and can prevent some situation, some cause in this slide also. We know that obstetric cause that's pregnant mother pass away, such as hemorrhage, PIS, peripartum cardiomyopathy, anesthesia complication, and AFE. Non-obstetric cause such as myocardial infarction, cardiac arrest, stroke, septic, and pulmonary trauma. We can use early warning score to prevent. This is that all of global cause of maternal death and select key intervention. We have many key intervention to reduce MMR rate, and early warning sign is one instrument that we can evaluate and to protect them to getting serious condition. About evidence intervention to reduce newborn deaths, we know that warming resuscitate skill and birth attendance is the activity that reduce birth asphyxia pathway, and we can use a newborn early warning sign to detect the initial phase of this condition. According to my review literature, I summarize the common barrier to deliver quality, essential obstetric and newborn care. What the proportion and maternal death that we are weak local leadership, lack of formal standard, and maybe sometimes we have problem about inaccessible services, financial and geographic and culturally. And we are inadequate input and infrastructure. That's some area you could not conduct the hospital or the services for maternal and newborn. And normally we are poorly organized patient care process. That's why we can apply early warning sign in this process also. And we are non-functioning referral counter referral mechanism. That's yesterday we already talked about this. This topic, and early warning sign is in the wonderful intervention that you can evaluate patient before you refer them. And we are inadequate supervision, lack of continued training, and poor staff motivation and poor provider competence. That's maybe sometimes we don't have enough high performance of RN or healthcare staff to take care maternal and newborn. Maternal code blue. Code blue is that someone is experiencing a life-threatening medical emergency. Usually this means cardiac arrest or respiratory arrest. One of the diagnostic maternal code blue is made is an unresponsive pregnant women. Acute intervention with CPR and BLS can help maintain maternal circulation while preparing to perform a potentially life-saving by perimortem. That's why you should have knowledge and experience of early warning sign before you go to enhance your ability of maternal resuscitation. Before you resuscitate, you should know, you should evaluate them well. Early warning sign is urgent need for the routine of National Obstetric Early Warning Chart, similar to those in use to other area of critical practice, which can be used for all obstetric women, which will help in the more timely recognition, treatment, and referral of women who have and developing a critical illness. This is the new guideline for maternal arrest guideline that we already talked about in the last web seminar on August. This is neonatal resuscitation. Before you apply the neonatal resuscitation, you also evaluate early warning sign. That's why you should conduct early warning system. It has been proposed to facilitate timely recognition, diagnosis, and treatment for women and newborn developing critical illness. A multidisciplinary working group convened by the National Partnership for Maternal Safety used a consensus-based approach to define the maternal early warning criteria and neonatal early warning sign, a list of abnormal parameters that you should apply in your organization. I know that maybe sometimes you could not take care of pregnant women or something like that. You can share the idea. We know that early warning signs have been used in a clinical practice long time in non-obstetric patient population. This common involve triggering system based on physiology parameter, where one or more value trigger a response. Sometimes an active scoring system is used where physiological parameters are assigned a value and the total score determine the response. A national early warning score, or we call NEA, NEWS, NEWS, was introduced in UK since 2012, and then it was developed again in 2017. The national system standard can and critical management simplify communication, and it is important for research validation. When consider the effective of early warning sign is sensitive and specific are important. That's why you can apply, and you know well about the score of news. I think you can search more such as a score of 0, 1, 2, and 3. I talked about this news before obstetric early warning sign because you the instrument in maternal and newborn apply for news also. And you can evaluate low risk, high risk, and low to medium and medium risk, high risk of news. If a score more than 7 or over, emergency access by critical care team usually leading to patient transfer to higher dependency care area. Okay. In about maternal and child, we have variants of obstetric early warning sign. You can maybe you can, if you work in maternal and child area, maybe you familiar maternal early warning score or MIL and modify early obstetric warning system male and I'm sorry, the maternal early warning trigger 2 and IRIS maternal early warning system and obstetric early warning score OEWS. That's why maybe it had more than this early warning sign that I show you, but the original is the MIL that's developed from news of non-obstetric population. Today I will show you about the updates instrument early warning sign of MIL and male. Okay. For the purpose of this presentation, why we should know about early warning sign? Because it's simple and quick to use tool based on routine physiological observation, and you can observe the parameter, the abnormal parameter that's mentioned in early warning sign. The score of those observations can provide an indication of the overall status of the patient condition. Prompt action and urgent medication review when indicators allow for appropriate management of women at risk of deterioration. This policy therefore apply to all pregnant, labor and parturient women. Delay in diagnosis contribute to a large portion of preventable maternal deaths. And you should that you should early warning system have 3 components: early warning score, prompt reporting, and bedside evaluation. About prompt report to physician and author qualified clinician. If you use instrument, you can report and to immediately. And prompt bedside evaluations by a physician and author qualified clinician with the ability to activate resource in order to initiate emergency diagnostic and therapeutic intervention as needed. And you can plan for implement the diagnosis workup and code follow up the senior provider of patient status until abnormality resolves. Parameters such to be a begin ethnography and patient is determined to be potentially critical ill and care is escalated that rapid response and high actual setting is referred to the yesterday that if you evaluate well, you can rapid escalation and good refer. This is the maternal early warning score MIL. It have a parameter that this is the old version that you can evaluate. That's white, yellow, alert, red line in a 6 and to 7 of parameter, physiological parameter. Due to MIL score is a normal physiological change of pregnancy. The early warning score for the non-obstetric population is not direct. That's why we evaluate to MIL score and we apply to develop MIL score. It's what designed to account for normal physiological change of pregnancy. The initial intention of MILs is to improve the condition of pregnant women at risk of clinical deterioration and facilitate early intervention. Trigger in the MIL system theoretically lead to earlier recognition of conditions that can contribute to maternal morbidity and mortality, includes the cause that I already told you, sepsis, cardiovascular disease, and this MIL scores the Center of Maternal and Child Inquiry report in 2011 recommend the introduction of MIL to all maternity in the United Kingdom. You should know that early warning sign developed from United Kingdom. It is to have also be recommended by the Association of Anesthetic and Great Britain and Ireland to apply. It's good. And it had a new version, but some research they apply MIL score from English to enhance quality of maternal care. This is one of example that maternal early warning score developed of Nigeria National Maternal Early Warning Score that in Nigeria they apply MIL and they evaluate the quality of MIL in their country, and they know that the quality of MIL can enhance quality of recognition and escalation of acute deterioration of obstetric condition in their country. In your country, maybe sometime I'm not sure about the early warning sign in a maternity unit, but in Thailand some hospital apply, but it's not true 100%. This is obstetric early warning escalation protocol in the old version. If you complete a full set of MILs observation, if you get one yellow alert, repeat observation in 30 minutes. If you get 2 yellow alert or 1 red alert, call the obstetrician and repeat observation in 30 minutes. And you get more than 2 yellow alert and more than or equal to red alert, immediate review by obstetrician and repeat observation in 15 minutes or continue monitors. This is the old version. I will show the news updates later. In 2018, about anesthetic tutorial of this week about this organization, They also apply Mew score, but it not change too much. It not change in 2018. The key point of this organization apply Mew score in Ireland because the key point is physiology commonly deteriorates progressive in clinical ill obstetric patient. Identify abnormal physiological parameter and early intervention may prevent future deterioration and reduce maternal morbidity and mortality. Obstetric warning score may help identify pregnant women at risk of deterioration. And Mews is a common use example of bedside screening tool that enable tracking of physiological parameter and when a predefined threshold is reached, trigger bedside assessments by healthcare professional. The anesthesia apply this organization in apply this instrument in organization that the trigger and escalation is did not change about Mews in that year. And maternal and morbidity and mortality report have found that clinical response to acute physiological deterioration in pregnant women is at time delay, and this is associated with poor outcome or something like that. They also apply Mew score, but this is the new version of Mew score in Scotland. They apply Mew score at the first version, but they change a little bit about escalation protocol. And I will show this Mew score conducted in 2021. The National Mew and Escalation Press should replace local charts. It will provide a standardized system across Scotland for recording routine clinical observation in hospital care. The physiological parameter of chart have been tested in clinical situation and must not be modified. All women who enter an acute hospital setting should have their observation record on Mew chart. This includes but not exclusive. You can apply, and the frequency of observation should be consistent with the clinical situation and individual history of the women. The frequency of observation must be considered and modified according to change in the clinical condition. This should be recommended in the ongoing plan to back up the Mew score. From this version, what can a maternal early warning score do? The trigger on is on do those things. However, if used by staff to initiate escalation, this can lead to earlier recognition of sick, deteriorate women during pregnancy can up to 42 day postpartum. You can apply early warning Mew score until 6 weeks of postpartum period. Mew chart part of bigger system improve situational awareness with T question. What is the current situation? What is our current understanding of situation, and what could happen in the near future? That they believe that Mew is a multi-professional approach to standards care, consistency of practice, the improvement of clinical outcome, and the safety of pregnant and postpartum women. Clinical illness in pregnancy may differ in presentation to non-pregnant situation. Therefore, it is important to use a chart specifically designed for maternal physiology. The trigger system has been shown to reduce morbidity and admission to adult critical care units also. The key recommendation of Mew that national and escalation process should replace local chart. It will provide a standard system across Scotland for recording routine clinical observation in hospital care. The physiological parameter and chart have been tested in clinical situation and must be modified. All women who enter an acute hospital setting should have their observation record on Mew chart. This includes, but in not exclusive that I already told you. And another key recommend that the only exception to use during part-time periods where observation will recorded on pathogram unless local policy start otherwise. In part-time period, we use pathogram. If your country would like to apply a revenue score, you will set policy, and it is the frequency. Okay. About this version in 2021, the total yellow and red score that data evaluates. Article should be add up and document at the bottom of the mule each time observation and are recorded. If the women score any yellow or red score, the escalation guideline should be initiated. If a family member is raising concern, consider escalating care regarding article. And if concern is about women escalation regarding article will apply. About escalation, there are identified article combinations which when reached, then activate the escalation pathway. The escalation pathway outline action required for timely review for each combination of trigger. This can be found next to the mule chat. Escalation is the responsibility of midwife staff to follow the escalation flow chart. It is the responsibility of the medical team to follow the escalation plan review within the appropriate time frame and inform senior staff if appropriate. This is a new escalation of mule score in 2020. If you get one yellow, repeat full set of observation in 30 minutes, and if remain one yellow escalation per local policy, you can set the policy is organization, document action plan and mule score frequency. If you get the pregnant women on maternity get to yellow, inform midwife in charge and obstetrician. If no response from obstetrician within 15 minutes, escalate to middle grade obstetrician and repeat full set of observation within 30 minutes. Document action plan for mule score frequency. And you get late, one late or clinical concern, inform midwife in charge, and it is the same. And then you repeat set observation in 15 minutes and 30 minutes. And if no medical review after further 15 minutes, call senior obstetrician or anesthesia. This is the deal. And it is if you anytime more than one rate and rapid deterioration of maternal condition, if you use early warning score, this is the blue code that you call midwife in charge and repeat full set observation in 5 to 15 minutes. If no medical review within 15 minutes, repeat senior obstetrician or anesthesia review, consult SDU, and maybe you call emergency. And you set emergency number by yourself in your area and document medical plan for mule score frequency. Consideration of maternal in this protocol, in the critical guideline, concern about maternal sepsis also. If you study more in this guideline, it will show you about taking and trigger tools such as mule aid and the diagnosis and management of the acute deteriorating women with sepsis. The bottom of escalation guide outline the systemic inflammation response syndrome or SIRS criteria that are aggressive of sepsis. This is mule trigger that it can help to predict sepsis, and you can give 3, take 2, and monitor 1. It include in protocol also. You can see the temperature and see interpartum women had an EVS white cells count and temperature in labor without having sepsis. About and when you escalation or something like that, you should apply SBAR situation background assessment recommendation. SBAR is an easy to use structure from communication that enable inform to transfer accurately between individuals. The use of SBAR provide clarity to communication and prevent the unreliable process, hint and hope that the other person understand. All maternity units should have effective communication system in place to ensure that there is minimal delay between the triggering of a call for a review and the arrival of medical staff. Yeah. I finished MuleScore, the update of MuleScore, and then the another early warning file of maternity we call modify early obstetric warning score, or MEOW or something like that. Some people call it. Have a you can study more, and you can and many style of modify early of MEOW score that you will use. This is the old version that in the past that they apply in a organization. And modify early warning score that they give in the new score. It change a little bit about the oxygen saturation. You see, it is less than 92 to 95, and it is more than 95. The score in the past. This is the old version. Okay, I will show. About MuleScore, when you evaluate score, it has score 2. Repeat 12 hours for all patient and community assessment for non-scheduled contact score to 0, and no checklist factor indication. Repeat not necessary exercise professional judgment and documentation. About the score 1 or 2, refer to qualified registered professional and midwife device plan and document when to repeat, such as 1 hour or 4 hours, 12 hours up to the condition. Continue with at least 12 hour observation. The score T refer to qualified registered professional to recheck observation. Increase frequency of observation to 4 hours. Consider need to increase frequency and observation to interval of at least 4 hours. Maybe sometime our routine it have done the wonderful job, such as we monitor women every 4 hours. If they get score 2 or 1 or something like that, we observe frequency more than the MuleScore recommendation. The score T within 1 parameter, any observation, you check oxygen saturation or mission. This criteria have many and refer to qualified setting and to recheck observation. Observe frequency increase at least 1 hour. Comments through it balance monitor and midwife inform medical staff to monitor and pay attention of them. About the 4 to 5 score, this is very detailed. If score 6 or more, check oxygen. This is the red color. You should pay attention more. Check oxygen saturation and administer oxygen at appropriate. Immediate transfer to delivery suits, inform delivery suit coordination, and many activity that you should apply. This is the new version. It changed a little bit of MuleScore. It's from the Joint Task Guideline for the use of the meals in detecting the serious illness and deterioration women by NSS Foundation. If you study more, it modified in 2022 this year by Norfolk Norwich University Hospital and the Queen Elizabeth Hospital King in England. The meal score had been designed to allow early recognition of physical deterioration in fertility women by monitor their physiological parameter. A score more than two trigger the use call. We didn't get a zero score. We call out cascade, CASCADE. Give specific instruction regarding level of monitor, referral for SY review and immediate action to be considered. Objective, this is to provide guidance for staff within the maternity services on recognition and monitoring the obstetric patient use meal score chart. The aim of this enable early recognition to deterioration as well on the level of monitoring require facilitate better communication within the multidisciplinary team and ensure prompt management of any women who condition deteriorating. This version modify every 2 years. This instrument from this early meal score from this organization modified in 2022. It changed about oxygen saturation cut-off level. This is this if you get the oxygen saturation less than 65%, you will get 3 score. This is change a little bit. Can you know that the calculation of the meal score we check temperatures, systolic, diastolic, heart rate, respiratory, and oxygen saturation. In the community, this is not always possible, so a score can be calculated in this situation without them. If they are concerned about patient condition, either clinical or scoring on meal, they can be referred in. Yesterday, some people asked me about how to evaluate or how to monitor pregnant women in the community. You can apply this instrument in community also. And maybe this you can check, you cannot check oxygen saturation, maybe you can refer check and you can get the score of meal score. And then the meal score level of consciousness using AVPU scale and urine and unresponsive. This is meal score escalation or something like that. Modify early obstetric warning call out escalate. If you guess the score 1, 2, 3, inform register midwife what RM must review patient and if any immediate critical concern medical review. If no immediate critical concern, repeat observation in 30 minutes and 60 minutes to 60 minutes. Meal remain 1, 2, 3 after repeat observation 30 minutes request the one doctor to review within 30 minutes. If you get 1, 2, 3 score, you should pay more attention and you ask more intervention to reduce the serious condition. If meal score more than 4 or something like that, you think about safe seat and you can inform what to coordinator RN what to and review patient and require trial one doctor to review within 30 minutes and you comment 1 hour observation and observe urinalysis and comment fetal monitoring if antenatal patient. And about meal score more than 6, think about safe seat, inform what and coordinator, register nurse, RM, and contact maybe many activity. If patient deteriorate further or fail to respond to treatment, think about safe seat and delay sick and you can call emergency and something. This is the new meal score that The process for use Mew score every time a set of observation is performed and anti or postnatal women, Mew should be calculated and record in the handheld record or on the observation chart as applicable. All women presenting to triad who are having baseline observation carried out should have Mews calculated and documented. Women is active labor do not require regular Mew score. All obstetric inpatient must have full set of observation and a Mew score calculated at every transfer to a new area. Yes, you can this document present that they refer to balcony ward. The Mew chart used is one area should be transferred with the patient to the next area in order to help identify change in trend to observation. If you are concerned about women condition, a Mew should be attributed if you are still concerned regarding of the music as well. Yeah. Mew score, this new version you can apply to all area. Antenatal care, delivery suit or LR, recovery, postnatal and community, such as antenatal care unit. You can frequency of observation will depend on the nature of the admission or as indicated by the list clinician. At a minimum, a full set of observation should be carried out twice a day, at least 12 hours apart. Mew score should be attributed to each of these set of observation. In my hospital that I train my students, they apply Mew score at the antenatal care unit also. In the community, yesterday, yes, someone asked me, yes, a Mew score should be attributed to every set of postnatal observation and document in the maternal record. Oxygen saturation are not included in a Mew score in the community. If there are clinical concerns that you can evaluate. If Mew score 1, 2, 3, observation should be repeated within 30 minutes. If score remain more than 0, the midwife should concern delivery suit and depend on the likely cause. If Mew score more than or equal 4 or 3 in any single parameter, the midwife does not need to wait for repeat Mew score before contact the hospital. Regarding of Mews, if you are concerned about women condition, do not hesitate to seek advice. That's why you can apply in community. If you get something 1 score or something like that, you must notify as one setting. Manage of patient and response to Mew score. The call out case set out the action to taken in response to individual Mew score. This should be followed to ensure the appropriate clinician are called and appropriate management and care in undertaken. All action taken must be clearly documented in the handed record along with the plan of care.
My apologies, Prof. Your time left 5 minutes.
Okay. This is the neonatal early warning sign. Okay, this is the new the asleep newborn infant. Yes, we know that if you give birth with thick meconium or something like that, you must pay attention and apply and use early warning sign to evaluate. Yeah. And about the respiratory of heart and about the parameter of heart rate and respiratory rate, maybe they are different from every many organization, and you can sum up newborn early warning observation. This is some example of neonatal early warning sign. This is from NHS newborn early warning system observational chart. And this is from this organization. And I show the news, the new of early warning score in newborn from Auckland district. Yet in 2021, that's for you can study more and you can apply. It's implemented in infant, especially was born in preterm, baby risk factor and sepsis. Any gestational and they are low birth weight and maybe macrosomia. You can it's very useful to in this instrument, in this protocol, in this document, they show about newborn observational chart and newborn early warning score that you can apply and you study. This is newborn early warning sign from Auckland that have white, yellow, and maybe pink. This you can observe and plot temperature and plot the parameter, and then you can evaluate. Yes. The core vital sign 6+1 include in the newborn observation chart for all baby. And additional observation for asleep baby include oxygen saturation, blood glucose, and lipid lactase, and newborn scarf shape. About the escalation pathway for news at Auckland City Hospital. One lipid in one, if you get one lipid in 1 hour, if unchanged, notify person in charge, such as CCM chief coordinator, and let's say 1A, let's say feeding and per feeding, and you get, if you get 3 or plus, require immediate neonatal team review. This is neonatal course book. That is very, I think it's very useful of instrument also. This is the about the calculation and midnight will undertake and document at 2 hours. In this instrument, they apply instrument to newborn every many period that you can apply. This chart also you can apply this instrument to evaluate and monitor. And this is the some example of news in resource limited and humanitarian setting. They are review literature, and then they summarize the news score, and the conclusion that news score can help them to reduce and can enhance reduce the negative condition, and it enhance quality of care. You can study. And this is in Arab Emirates also. They modify about the news early warning system in this country. You can yes, you can apply. This is yes, many countries try to apply news in newborn in the hospital. The reason not have that's why they would like to increase quality of care, and they can support quality insurance also. This is called in Arab Emirates. That's maybe you can modify in. Yeah, this is 3 color: green, light color, yellow, amber, and red color. Okay, thank you very much. I'm sorry. Okay.
Okay, I think it's sub time. Thank you, Prof. I think it's great presentation. Okay, I will make a little bit summaries about AWS for maternal. AWS developed every time by many countries and many hospitals in the world. Variation of obstetric AWS, content of MEWS, MEOWS, and OEWS. MEWS, the parameter are respiratory rate, saturation of oxygen, temperature, systolic and diastolic blood pressure, and heart rate. There are many for measure. It's like normal value to determine the patient in area yellow on area red. And the escalation is to responsibility by midwifery staff. And here, consideration to obstetric emergency, it's like 1 rate or depend on clinical situation, or more than 1 rate or rapid deterioration of maternity condition. And the second consideration, maternity sepsis depend on temperature, depend on heart rate more than 100, respirasi, white blood count, and I'm sorry, it's not clear. And MEOWS assessment tool have score between 0 until 3. It's a little bit different with MAWS. MAOWS contain respiratory rate, oxygen, temperature, systolic and diastolic blood pressure, and consciousness, heart rate, and urine output. I think it's my summary from the subject of Prof. Ratuma. Jadi kalau dilihat di sini, ini adalah AWS atau alat ukur untuk orang-orang dengan orang hamil atau ibu hamil, ya. Saya rasa di sini sudah dikembangkan oleh banyak hospital, mungkin dari Ireland, dari Swedish, ya, dari Ireland. Kemudian bisa dikembangkan dalam MEWS atau maternal early warning system, ada MOWS, AWS, and OEWS. Dan pengukurannya itu yang diukur antara lain parameternya itu adalah respirasi, kemudian saturasi oksigen, suhu, sistolik dan diastolik untuk tekanan darah dan heart rate, ya. Di sini ada untuk melihat apakah pasien itu keadaannya baik atau tidak, meskipun di sana dituliskan ada normal value, ini sebagai tolok ukurnya, yaitu di sana ada yellow and red alert, ya. Kemudian untuk eskalasinya ini adalah tanggung jawab daripada midwifery staff untuk melaporkan ke yang lebih senior atau dilaporkan ke dokter, ya. Ini dipertimbangkan kalau ada obstetric emergency itu ada satu merah atau bergantung kepada kondisi kliniknya, atau lebih dari satu merah, tetapi di sana ada satu gangguan pada ibu hamil atau maternal. Kemudian diperkirakan ibu hamil ini mengalami sepsis kalau di sana tekanan temperaturnya lebih dari 38 derajat Celcius, heart rate-nya lebih dari 100, respirasinya lebih dari 30, ke sel darah putihnya kurang dari 4, ya. Kemudian kelihatannya ibunya terlihat tidak baik atau tidak sehat, ya. Kemudian bedanya dengan yang sudah dikembangkan menjadi MEOWS atau MEOWS, ini assessment tool ini mempunyai skor 0 sampai 3. Sedikit perbedaan, di sini ada yang diukur adalah urine output, ya. Saya rasa itu ringkasan dari materi Prof. Paratuma. We will continue to Q&A, Prof. Many questions here for you. Okay.
Every time.
Okay. The first question is, who is authorized to observe or fill in this MEOWS, whether the room nurse or the midwife? And is this MEOWS done for neonatal too?
Okay, the first question. You can
Yes.
evaluate RN, who cross with who support maternal. You can use early warning sign.
Okay. Who is the responsible, nurse or midwifery?
Both.
Both.
Yeah.
Okay.
Yeah, you can
Thank you.
Yes. Yeah.
Okay. The second question is, MAWS be implemented in the delivery room, maternity ward, or birth room?
Again, meals.
Okay.
Yes. But MEOWS recommend many setting. And about meal, you can apply or setting also that have maternal and maternal. Yes.
Okay.
Yeah.
The third question.
Yeah.
How is the division of performance between nurses, midwives, and doctors in handling maternal and neonatal emergencies? What is the authority of male nurses in handling maternal and neonatal in emergencies?
About male nurse responsibility. Yeah, you can apply. You can I don't know about your culture, the male nurse, but the male nurse can apply meal score, and new in emergency or everything like female nurse. Yeah, you can use in the USA or UK, male nurse and female nurse are similar and responsibility. But I'm not sure in your cultural, but you can apply. The male nurse can apply as well.
Okay.
You know, some in Thailand, some Thai professor, Thai nursing instructor who teach in LR, they are male nurse, male. They are males. Yeah. Yeah.
Okay.
Yeah.
Next question, Prof. Can the MEWS tool be used in all maternal conditions such as intranatal hemorrhage and eclampsia? Is it possible?
Yeah, you can use meal score because it's a 6 parameter, at least 6 parameter. Heart rate, systolic, diastolic, and pulse pressure and oxygen stats. You can apply every condition, yeah, and you can evaluate by meal or male score. Yeah.
Okay. And the next question.
Okay, maybe 20 questions. Okay.
Because your subject or your topic is good, so many questions for you here, but we have limited time. I think it's one question.
Okay.
Only.
Maybe you send email to ask me.
Okay.
Okay.
When did MEWS switch to AWS? Is it after the puerperium or after the patient is postpartum or post-section cesarean?
What do you meal score and meal
switch
score
to AWS?
Yeah, MEWS. Okay.
Yeah. When did MEWS switch to EWS? Is it after the puerperium or after the patient is postpartum or post-section cesarean? Caesar. After Caesar.
Yes. We apply meal score in postpartum period and after the delivery also because I already told you that we have parameter include the condition and vital sign in postpartum and post-cesarean section. After about the anesthesia organization that I already show you, they already apply mu score when they conduct cesarean section in labor room also. That's why you can apply mu score, but the modified meals is maybe is you can apply both mu and MEOWS. Yeah,
Okay,
you know,
okay,
in the
okay.
case between, I already show you about some document. Anesthetician organization, they apply mu score when they take care. Yeah, when they take care of patient and pregnant women. Yeah, that's why. You can
Okay.
apply. Yeah.
Thank you, Prof. I think the time is end, and thank you for your attention here. Very appreciate it is, and have a nice day, Prof. And goodbye.
Thank you very much, and I really appreciate your organization that you conduct wonderful conference for Indonesian people and other peoples. Yes, thank you very much, and see you next time. And thank you very much, I-In also. Bye bye. สวัสดีค่ะ
Bye. Swadika.
Yeah, สวัสดี
Okay, and now we will continue with presentation, video presentation from a student master student with name Yani Setiasih. The topic is difficult IV access score. It's for neonatal. Okay, Pak Yus, please. It's time for you.
Hello, everyone. Today I would like to presentation regarding DIFA score or difficult intravenous access. Neonatal period is a critical period. Adaptation to the environment. Neonates admitted to special care rooms have a need for frequent invasive procedure. Invasive procedure, insertion of a peripheral venous catheter is one of the standard services in the neonatal care room. According to data from the National Healthcare Safety Network, complications, especially infection from intravenous access, occur in neonates. Prevention of the many factors that cause complication in intravenous insertion is a key step in the development of prevention strategies. Difficult and failure of IV access insertion, that is clinician prediction are needed or predictor are developed to help identify the risk of difficult intravenous access. Difficult intravenous access is used as a guideline to determine the success rate of intravenous access. Several studies using the DIFA score were generally conducted in adult and pediatric patients. There are no specific study with neonate research subject. Difficult intravenous access, the condition of catheter insertion when the catheter cannot be inserted into the vein in one attempt. Difficult intravenous access is a tool used to predict the difficulty in inserting a peripheral intravenous catheter. Yan et al. In the tables, we can see about DIFA score. From the predictor measure, it means that subject with DIFA score of 4 or more have a more than 15% chance of failing to insertion a peripheral intravena catheter on the first try attempt. Typical intravenous access, DIVA-3 saw similar result, but is more recommended to be used after the failure of the first insertion using the previous 4 variables. By Ricker et al., intravenous access is successful if it meets the following criteria. There is a blood return after intravenous needle puncture. 2, after the intravenous access was fixed and the infusion rate was adjusted accurately, 100 milliliter of intravenous fluid was successfully injected with evidence of extravasation in adult, but in a neonate, not yet. Literature review research result by Giroto et al. External validation of DIVA and DIVA-3 clinical predictive rules of identify typical intravenous access in pediatric patients. Result is patient with DIVA and DIVA-3 more for nurses prediction of greater difficulty in IV placement and moderate after severe dehydration were common independent predictor of difficult IV at multivariate analysis. The study externally validated DIVA and DIVA-3 showed the same accuracy. Schools et al. Difficult peripheral venous access in children, an international survey and critical appraisal of assessment tool and escalation pathway. Resources for the identification and escalation of children with DIVA are not standardized on consistently used. Further work is needed to streamline processes for DIVA identification and escalation to the appropriate clinician with technology-assisted insertion capability. This will exchange patient experiences and reduce harm from multiple insertion attempts. And then Sokat et al. With utility of the DIVA score for experienced emergency department technician. Result is in patient with score more for emergency department technician with more 5 years of experience were significantly more likely to be successful on the first attempt. From patient with high DIVA score, more 4 years of IV experience was associated with higher odds of successful first-time IV placement and shorter time to placement.
Research design. The type of research used is an analytic survey research with a cross-sectional research design. Cross-sectional study is a study to compare the success rate of peripheral infusion in one step at neonates performed by clinical nurse 2 and clinical nurse 3. Measurement of variable is done once at the same time. This research will be conducted at Hasan Sadikin Hospital, Bandung, West Java. Thank you.
Okay, we will continue with third speaker. Ibu Fauziah Rudiati. Ibu Rudiati. The topic today for her is evidence base of critical nursing in pediatric. Ibu Fauziah is a nursing lecturer and master student and she graduated from University of Indonesia with a specialized in children. Okay, Bu Fauzia, are you ready? Are you ready, Bu?
Yes, I'm ready.
I'm sorry, your voice is not clear.
It's clear enough?
It's okay.
Okay.
Okay, now it's your stage, please.
Okay. Thank you, Ms. Mercy, for the opportunity. I'm very happy to meet the participants who are very proud, even though it's only through online. Today, I will review related disease conditions that are up to date in our country lately, but I will explain with bahasa Bu Musri.
It's okay.
Okay. Because my English is I don't know if I explain about with English. I afraid I cannot explain clearly. Let me share the. Sudah jelas ya, Bu Musri?
Clear, Ibu.
Ya. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Hari ini saya akan mereview sedikit terkait kasus gagal ginjal akut misterius ya mungkin yang memang akhir-akhir ini sangat kejadiannya cukup banyak dan angka kematiannya itu sudah mencapai 48% yang sedang dialami oleh anak-anak Indonesia. Meskipun memang tidak seluruh daerah di Indonesia itu mengalami kejadian akut kidney injury ini ya, tetapi dengan angka kejadian 48% yang angka kematian yang 48% ini cukup sangat mengkhawatirkan dan perlu banyak edukasi bagi masyarakat kita untuk mengetahui tanda-tanda dan tanda-tanda gejalanya berikut pencegahannya. Nah ini kita sudah mulai ya kemarin di akhir Oktober gitu ya mendengarkan berita-berita terkait bagaimana insiden cedera pada ginjal yang misterius gitu ya, yang hampir menewaskan 133 anak di Indonesia. Dan sebetulnya kejadian ini sudah mulai terjadi di Indonesia itu di awal Januari tahun 2022. Akan tetapi peningkatan kejadiannya itu cukup meningkat tajam di 2 bulan terakhir ini ya. Nah, jadi kalau di awal Oktober mungkin ya di pertengahan Oktober itu di report ada 70-an anak gitu ya. Nah, di tanggal 21 Oktober Kementerian Kesehatan itu merilis data bahwa telah terjadi 241 kasus gagal ginjal akut secara misterius gitu ya, dan menewaskan hampir 133 anak. Dan itu rata-rata terjadi pada anak-anak di bawah usia 6 tahun gitu ya. Nah, jadi kita akan mereview lagi nih ya, kita harus memahami dengan baik gitu ya terkait apa sih gagal ginjal akut pada anak itu ya. Nah, dimulai dari definisi dari ginjal tersebut. Jadi apa sih ginjal itu gitu ya, organ ginjal itu? Jadi ginjal itu adalah sebuah organ gitu ya yang berbentuk seperti kacang gitu ya, dan dia memiliki 2 buah ya, jadi ada sepasang gitu ya organnya, dan berada di area abdomen gitu ya. Dan masing-masing masing-masing ginjal itu ukurannya adalah sebesar 4-5 incis panjangnya, dan kalau misalnya diperkirakan itu besarnya seperti 1 kepal tangan ya. Dan fungsi ginjal itu apa sih gitu ya?
kenapa bisa sampai menyebabkan begitu banyak kematian ketika terjadi pada anak-anak. Yang pertama, ada 3 fungsi dari ginjal itu. Yang pertama adalah ekskresi, ya, di mana fungsi ginjal ini adalah untuk mengekspresikan sisa-sisa metabolisme yang akan menjadi racun bagi tubuh kita, ya, seperti urea, kreatinin, ya, urik asid, kemudian bilirubin dan lain sebagainya. Nah, di mana ketika fungsi ekskresi ini terganggu, gitu ya, maka di dalam tubuh kita itu akan terjadi peningkatan sampah-sampah gitu yang akan meracuni diri kita sendiri. Gitu. Contohnya, kalau misalnya terjadi peningkatan bilirubin yang tidak dapat diekspresikan, maka hal ini akan menyebabkan ancaman terhadap fungsi otak kita, gitu ya, di mana terjadi chronic icteric. Nah, kemudian fungsi yang kedua dari ginjal sendiri adalah untuk kontrol, di mana fungsi kontrol ini adalah untuk menyeimbangkan cairan dan elektrolit, kemudian menyeimbangkan pH pada darah, serta untuk menyeimbangkan tekanan darah, ya. Nah, kemudian untuk fungsi yang ketiga adalah untuk sebagai foaming atau pembentukan, ya. Nah, di sini ada kalsitriol, di mana kalsitriol ini adalah suatu zat yang berasal dari vitamin D, dan ini sangat berguna untuk metabolisme kalsium dan fosfat, gitu. Jadi bukan hanya sisi ekspresi saja ternyata, ya, ginjal itu, tetapi dia juga memiliki fungsi untuk mempertahankan keseimbangan atau homeostasis di dalam tubuh kita. Kemudian, nah, berdasarkan Sethi, Buchman, dan Chakraborty tahun 2021, gitu ya, di sini ada sebuah penelitian yang meneliti terkait kejadian acute kidney injury pada anak itu di rumah sakit, gitu ya, atau di pelayanan kesehatan. Ternyata AKI itu mempengaruhi hampir sepertiga dari anak-anak, baik itu yang menderita penyakit kritis maupun non kritis, ya. Dan ini terjadi pada sekitar 30% anak-anak yang dirawat di pediatric intensive care unit. Nah, kejadian AKI ini sangat berhubungan, ya, dengan kejadian morbiditas dan mortalitas, ya. Nah, setelah beberapa faktor resiko yang bisa menyebabkan morbiditas dan mortalitas itu disingkirkan, gitu ya. Nah, kemudian AKI ini juga memiliki kemampuan untuk bisa meningkatkan faktor-faktor untuk terjadinya hipertensi maupun chronic kidney disease, ya, pada efek jangka panjangnya. Nah, kejadian AKI ini, gitu ya, terutama pada anak-anak di usia infan ataupun anak-anak di usia school age, preschool, gitu ya, itu terjadi atau meningkat kejadiannya sebesar 30% sampai 50% pada anak-anak yang mengalami pembedahan jantung, gitu ya. Jadi kalau misalnya anak-anak ada yang memiliki kelainan jantung, gitu ya, maka dia akan beresiko 30% sampai 50% untuk menderita AKI. Kemudian pada anak-anak yang mendapatkan intervensi pemasangan ventilator maupun obat-obatan inotropis, gitu ya, maka mereka juga akan beresiko untuk mengalami AKI, di mana AKI ini juga biasa terjadi pada anak-anak yang menerima aminoglikosid dan multiple nephrotoxin selama perawatan di rumah sakit, ya. AKI juga terlihat pada 26,9% anak, ya, dan AKI yang cukup berat ini terlihat pada 11,6% anak dengan lama rawat di intensive care unit itu selama kurang lebih 7 hari. Jadi beberapa kejadian, gitu ya, atau beberapa treatment pada anak-anak yang sedang dirawat di rumah sakit itu juga ternyata meningkatkan kejadian AKI ini pada anak-anak gitu ya. Nah, kemudian di sini ada definisi ya terkait acute kidney injury yang cukup akurat ya dibandingkan dengan definisi-definisi dari beberapa literatur ya. Di antaranya itu adalah dari Kidney Disease Improving Global Outcomes atau KDIGO gitu ya, di mana dia memiliki definisi yang mampu diterima oleh praktisi-praktisi yang sangat concern pada kesehatan ginjal anak gitu ya, di mana dia mendefinisikan AKI sebagai sindrom klinis yang merupakan kejadian deterioration pada ginjal secara tiba-tiba yang akhirnya mengakibatkan ketidakmampuan ginjal untuk bisa mempertahankan keseimbangan cairan dan elektrolit gitu ya. Dan ini ternyata bukan hanya dialami oleh anak-anak yang sudah berusia lebih besar gitu ya, tetapi juga bisa dialami oleh anak-anak atau bayi-bayi yang baru lahir di usia neonatus, yaitu 0 sampai 28 hari, dan kejadiannya ini adalah sebesar 8%. Nah, ini ada etiologi untuk terjadinya acute kidney injury gitu ya, di mana kejadian ini bisa penyebabnya itu bisa prerenal, bisa intrinsik renal, ataupun postrenal, di mana prerenal ini diakibatkan kemudian adanya sepsis, kemudian kekurangan albumin, dan gagal jantung ya, di mana prerenal ini biasanya ya terjadinya sekitar suplai darah ya, adanya gangguan suplai darah pada yang masuk pada ginjal. Kemudian etiologi intrinsik renal itu terjadi akibat dari gangguan atau kerusakan di dalam struktur organ ginjalnya itu sendiri gitu ya. Biasanya diakibatkan oleh glomerulonefritis, kemudian post infeksi, kemudian post streptokokal gitu ya, infeksi bakteri, kemudian ada penyakit lupus, ada juga gangguan-gangguan kongenital ya pada ginjal ya, seperti misalnya tumor rhabdomyolysis ya. Nah, kemudian juga ada penyebab AKI ini yang postrenal, di mana postrenal ini melibatkan adanya obstruksi pada urine outflow gitu ya, kemudian misalnya kandung kemih juga, dan misalnya terjadi pada terjadi tumor pada kandung kemih, atau misalnya ada kejadian ureteroksel gitu ya, ada juga sistitis. Nah, itu juga bisa mengakibatkan kejadian AKI pada anak. Nah, di sini ada beberapa penyebab yang paling sering terjadi gitu ya pada mengakibatkan AKI pada anak-anak. Di antaranya dibagi menjadi penyebab untuk anak-anak di bawah usia 5 tahun dan penyebab AKI pada anak-anak di atas usia 5 tahun. Di mana untuk penyebab AKI pada anak-anak di bawah usia 5 tahun ini adalah terjadi karena adanya kelainan kongenital seperti polycystic kidney, kemudian bile duct obstruction, kemudian juga misalnya ada anak-anak yang mengalami tumor Wilms misalnya gitu ya. Nah, kemudian untuk anak-anak di atas usia 5 tahun biasanya terjadi glomerular disorders seperti nephrotic syndrome, lupus nephritis, dan congenital abnormalities lainnya. Nah, ini adalah bagaimana caranya kita bisa menentukan apakah terjadi gangguan pada fungsi ginjalnya atau tidak gitu ya. Tetapi ini kan settingnya adalah setting rumah sakit, di mana memang di setting rumah sakit ini kita harus betul-betul memahami ya setiap hasil-hasil pemeriksaan laboratorium, baik itu yang berasal spesimennya itu dari darah maupun dari urin gitu ya. Nah, di mana salah satu beberapa di antaranya adalah ketika misalnya dalam pemeriksaan laboratorium anak diidentifikasi terjadi anemi gitu ya. Nah, maka kita harus harus memprediksi nih kira-kira asal dari kejadian anemia itu ada di mana, gitu ya. Apakah misalnya ada SLE, apakah ada renal vein thrombosis dan lain sebagainya. Kemudian misalnya jika kita dapati terjadinya leukopenia, ya, maka itu bisa saja penyebabnya adalah SLE dan sepsis. Atau misalnya terjadi trombositopenia, maka penyebabnya ada SLE, renal vein thrombosis, sepsis maupun HUS ya. Kemudian ada hiponatremi yaitu dilusional. Kemudian ada terjadinya metabolic acidosis karena tadi ya proses penyerapan atau proses pengeluaran sampah-sampah di dalam tubuh yang kurang maksimal sehingga terjadinya peningkatan kadar bun, kreatinin, kemudian uric acid, potasium dan fosfat ya. Dan hipokalsemia. Kemudian ada juga penurunan serum C3 level, di mana serum C3 level ini adalah untuk menunjukkan adanya terjadinya glomerulonefritis dan SLE. Kemudian dari sisi pemeriksaan antibodi juga gitu ya, bisa didapatkan misalnya apakah terdapat streptokokal, apakah ada SLE, apakah ada neutrofil sitoplasmik gitu ya, yang biasanya diakibatkan oleh sindrom Wegener ya. Nah, kemudian ada juga GBM. Nah, kemudian ada juga CXR, di mana CXR ini menunjukkan bahwa terjadi gangguan pada fungsi kardiomegali, pulmonary congestion, dan pleural effusion ya. Jadi yang kondisi-kondisi yang menyebabkan terjadinya penumpukan cairan ya, sehingga volume cairan maupun volume darah yang masuk ke ginjal itu menjadi overload sehingga ginjal tidak dapat melakukan fungsinya untuk filtrasi ya. Kemudian selain pemeriksaan lab, pemeriksaan diagnostik juga wajib kita lakukan ya, yaitu dengan renal USG. Di mana renal USG ini adalah untuk mengetahui apakah terjadi hidronefrosis atau hidroureter ataukah terjadi nephromegali ya. Kemudian ada juga renal biopsi. Nah, jadi renal biopsi ini tidak dapat menjelaskan secara detail gitu ya terkait penyebab dari apakah ini adalah prerenal atau postrenal ya. Nah, kemudian di sini juga ada other biomarkers gitu ya, di mana seperti yang kita ketahui bahwa penanda fungsi ginjal yang sangat umum kita cari atau kita lakukan itu adalah serum kreatinin gitu ya, kemudian ureum kreatinin kayak gitu. Nah, ternyata menurut Misra ya dan Tarabisi itu pada tahun 2005 dalam sebuah jurnal ya yang berjudul Neutrophil Gelatinase Associated with Lipocalin as a Biomarker for Acute Renal Injury After Cardiac Surgery. Nah, jadi dia menemukan bahwa ada yang namanya plasma neutrophil gelatinase associated lipocalin ya. Nah, itu tuh adalah biomarkers yang bisa kita deteksi bahkan sebelum terjadi kerusakan pada ginjal gitu. Jadi NGAL ini merupakan sebuah biomarker yang sangat sensitif gitu ya terhadap adanya kelainan pada fungsi ginjal tersebut. Maka kalau misalnya saya nggak tahu ya di Indonesia itu sudah ada atau belum yang melakukan pemeriksaan NGAL ini. Tetapi kalau misalnya bisa kita lakukan, saya rasa ini akan menjadi hal yang sangat baik gitu ya untuk pencegahan morbiditas dan mortalitas akibat dari AKI. Nah, kemudian ini adalah tanda-tanda dan gejala ya ketika anak sudah menampakkan bahwa ada sesuatu yang terjadi pada ginjalnya gitu ya. Di antaranya adalah edema ya, di mana edemanya ini adalah edema yang khas gitu. Karena apa? Karena dia simetris edemanya, antara kiri dan kanan itu sama. Mungkin kita juga pernah ya bengkak di kaki, tapi bengkak di kakinya itu adalah misalnya satunya normal, satunya bengkak gitu ya. Nah, itu belum berarti bahwa ketika misalnya bengkaknya secara gantian itu dia sudah menderita aki, tidak gitu ya. Tetapi memang dia harus simetris bengkaknya, harus sama gitu ya besarnya dengan ekstremitas kiri atau kanannya. Kemudian ada hematuria gitu ya. Jadi kemunculan darah atau adanya darah pada urin gitu ya, itu bisa ditentukan secara dua hal, yaitu makroskopik ataupun mikroskopik. Dimana kalau misalnya secara makroskopik itu berarti darah itu terlihat jelas gitu. Nah, tapi kalau misalnya dia itu darah di dalam urin itu mikroskopik, maka dia invisible, harus dilihat di bawah mikroskop gitu ya. Nah, jadi jangan sampai kita itu anak kita itu jatuh pada kondisi ini, jatuh pada kondisi hematuri. Kalau sudah terjadi hematuri kan berarti fungsi filtrasi ginjalnya pun terganggu gitu ya. Kemudian ada leukosituria, di mana peningkatan jumlah leukosit di dalam urin itu lebih dari 5 sel ya. Nah, jadi ini juga bisa menjadi salah satu pertanda bahwa ada hal yang sedang mengganggu kinerja ginjal. Makanya kita harus segera aware. Nah, kemudian selain hematuria, kemudian leukosituria, ada juga proteinuria, oliguria, dan hipertensi, di mana masing-masing tanda dan gejala ini merupakan warning gitu ya, merupakan salah satu peringatan gitu bahwa ginjalnya sedang tidak apa-apa, sedang tidak baik-baik saja gitu ya. Kemudian ada hipertensi, di mana hipertensi ini juga mengalami peningkatan dalam tekanan sistolik maupun diastoliknya ya. Karena apa? Karena ketika suplai aliran darah ke ginjal atau cairan darah ke ginjal itu berkurang, maka otak akan mengirimkan sinyal bahwa tubuh perlu asupan cairan ya, terutama pada pembuluh darah agar tidak terjadinya shock gitu. Nah, sehingga fungsi tubuh kita itu secara otomatis akan melakukan peningkatan frekuensi denyut jantung gitu ya, untuk bisa memenuhi kebutuhan tersebut. Nah, kemudian apa sih tanda dan gejalanya gitu ya? Yang pertama ada growth disorder. Kenapa terjadi growth disorder? Ya karena tadi fungsi filtrasi ginjalnya terganggu. Zat-zat yang seharusnya diserap kembali oleh tubuh itu terbuang bersama urin. Seperti tadi ada glukosa, ada protein gitu ya. Jadi tidak dapat dimanfaatkan oleh tubuh untuk tumbuh kembang anak tersebut. Kemudian ada kepucatan atau anemia gitu ya. Nah, itu juga mungkin ya diakibatkan oleh tadi ya, suplai darah kepada seluruh tubuhnya kurang baik. Kemudian ada bone abnormality. Nah, kenapa bisa terjadi bone abnormality? Karena tadi ya salah satu fungsi ginjal itu adalah forming, di mana dia juga turut melakukan penyaringan ya, kemudian juga ada adil dalam mempertahankan aliran darah yang cukup ya. Dimana kita tahu bahwa letak atau titik pertumbuhan pada anak itu adanya di tulang-tulang panjang yang memang produksi sel darahnya di situ ya, sehingga ketika terjadi kerusakan ginjal, kemudian darah-darahnya tidak bisa disaring, tidak bisa didistribusikan kepada seluruh tubuh, maka akan terjadi gangguan pertumbuhan tulang gitu ya. Kemudian ada juga dyspnea. Dyspnea ini bisa juga karena komplikasi aki ya, yang menuju arah jantung, sehingga dia bisa menimbulkan sesak ya. Nah, kemudian juga ada hipertermia. Nah, dampak ya terhadap gagal ginjal terhadap anak itu adalah adanya growth disorder, anemia, terjadi hipertensi, terjadi dislipidemia, ada kelainan tulang, ada gangguan kelainan pada jantung, ketidakseimbangan elektrolit, dan kejadian gangguan pada hormon. Nah, apa sih yang bisa kita lakukan sebagai perawat gitu ya dalam melakukan preventif atau melakukan pencegahan terjadinya AKI pada anak-anak yang sedang kita rawat gitu. Yang pertama kita harus mampu mengidentifikasi faktor resiko, di mana pengidentifikasian faktor resiko ini tidak bisa dilakukan hanya satu kali. Jadi harus dilakukan secara periodik gitu ya, dengan memantau berat badan bayi, kemudian apakah misalnya sebelumnya ada histori atau riwayat mengalami AKI gitu ya, apakah ada hipertensi, apakah ada obesitas, apakah ada diabetes pada anak gitu ya, apakah terjadi terjadi gangguan pada saluran perkemihannya, kemudian apakah terjadi kelainan ginjal yang tidak diketahui sebabnya sebelumnya, atau bahkan ada salah satu anggota keluarganya yang juga mengalami atau memiliki riwayat penyakit ginjal. Nah, dari sisi penyebab juga kita harus bisa mencegahnya ya. Nah, seperti apa? Seperti kita harus mencegah dehidrasi pada anak. Kita kan tahu bahwa anak-anak itu khususnya misalnya toddler gitu ya, toddler, preschool, itu senangnya sedang mengekspor. Jadi mengekspor semua dunia yang ada di sekitarnya. Tetapi dia belum bisa memutuskan terkait apa yang harus dia masukkan ke dalam tubuhnya gitu ya, sehingga banyak sekali anak-anak yang menderita dehidrasi saat-saat ini gitu ya, karena kan kita sudah mulai adaptasi kebiasaan baru ya, aktivitas juga sudah mulai banyak, anak-anak sekolah juga sudah mulai full time gitu ya, jadi ada dari jam 8 sampai jam 4 misalnya. Kemudian anak-anak kita itu saking asiknya mengekspor, saking asiknya berinteraksi dengan teman-temannya lagi, setelah sekian lama mereka nggak bisa bermain gitu ya, akhirnya fokusnya ke sana sehingga anak-anak itu lupa ya untuk mencukupi kebutuhan cairan tubuhnya. Kemudian kita juga harus mengurangi exposure ya pada ibu-ibu hamil, exposure infeksi bakteri ya pada ibu-ibu hamil. Nah, kemudian bisa juga kita melakukan genetic counseling untuk mencegah penyakit ginjal yang diturunkan ya, atau misalnya penyakit hipertensi yang diturunkan atau penyakit diabetes yang diturunkan. Fungsinya untuk apa? Ya tadi kan ini adalah preventif. Gitu ya. Ketika kita mengetahui bahwa ada sesuatu ya di genetiknya yang memang bisa menyebabkan AKI secara dini, maka kita harus mampu untuk melakukan edukasi dan melakukan persiapan kepada keluarganya gitu ya, untuk bisa supaya anaknya tidak mengalami gangguan AKI tersebut. Nah, kemudian kita juga harus berkolaborasi dengan dokter untuk melakukan pencegahan secara sekunder, di mana pencegahan secara sekunder ini bisa mencegah terjadinya AKI ya. Nah, kemudian kita juga harus melakukan manajemen untuk hipertensi, anemia, proteinuria gitu ya, dan menyusun sebuah regulasi ya untuk pengobatan akut kidney injury yang serius ini beserta contoh-contohnya. Gitu. Nah, kemudian di sini ada beberapa kriteria ya menurut pediatric risk injury, kemudian NNSTEP ya, di mana ketika kita misalnya menemukan beberapa tanda-tanda dan gejala di sini, maka kita harus segera merujuk anak tersebut, gitu ya, atau anak kita tersebut kepada fasilitas kesehatan yang memiliki unit hemodialisa anak, gitu. Jadi tidak semua rumah sakit rujukan, baik pusat maupun daerah itu memiliki fasilitas untuk hemodialisa anak, ya. Sehingga tadi wajar saja ya dari 241 itu meninggal 133 itu karena memang ketika anak-anak yang terkena AKI secara misterius dan akut itu berlangsungnya hanya beberapa hari saja gitu ya. Jadi ini memang harus kita betul-betul koordinasikan dan perhatikan. Nah, di sini ada stadium-stadiumnya. Dan di sini ada baseline-nya atau apa namanya biomarker gitu ya. Hasil yang bagaimana sih yang dinyatakan sebagai resiko, hasil yang bagaimana dinyatakan sebagai injury, dan hasil yang bagaimana yang dikatakan sebagai failure. Di mana untuk faktor injury ini ada dua pandangan, yaitu dari tadi kidney dan dari pediatric risk and injury and NSAID gitu ya.
Ibu Uji,
Ya.
my apologize. Your time 5 minutes left.
Okay. This is the end slide, I think.
5 menit lagi ya.
Ya, 5 menit lagi. Oke. Nah, di sini ada faktor resiko, di mana ketika misalnya terjadi peningkatan kreatinin 1,5 sampai 1,9 kali lebih tinggi dari baseline, ya, atau terjadi peningkatan kreatinin lebih dari 0,3 mg, itu sudah bisa dikategorikan sebagai beresiko. Nah, sedangkan menurut Pediatric Risk Injury and NSAID itu peningkatan kreatininnya itu kalau misalnya sudah terjadi 1,5 dari baseline atau penurunan laju glomerulus filtrasi sebesar 25%. Nah, dan ketika terjadi produksi urin kurang dari 0,5 ml per kilogram per jam selama 6 sampai 12 jam atau kurang dari 0,5 produksi urinnya selama 8 jam. Itu termasuk resiko. Nah, kita harus hati-hati nih. Berarti kita harus melakukan misalnya mencukupi asupan cairannya gitu ya. Kemudian yang kedua dikatakan injury, dikatakan sudah AKI itu bagaimana ketika terjadi peningkatan kreatinin 2 sampai 2,9 kali dari baseline. Menurut pediatrik itu ada peningkatan kreatinin 2 kali dari baseline atau ada penurunan laju filtrasi glomerulus ya sebesar 50% ya. Nah, kemudian ada penurunan produksi urin kurang dari 0,5 ml per kilogram per jam selama lebih dari 12 jam atau lebih dari 16 jam. Nah, itu sudah dikatakan injury. Nah, kemudian ada yang dikatakan failure atau gagal ginjal ketika sudah terjadi peningkatan kreatinin 3 kali dari baseline atau peningkatan kreatinin sampai 4 mg per deciliter ya, atau inisiasi terapi pengganti ginjal atau penurunan laju filtrasi glomerulus kurang dari 35 ml per menit. Nah, sedangkan menurut Pediatric Risk Injury and NSAID peningkatan kreatininnya itu 3 kali baseline atau penurunan GFR sebesar 75% ya. Nah, untuk produksi urinnya itu jika terjadi anuria selama lebih dari 12 jam. Nah, jadi jangan sampai kita menemukan anak itu sudah pada tanda-tanda failure ini gitu ya. Kalau bisa itu kita harus memonitor anak itu sampai pada resiko gitu ya. Itu pun sudah cukup sudah cukup kejar-kejaran gitu ya untuk memperbaiki fungsi ginjalnya. Nah, sekian dari saya, mudah-mudahan yang sudah saya sampaikan tadi itu bisa meningkatkan kewaspadaan kita kepada terkait untuk pencegahan terjadinya gagal ginjal akut pada anak ya. Yang harus kita garis bawahi di sini adalah bahwa kejadian gagal ginjal akut pada anak itu bukan suatu proses yang bisa terjadi dalam hitungan jam atau hitungan hari gitu ya. Jadi pasti ada beberapa hal faktor resiko tadi yang memang kita tidak terlewat menyadari, sehingga kita itu menemukan anak-anak sudah tadi pada state resiko atau bahkan state injury gitu, atau bahkan state failure. Sehingga yang ketika kita sudah menemukan anaknya itu ada di state failure, maka kesempatan kita untuk bisa menyelamatkan anak-anak tersebut akan menjadi sangat kecil gitu ya. Itu saja mungkin dari saya, Bu Musti, mudah-mudahan bisa dipahami oleh teman-teman semua yang ada di sini. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Bu Uji. It's a wonderful presentation, I think. And I get a summary your subject. It's like acute kidney injury or AKI in children. It's a sudden deterioration in renal function. Oh, another word is acute renal insufficiency. Incident of AKI at pediatric intensive ward, 1/3 critically sick children and non-critically ill children. Increase 30 until 50% to children in heart surgery. And it happened to children with ventilated and 80% infant in NICU. Etiology of AKI is it happened in prenatal. My apologize, not prenatal, but prerenal, intrinsic renal, and post-renal. Sign and symptom in many, but focus on edema. Edema have symmetrical between leg right and left in lower extremity. Impact can happen in children, especially to growth disorder, anemia, hypertension, and so on. The role of the nurse is to identification risk factor, periodic screening, and preventive etiology. I think it's a summary subject from Ibu Fauzia. Now we go to Q&A. Many questions for you, Ibu Fauzia. The first is in Bahasa Indonesia. Ibu masih ketutup. Okay. This is from Master Unjani M. Agus Jabir, Escape Nurse MCAS to everyone. Saya M. Agus Jabir dari Sulawesi Selatan. Wow. Ingin bertanya, apakah yang harus dilakukan oleh orang tua agar terhindar dari gagal ginjal pada anak, Bu?
Oke, baik. Nah, seperti yang tadi sudah saya sampaikan gitu ya, bahwa penyebab-penyebab terjadinya gagal ginjal itu kan bisa prerenal, bisa intrinsik, bisa postrenal gitu ya. Nah, kita harus bisa memastikan bahwa anak-anak kita itu tidak memiliki kelainan ya secara kongenital pada atau abnormalitas pada ginjalnya. Ketika kita sudah bisa memastikan itu, berarti kita harus bisa melakukan pencegahan dari sisi aspek postrenalnya. Nah, tadi kan bahwa penyebab terjadinya gagal ginjal secara postrenal itu akibat dari kekurangan volume cairan atau volume darah yang masuk ke dalam ginjal. Nah, kekurangan volume cairan itu kan bisa diakibatkan oleh kurangnya asupan cairan, kemudian pola asupan cairan yang memang bisa memperberat kerja ginjal ya, seperti misalnya mengkonsumsi makanan-makanan yang tinggi natrium, kemudian mengkonsumsi minuman-minuman yang apa namanya, berperisa ya atau berasa gitu ya, minuman-minuman kemasan yang secara apa namanya, isi atau secara ingredient kita tidak bisa memastikan bahwa itu aman atau tidak gitu ya. Seperti misalnya sekarang kan sudah banyak ya minuman-minuman kemasan dengan harga yang sangat murah gitu ya. Rp500 kita sudah bisa mendapatkan minuman berperasa gitu ya dalam kemasan gelas. Nah, itu juga itu apa namanya? Bisa meningkatkan resiko ya terjadinya gagal ginjal pada anak-anak karena kita tidak tahu, tidak jelas di situ dicantumkan apa sih isi minuman tersebut gitu ya. Nah, kemudian dengan beredarnya bebas, kemudian dengan harga murah gitu ya, itu akan sangat mudah dijangkau oleh anak-anak. Sehingga ya tadi kita harus apa namanya, pola konsumsi minum-minuman kemasan yang kita tidak bisa mengetahui dengan pasti isinya yang sangat sering gitu ya, atau bahkan seperti minuman-minuman energi ya, minuman-minuman energi yang mungkin bagi sebagian orang tua gitu ya, itu mengizinkan anak-anaknya untuk mengkonsumsi itu gitu ya. Saya pernah punya pengalaman gitu ya, punya tetangga anaknya usia 8 tahun, mungkin lebih muda lagi ya, di bawah 8 tahun gitu ya, dan dia itu memiliki kebiasaan meminum minuman energi setiap hari, hampir lebih dari 1 botol satu harinya gitu ya, dan pada akhirnya anak tersebut itu mengalami gangguan pada ginjalnya. Nah, itu juga merupakan salah satu hal yang harus kita waspadai ya, terkait misalnya kalau anak kita sudah bisa jajan di luar, kita harus pantau dia jajanannya apa gitu ya, makanannya apa gitu. Jadi pencegahan apa namanya, pencegahannya itu terkait dari apa yang dikonsumsi oleh anak-anak kita, itu yang harus kita perhatikan. Mungkin itu Bu Musri.
Oke. Ini satu lagi kayaknya pertanyaannya bagus. From Parmo Sinaga. Selamat pagi, saya Parmo Sinaga, mahasiswa program Magister Keperawatan dari Universitas Jenderal Ahmad Yani. Saya ingin bertanya kepada Ibu Fauzi tentang gagal ginjal pada anak. Akhir-akhir ini gagal ginjal akut pada anak semakin meningkat angka prevalensinya dan juga angka mortalitasnya. Penyebab gagal ginjal akut pada anak diduga karena penggunaan obat sirup yang mengandung etilen glikol. Pertanyaannya, bagaimana penanganan pada pasien dengan gagal ginjal akut yang divonis harus mendapatkan terapi hemodialisis? Apakah gagal ginjal anak yang menjalani hemodialisis akan rutin HD seperti GGK? Terima kasih, Bu.
Baik, pertanyaan yang sangat bagus sekali ya. Jadi kita apa namanya, kalau melihat klasifikasi dari gangguan ginjal itu kan ada 2 ya, ada gagal ginjal akut, ada gagal ginjal kronis gitu. Nah, ketika dia ada di tahap gagal ginjal akut dan itu early detection gitu ya tadi, terdeteksi secara dini, kemudian kita juga sudah memastikan bahwa kerusakannya pada ginjal itu masih tahap injury gitu ya. Nah, mungkin apa namanya, intervensi untuk hemodialisanya itu hanya untuk membantu meningkatkan atau menormalisasi fungsi ginjal gitu. Nah, tetapi ketika kita sudah bisa mengidentifikasi atau teridentifikasi bahwa apa namanya, klasifikasi gangguan pada ginjalnya itu sudah mengarah kepada gagal ginjal kronis, pada gangguan ginjal kronis mengarah kepada gagal ginjal, maka ya mau tidak mau intervensi pemberian hemodialisanya itu adalah menjadi intervensi yang rutin diperlukan gitu. Jadi tergantung pada apa namanya tadi hasil pemeriksaan ya, apakah fungsi ginjalnya itu ada pada tahap injury kah atau sudah pada tahap failure atau gagal ginjal gitu.
Oke ya, semoga jawaban tadi bisa dipahami oleh Parmu Sinaga. Mungkin ini kita ada waktu, masih ada waktu Bu. Ini mungkin bisa dijawab pertanyaan dari Klinik Siliwangi, Nurhasi Eskep Nurse. Apakah pola minum pada anak kurang baik bisa menjadi penyebab terkena aki? Contoh, sering mengkonsumsi minuman yang bersoda, minuman kemasan daripada air putih. Bagaimana dengan anak-anak seperti ini, Bu? Mangga Bu Iji.
Baik, tadi seperti yang sudah saya jelaskan gitu ya, bahwa kejadian aki pada anak itu bisa diakibatkan oleh postrenal. Gitu. Jadi memang yang penyebab yang di luar ginjalnya itu sendiri gitu. Jadi pada saat ginjalnya itu baik-baik saja, misalnya struktur anatomisnya tidak ada kelainan-kelainan kongenital pada ginjal, tetapi pola konsumsi pemenuhan cairannya yang tidak baik itu pun bisa mempengaruhi kejadian aki ini. Ya, kita tahu bahwa tadi ada 3 fungsi dari ginjal gitu ya, yang diantaranya adalah fungsi filtrasi, di mana ketika cairan yang kita konsumsi atau anak konsumsi itu lebih banyak mengandung zat-zat yang terlarut gitu ya, maka itu akan memperberat kerja ginjal pada anak gitu. Nah, minuman-minuman apa saja sih yang mengandung zat terlarut yang cukup banyak, yaitu ya minuman-minuman yang memiliki rasa, minuman-minuman kemasan, minuman-minuman soda gitu ya, itu akan meningkatkan kerja ginjal pada anak ya, yang mana kita tahu bahwa anak itu kan ada dalam masa pertumbuhan dan perkembangan. Begitupun juga dengan organ-organnya, gitu ya. Ketika dia masih dalam tahap perkembangan fungsi-fungsi di ginjalnya, kemudian dia diberikan beban yang cukup berat untuk memfiltrasi minuman-minuman tadi yang banyak mengandung zat-zat ya, apakah itu misalnya natrium, apakah misalnya itu banyak gulanya, kemudian ada sodanya juga gitu ya, dan mungkin minuman-minuman yang malah justru mengandung zat-zat yang toksik terhadap ginjal. Nah, itu juga akan meningkatkan kejadian aki pada anak seperti itu, Bu.
Oke. Terima kasih. Semoga penanyanya bisa memahami ya. Ini ada lagi satu tentang asesmen, Bu. Pengkajian pada anak. Asesmen awal keperawatan yang harus kita tekankan pada saat kita menerima pasien anak dengan suspek GGA itu seperti apa, Bu?
Oke. Ya, terkait pengkajian ya.
Ya,
pengkajian di sini di antaranya adalah kalau misalnya pada fisik kita lihat ya. Kita lihat tadi apakah ada edema atau enggak. Edema pada kelainan ginjal itu sangat khas gitu. Jadi edemanya itu terjadi secara simetris, baik itu pada ekstremitas atas, bawah, kiri, kanan gitu. Jadi edemanya itu simetris. Kemudian yang paling khas lagi adalah ketika terjadi edema di periorbital ya. Ada beberapa orang tua yang mungkin menyampaikan bahwa biasanya nih kan ada anak-anak yang begitu pas bangun tidur dia itu bengkak, matanya bengkak gitu ya, dua-duanya periorbital gitu. Dan ya ternyata itu adalah salah satu tanda gitu ya bahwa ada sesuatu yang tidak benar gitu ya pada sistem fungsi ginjalnya. Nah, itu juga mungkin orang tua harus waspada gitu ya ketika misalnya menemukan kok anak saya nih habis bangun tidur atau misalnya habis tidur lagi rebahan, ketika bangun itu ternyata ada udem di periorbitalnya ya, itu secara fisik. Yang kedua adalah kita bisa tanyakan ya kepada orang tua terkait pola eliminasinya. Nah, untuk normal produksi urin pada anak itu kan sebesar 0,5 sampai 1 ml per kilogram berat badan per jam, ya. Nah, kadang-kadang kan karena misalnya anak-anak itu pakainya Pampers, ya, sehingga dia orang tua nggak ngeh apakah berapa kali si anak itu pipis gitu, berapa kali si anak itu berkemih. Nah, kita bisa lihat dari berapa kali dia ganti Pampers. Misalnya dalam 6 jam itu Pampersnya itu kering, selalu kering, atau misalnya sudah terisi penuh. Itu juga kan itu bisa menjadi salah satu indikasi apakah si anak itu berkemih secara adekuat atau tidak. Kemudian kita juga bisa tanya gitu, berapa banyak sih asupan cairan yang anak itu minum misalnya dalam waktu 6 jam. Ya kan pasti bisa misalnya apakah 1 cangkir gitu ya, 1 cangkir anak-anak yang bisa kita perkirakan itu berapa ratus mili gitu ya. Atau misalnya jenis minuman yang si anak selalu konsumsi. Kemudian berapa banyak dia minumnya gitu jadi intinya adalah dari sisi intake dan output cairan si anak gitu. Jadi kalau memang misalnya kita bisa istilahnya bisa misalnya tidak memakaikan Pampers sekali pakai pada anak, itu akan lebih baik lagi karena pemantauannya bisa lebih jelas gitu. Nah, ini kan sama seperti halnya pemantauan dehidrasi pada bayi gitu kan. Berapa kali sih bayi itu pipis dalam waktu 6 jam? Kemudian tanda-tanda dehidrasi juga bisa kita lihat gitu ya. Kalau misalnya masih anak-anak di bawah usia 2 tahun, kita bisa lihat fontanelnya atau ubun-ubun besarnya cekung atau tidak. Kemudian kondisi kulit, kemudian kondisi turgor kulit, ya. Kemudian kondisi mukosa bibir, gitu ya. Nah, itu juga bisa kita lakukan pemantauan tersebut, gitu ya, untuk bisa memastikan terkait ketercukupan konsumsi cairan pada anak. Jadi awalnya memang pada ketercukupan cairan ya, Bu Musri ya. Gitu.
Oke, saya rasa waktunya tepat, selesai tepat pada waktunya. Oke, terima kasih Bu Uci. It's
Baik,
wonderful
sama-sama, Bu Musri.
presentation. Oke, senang ketemu Bu Uci meski tidak ketemu di darat tapi ketemu di webinar. Thank you so much. Bye-bye.
Sama-sama Bu Musri. Terima kasih banyak.
Sama-sama. Okay, we will continue with next speaker, Professor Dr. Rasidi Ahmad. I know you have joined us now, Prof.
Yes.
Okay.
Thank you.
Okay, it's your time for presentation, but for the first, I will read your CV for new audience. Okay, Prof. Rasidi, education background from USM, bachelor and master, and many training from another country like Canada and Calcutta. Professional experience, no consultant emergency physical in KPJ, Johor Specialist Hospital, Malaysia, and before consultant emergency physical at University Malaya. And specialist interest in cardiovascular emergency, critical care, pain management, and mass casualty management, and CBRNE. Now, he will presentation the topic today, and please, Prof, it's your time.
Thank you, Ibu Musri, for the kind introductions. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and very good morning So I'm very honored again to meet all of you today in the International Nursing Conference. I'm now at the Aloha Hotel at the KL Centrals. I'm at the lobby at the current moment. That's why maybe there is a bit of disturbance of noise disturbance here. So I hope that everybody can listen to me and then bear with me for the next 45 to 1 hours. Topic that was given to me is about in-hospital management. Ibu Musli contacted me about 2 days ago. So honestly, yes, I did this slide is quite in a ad hoc manner. However, when I'm going through the topics for today, it is about the the early warning score and also code blue management in hospitals. So it just make me wonder whether that the previous slide that I submitted is quite suitable. So I immediately make some changes because I'm going to talk more specifically about the in-hospital management, particularly about the code blue, because I think and I believe that this topic is more relevant rather than I'm discussing the specific topic about how the emergency department manage the emergency case. Okay, so I hope that do not get confused with the slides that I provide to you. Just consider it as a bonus, as an extra information. So before I going on, I would like to share my slide with all of you. Okay, as what you can see, is still in hospital emergency management. Okay, only that the topic is a bit different. I emphasize more on this our team today, which is early warning score and also the code blue management. Okay, now before I'm further discuss about this topic, I'd like to ask questions. Okay, now what do you understand by the sudden cardiac arrest or SSA as usual? What do you understand by sudden cardiac arrest? Anybody want to try? Or I won't receive any response, Bu, There will be no response, Bu, Okay,
Halo
okay.
audiens, jika ada respon, mangga silahkan.
Yeah, silakan. I think that one of the deficiencies in the online is that poor communications between the speakers and also the candidate, but it's okay. All right, so when we're talking about sudden cardiac arrest, we always discuss about someone who are collapsed, and then we immediately assess the patients. We noted that patient is unresponsive, patient has no breathing, patient has no pulse, patient has no coughing, patient has no movement. And these patients we consider as sudden cardiac arrest. Therefore, immediately we perform chest compressions and also ventilations. And then immediately that we want to know what is the responsible rhythm. It's either shockable rhythm or non-shockable rhythm. So this is what we do that when we identify patient with the cardiac arrest. This patient is in sudden cardiac arrest, therefore we provide the CPR. And what is the rhythm? If it is turned up to be a shockable rhythm, then we shock the patient. Okay, so first we already understand what is sudden cardiac arrest. And the next question that I would like to ask is, what do you understand about advanced cardiac life support? We're always talking about basic life support. We're always talking about cardiac life support. Okay, sekali lagi, Bu, there will be no response. Okay, it's okay. Okay, I ask the question and then I answer by myself. Okay, all right. So sudden cardiac arrest, the full definition is death. Okay, mati, so it means that someone is dying. So in other words, that when we're talking about advanced cardiac life support or ACLS, we are talking about management of death, management of someone that already died. Is it? Okay, that's what we understand. However, in medicine, we divide death into two groups. One is the biological death. The other one is the clinical death. So basically that the outcome is better if we able to provide the ACLS for what? For those with the clinical death. So when we define what is the ACLS, actually we are referring to the peri-arrest management. Okay, so what we mean by peri-arrest management is what we should do when someone is dying, when someone unconscious, become unconscious, someone unresponsive, no breathing, no pulse, what we should do. It's not only about when they are arrested, more than that is before arrest, or we call it is pre-arrest, what we should do before the arrest. Okay, and next is that if patient is survived or revived or return of spontaneous circulations, next what we going to do. Okay, so this is what mean by the peri-arrest management. So in our hospital, that many instances, okay, patient going to collapse, patient going to die, no breathing and no pulse, and then we provide the chest compressions. But one thing that we always forget is that 1 hour before someone is collapse, okay, no breathing, actually patient already has a sign and symptom. So this is very, very crucial period whereby we able to detect early for this patient and then aggressive manage the patient before they end up with the cardiac arrest. And next important thing is that if patient already in cardiac arrest, we provide good CPR, we administer the defibrillations, maybe drugs to improve the circulation. Once patient is revived or ROAC, what we should do next? Okay, so we discussed yesterday that in order for us to improve the mortality and morbidity, or to improve the survival of the cardiac arrest, there should be a seamless continuum of care. In other words, it's not only about the management of patient who are already dying or a patient already dead, but it's also about that what should we do before they collapse, they die. And then next question is that what we should do once they are survived. So ACLS is about the peri-arrest management. And then if you look carefully, actually ACLS is about the peri-arrest arrhythmia management. It's all related, many of that is related to the arrhythmias. For example, we are talking about stable arrhythmias, either stable tachyarrhythmias, stable bradyarrhythmias. We're talking about unstable tachyarrhythmias, unstable bradyarrhythmias. And then once they collapse, we are talking about shock of rhythm or non-shock of rhythm, whether it's VT, pulseless VT, BF, or torsades, or patient has non-shock of rhythm such as asystole and also the pulseless electrical activity. Now, the next questions, okay, what do you think about the outcome of patients who have cardiac arrest, out of hospital cardiac arrest versus in hospital cardiac arrest? Okay, what do you think? If you think is IACA has a better outcome, maybe you can press any button or raise your hand. Which one is better? Yeah, tidak ada undian bu ya. Okay, okay, baik. So in generally, the outcome of cardiac arrest in hospital much better compared to the for those who are collapsed out of hospital cardiac arrest. Okay, so this is the reason why this in hospital emergency management is very important and is very vital. And this is the reason why we're going to discuss today what we're going to do to these patients. Okay, because why? Because when someone collapses in our hospital, the outcome should be much better compared to the if they collapse out of hospital. Right now, maybe you want to be why? Okay, why? Okay, so there are 4 important factors that are associated with outcome. Right? Okay. Now this is very important. If you can write it, please write it there. Okay, number 1. What is the first factor? The first important factors is early recognition. This is very important. Okay. In other words, witness events. Okay, someone witnessed the event. We call it witness arrest. Okay, and this is very important in hospital because if someone collapsed in hospital, by right, by definition, they should be witness arrest rather than unwitnessed arrest. Okay, so the first factor is witness arrest. The second factor is high quality chest compression. Okay, I stress again, is high quality chest compression. It's not about just providing the chest compressions. I think before 2010, yes, we always said that bad CPR is better than no CPR at all. But after 2010, we said that it's no more about bad CPR. We must perform high quality CPR. Okay, as a second factors. Okay, and the third factors is the shock algorithm, either VF or VT, and the last one is a rapid defibrillations. Okay, many times in hospital, when patient collapse, they are witness, and then most of us we able to provide a high quality chest compression. If patient has the shock algorithm, we shock patient, and I can guarantee you that patient will survive. I have many experiences in managing patient with cardiac arrest, witness cardiac arrest, and the outcome is good, though it's not 100%, but at least about up to 40% patient will survive in terms of ROSC, and less than that can go back home and meet the families. Okay, because by the understanding these four factors, okay, we translate to the chain of survival. Okay, now everybody knows that in 2020 we have the new guidelines, and there is a bit of changes in the chain of survival for the guidelines of 2020, as what I show here. There is an additional of the rings in the chain of survival 2020, whereby they insert the recovery as the sixth link. And then if you noted here, after rapid defibrillations, they rather than they mention about the ACLNs, they discuss more on the post cardiac arrest care. Okay, now why they do this? Because the hope of the American Heart Association is that the outcome of cardiac arrest patients after basic life support is much better compared to after provision of the ACLS. So therefore, they want us to focus on the early recognition and prevention, activation of emergency response, high quality CPR, and also defibrillations. Once patient survive, we provide the good or post cardiac arrest care. So my discussion today, I'm going to discuss all the factors, the important point related to the chain of survival according to the AHA 2020. And I believe that all important points that we're going to discuss is very beneficial for all of you. Okay. Now, next, let's discuss about this early recognition and preventions. Okay. Okay. Now, what is the main thing about these early recognitions? I think everybody's know that there are 12 important reversible causes for pediatric patients, and there are 10 reversible causes in adults. Okay, what are they? We have the 5H and 5Ts for adults, and then we have the 6H and 6Ts in children. So this kind of patient, usually they come to emergency department. For example, at the place where I work, we have these dialysis centers, and then we have many patients, many end-stage renal failure who require regular dialysis collapse at our department. And then one of the main reasons why they collapse, because number one, it has multiple comorbidities. These patients are hypertensive, they are diabetes, they are heart failure sometimes, some on and off, they got this infection. Sometimes they miss dialysis, so therefore they have the hyperkalemia, and also they have the metabolic acidosis. Okay, so this group is common, especially is that you have the aging population, and then you have those patients with diabetic retinopathy, hypertensive retinopathy, that end up with the chronic renal failure, and also the end-stage renal failures. Okay, this is the group. These 5H, 5T, I'm not going to discuss in detail, but it's very important for you to understand. Those with the 5H and 5Ts, they are having risk of sudden cardiac arrest. Okay, however, they have a potential reversible cause. Okay, so those patients come to you with respiratory failure, you can manage them. For example, those patients with the shock, okay, hypotension, you're able to manage them. Those patients with the trauma, you're able to manage them. For example, so it's very, very important for us to recognize all these reversible causes and aggressively manage the patients. And the other thing is that admit them to the proper place. Okay, if they require ICU, please admit them to the ICU. If they require HDU, high dependency unit, admit them to high dependency unit. If they are stable, then you admit them into the common ward. Okay, at my working place, KPJ, common ward is a room based. So if someone collapses in your room, it's very difficult for you to recognize. Okay, so please look your setup. Okay, whether you able to to monitor the patient or not, because it's very, very important. Because these patients, they are high risk of sudden cardiac arrest. Okay, and next, the most important is that if patient is arrested, it need to be recognized immediately. This is very, very important. Okay, so number one, those who are high risk for sudden cardiac arrest, we must manage them aggressively. We must put them into the appropriate place. Number two, we need to continuously monitor the patient. If they collapse, it need to be witnessed. Why? Because witness arrest has better outcome compared to the non-witness arrest. So we need a system whereby you able to perform the surveillance to this group of patients so that you can be early recognized. So it's unfair or is inappropriate if someone in our care collapse unwitnessly. Okay, you understand what I mean? It means that patients who are at risk, patients who are in critical inpatients, and then when they collapse, we call it their collapse alone. Nobody know about it. So it's unfair and is inappropriate. Okay, so yes, we know there are critical ill patients. Okay, but if they collapse, we're able to witness immediately, and then we're able to activate the emergency response and provide high quality chest compression. So that's what we need. Okay, so the staff, okay, the hospital responders or the healthcare providers must be able to recognize sudden cardiac arrest, must be able to recognize unresponsiveness, must be able to recognize no breathings, no pulse. Very, very important. Okay, it's not that easy, but it's need to train. Okay, for nurses, for all of us, especially how to check the pulse. Okay, some people, the check pulse is very immediately, whereby if you want to check pulse, at least 5 seconds for you to check pulse, because we don't want you to miss the bradycardia. Okay, so looks very simple, but actually it's tough. That's the reason why when we're talking about this code blue management, it need to be trained. Staff need to be trained continuously, so that when the event occurs, easy for us to manage the patient efficiently. Okay, now number two, once you recognize the patients either in critical state or patient in cardiac arrest, we must know what to activate. Okay, so the next point is about this activation of emergency response. Now, the topic that you discussed today is an early warning score. Is a very good topic. It's about that early recognize those who are critical patients, because those who are fulfilling certain criteria or score of the early warning score, they are at risk, for example. Okay, so it's not a sake of jotting down all the vital signs, but it also it must reflect in terms of the aggressiveness of your management. Okay, all right, good. So those who are critical patient, you must know who to activate, and those who are cardiac arrest, you also must know who you should activate. That's why in Malaysia, for example, in my place, we have two teams. We call it the Code Blue team, and the other one we call it CODMED, or Code Medical Emergency Team. In some places they have RRT. They call it Rapid Response Team. Okay, betul Ibu, eh? So maybe your hospitals maybe have code blue team. Don't worry about the term. Okay, the most important is not the term. The most important is what is the team objective. Okay, for example, there is a hospital whereby they only have one team, which is code blue team. However, code blue team also manage those who are critical ill and also manage those who are cardiac arrest. Okay, means they have two jobs. Okay, the disadvantage of this is that maybe it's not cost effective, because when you activate code blue team, it means you are activating. The reason you activate is because of the cardiac arrest. Therefore, we need more specialized team. We need emergency physician, for example. We need the anesthesia, for example. That's the reason why you activate the code blue team. Whereas code med team, sometimes what you just need is the senior medical officers. For example, patient suddenly oxygen saturation drop from 94 to 86, for example. Okay, you need someone to assist you immediately. Then you can activate the code blue team. Or if the nurses or the healthcare providers feel something is not right with this patient, despite of your early warning score, it seems to be good, but inside your heart, you feel something is not, something strange and odd, and then you worried about it. Actually, you can activate this code med team. Okay, because code med team, you activate this code med team before their collapse. Okay, so it is very, very useful. Sometimes, I'll give you an example. We have the case whereby this elderly came to the clinic. Patient is hypertensive, okay, taking multiple drugs, waiting to be seen by doctors, and then complain of dizziness. Patient is not taking the medication that morning. When you check blood pressure normal. Okay, so while waiting, suddenly patient collapsed. Okay, but when we ask the nurse saying that something is not right with the patient. However, the vital sign is normal. Yes. Okay. Why this happened is that vital sign is normal doesn't mean it's a normal. For that patient, hypertensive patient who did not take medication, maybe the blood pressure is 180, but they when come to see you, the blood pressure is 100 or 110. Actually, it's very, very low. It shows a sign of the deterioration. Recently, we also have a case whereby patient post angiogram, okay, and then at the site of the punctures, continuous compressions performed at the site of punctures. Actually, patient is bleeding, and the vital sign shows what? Actually, the heart rate is climbing up, heart rate is increasing, blood pressure is reducing, but within a normal range. Okay, within a normal range. So if you measure by your early warning score, maybe you notice it's a normal, but actually it's not normal. Okay. Okay. Why? Because it is not only the value is important, but the trend is as important as the values. Okay. So activation of respiratory is very, very important, because when you manage emergency cases, it's about the team management. Okay, it's not about the individual management. You yourself is not important. Professor Rashidi, you are not important. What is the most important? The most important is your team, because this is not one man shows. Okay, someone need to become the team leader. Someone need to be the chest compressor, someone need to control the airway, need to avoid excessive ventilation, someone to provide the defibrillation, someone need to get the line, someone to give the administer the medication, and someone also need to document, okay, to document all the events. Okay, so it's not about you, it's about your team. Okay, the success of this cardiac arrest management in hospital is the success of the team. That's why if you went for training, we always focus on the dynamic team. It's very, very important. Dynamic team. Okay, with the dynamic teams, your success rate to get ROAC actually much higher compared the uncontrolled team. Okay, so first that the prevention and early recollections. Number two is activation the emergency response. Okay, so you need to come out that what is a suitable emergency response for your hospitals. Okay, think about it. Think about Code Blue team, think about CODMED, think about RRT. Okay, you can you Google in the website, then you can. There's an ample of information about this. It just matter whether you want to practice it or don't. Okay. So next is this high quality CPR. Okay. It's not educate only about the recognized. Yes. Early recognition save lives. Agree. It's not also about activating appropriate team. Yes, it's very important. But the most important is that once you recognize patient has sudden cardiac arrest, the team or someone need to provide high quality CPR. What I mean by high quality CPR? Providing effective chest compressions and providing the effective ventilation. In other words, avoid excessive ventilation. This is very, very important. I always say that this high quality CPR is very, very crucial, because only by high quality CPR we're able to generate up to 40% of the cardiac output. Okay, just want to emphasize again. Only high quality CPR able to generate 40% of cardiac output, whereby it can perfuse the 40% of cardiac output. It will perfuse the brain. Okay, so several perfusions only can be achieved once you have the cardiac output of 40%. So therefore, we need to provide the high quality CPR. Okay. Now, okay. So therefore, that what you can see in the changes in the guidelines in 2010, they always mention about these two things. Okay, high quality CPR, and the other one is chest compression fractions. These two very important. Okay, so that's why in 2010, instead of they are discussing about ABC, how to manage cardiac arrest, ABC, now suddenly they change to CAB. Okay, so instead of start with the providing ventilations, your suggestion now is start by providing the chest compression. Because why? Because we want more chest compressions compared to the ventilation. So these are the two great changes after 2010, and it's more emphasized in the guideline 2020, whereby that the chest compression fraction, for example, it was increased from 60% to more than 80% in order for us to get the ROAC, or return of spontaneous circulation. Okay, so what is high quality CPR? Once again, so every time that we providing the CPR, always remember these 6 things. Always remember. Okay, so we need to comply with this. Okay, if we not comply with this, the outcome is very poor. Like I mentioned to you, what are the 4 factors that are important? Witness arrest, high quality CPR, shockable rhythm, and rapid defibrillation. Okay, so once again, please make sure that our staff provide the high quality CPR by push hard. So the depth for adult is 5 to 6 centimeter. Okay, push hard is about 100 to 120 per minute, or push once again, push hard at the center of the chest with the depth of 5 to 6 centimeters. Okay, sorry. Maybe dah aging bu ya, sudah aging, sudah tua. Okay, and then push fast. Okay, heart rate about 100 to 120 per minute, or 30 chest compressions within 15 to 18 seconds. Okay, all right, allow complete chest recoil. In other words, push hard, push fast is about cardiac contractions. Allow complete chest recoil is about cardiac relaxations, whereby you need a feelings. Okay, educate feelings will lead to increase the cardiac output. So these two things is very important. And next, the emphasis is on minimize interruptions during the chest compression. Okay, so this is another things that we need to emphasize. I will emphasize more. And the 5th one is that the compression providers should be changed every 2 minutes. However, if the chest compression providers fatigue, then you can change as frequent as possible. And the last one, number 6, is avoid excessive ventilation. This is the most difficult one. Compared to the rest, I found out that the rest actually not that bad. By avoiding excessive ventilation is very difficult. This one is very, very difficult. Because why? Because I noticed that every time that we provide ventilation in cardiac arrest patient, we tend to follow our breathing. Okay, whereas the recommendation is that 30 compressions, 2 ventilations. So during the cardiac arrest, then we just follow our breathing. Okay, Okay, and then we number one is rapid inflations of the back valve mass. Number one. Number two is large volume, and this is not good to the patient. Okay, all right. So excessive ventilation, risk of regurgitation. Okay, excessive ventilation, increase intrathoracic pressure, therefore reduce venous return, reduce stroke volume, reduce cardiac output, and reduce cerebral perfusions. Okay, so high quality CPR is very, very important. So because of that, these are always the questions. Okay, when providing this emergency management for cardiac arrest, these questions: is your CPR effective? Okay, in other words, is that we are talking about high quality CPR, yes, but we're also talking about, can you make sure that you are providing the high quality CPR continuously till patient has ROAC. Okay, it's not only high quality CPR, but also in terms of the chest compression fraction that I'm going to discuss later. Okay, all right. Now, how to do it? Okay, so I believe that everybody know about this thing. The first one show you is an audio visual feedback. Okay, for when you performing the chest compressions, so you have this gadget. Okay, you put it on the patient chest, the patient victim, and you perform chest compressions, and then you can see whether your depth and your rate is appropriate or not. Okay, so someone providing the chest compressions, and then someone looking at it, and then start giving the advice. Hey, look, your compression is not that deep. Push harder, push hard. Okay. Hey, look, your compression is too fast, slower, something like that. Okay. Why? Why it is not only saying, it's not only about saying high quality CPR, it is also about ensuring that you are providing the high quality CPR. So these other visual feedback is very good. That I suggest everybody to have this one. Okay. Next is the ETCO2, end-tidal CO2 is very, very good, especially that after you tube the patient or after you insert advanced airway, either laryngeal mask airway or endotracheal interventions, because you can see the values of these end-tidal CO2, because end-tidal CO2 correlate with your cardiac output. Okay, so for example, that if your ETCO2 level is more than 10, it means that you are providing high quality chest compression. For me, it's very good. In fact, I'm using this. It's not only to determine high quality CPR. I'm also using ETCO2 to determine the presence of pulse or to determine the ROAC. I'm also using the ETCO2 to stop chest compressions, to determine when to stop the chest compression. It is something that worth to have in order for us to manage the cardiac arrest effectively. Okay, all right. Okay, another one. Okay, this is very important. This one is very important. This is very important. We call it as CPR coach. Okay, this is something is very new. Okay, so now what is a CPR coach? Now, when we have this patient collapse, okay, so it's so sudden, you know, and then suddenly so many people come. We need to identify the roles. So you need to properly design the role. You do this, you do this, and at the end of the day, you notice that the team leader has many roles. Okay, okay. Therefore, sometimes the team leaders are unable to monitor the CPR. Okay, so AHA in 2020 come up with these ideas, which is CPR coach. Who should be the CPR coach? So CPR coach is for defibrillator staff. Okay, those who are in charge of the defibrillators, they are also the CPR coach. Okay, rather than the team leaders. Okay, so what is their duty? Their duty is that to make sure that the chest compression was effectively provided. Okay, so means they have to make sure that push hard, push fast, allow complete recoil. If you need the changes, so they're the one that assist. For example, okay, we need to change. But in my collection, 5, 4, 3, 2, 1, change. Okay, so this is the person that in charge. Okay, it seems to be that it has a major role, but actually team leaders still control the whole case management. Okay, so something that we need to consider, Bu, CPR coach, and then CPR coach works well if you have the audio visual feedback. Okay, so meaning that you can see objectively. Okay, or if you have the ETCO2, say therefore CPR coach can look at the audio visual feedback and then advise the chest compression providers. Okay, if the chest compression providers don't want to listen, remove them. Okay, remove them. Or the chest compression provider is very small, unable to provide appropriate depth, and after you give advice, remove them, change one. Because why? We need to maintain the high quality CPR. Okay, that's why one of the features of the team is understand the limitations. Okay, if it's not everybody can perform the chest compression. Me myself also, this 1 year I'm able to perform the chest compression because I have the frozen shoulders. So though I'm my size, I have a big size, I'm quite strong, but since that I have the frozen shoulders, so I devoid to provide the chest compression. So if your staff had the problems, you need to identify it. Do not force, okay? Because by forcing, it doesn't mean that your high quality compression can be providers. Okay, so understand the limitation. Okay, so this is something new that you can think of how to improve the emergency management, particularly in the management of sudden cardiac arrest in your hospital. Okay, so study have been shown that if you have this CPR coach, okay, better in terms of chest compressions depth, okay, reduce duration of pauses in chest compressions, minimize interruptions, less, therefore your chest compression fraction also better, and improve the outcome. Okay, so please look forward, Bu and rakan-rakan semua, please look forward with this CPR coach, which is something that is not that difficult, but something that is very, very interesting. Okay, next important point, okay, is about chest compression fractions. Okay, what do you mean by the chest compression fraction? Chest compression fraction basically is the amount of time spent providing the chest compressions. For example, let's say that within that, when someone cardiac arrest, total time of managing the cardiac arrest patient is, let's say, is 5 minutes. Okay, it's 5 minutes. Okay, it's 5 minutes, and then during that 5 minutes, what is the duration of chest compressions? So meaning, so you monitor for the 5 minutes, and then every time patient chest compression, you start your timer. When they stop, then you stop the stopwatch, and then when they start again, then you continue again, and then that you measure. Okay, time of the chest compression, total time of chest compressions, okay, and the total time of the coach. Okay. And then the aim is that it should be more than 80%. So this reason out why that we need to immediately provide this chest compressions rather than ventilation when we identify patient with the cardiac arrest. Okay, the code start with once you activate code blue, that is your time of your code. And the time of your chest compression is within the 10 seconds of recognize the chest compressions. Okay, so very, very important. You start the code early, but you start chest compression maybe a bit late. Okay, but at the end of the day, what is your chest compression fractions? Okay, boleh faham Bu? Yeah. Okay. For example, ganggu sikit ni saya punya ni Bu. Ada gangguan sikit. Okay, alright. Okay. Okay. So you can see it here. This is old old guidelines, 2010. But at the 2010, they start looking for the compression fractions more than 60%. Okay, it's pathway 1, we have pathway 1, and we have the pathway 2, and then we look at this compression fraction percentage, and then we look in terms of this cerebral perfusion pressure. Okay, and then what we notice is that if you provide the chest compression fraction more than 60%, then the outcome is better, whereby the cerebral perfusion also better, cerebral central resuscitation also is better. Okay, means that sustained chest compression, there's the second interruption at any point. So it means that minimize interruption, meaning you should not stop chest compression more than 10 seconds is very, very crucial. So therefore, every time you stop the chest compressions more than 10 seconds, actually you increase the mortality up to 20%. Okay, so that's one issue. But in 2020, it's not only about stopping the chest compression more than 10 seconds, but the question now is that how much compression that you should provide. Okay, so therefore, when they did the study, they found out that if your chest compression fraction is more than 80%, okay, like this information, actually your outcome is very good. Okay, your outcome is very good. Okay, so it's not only about that stopping the chest compression more than 10 seconds, it's also about do not frequently stop the chest compression, also a important point. Okay, boleh faham bu Pertama, minimize interruptions, meaning do not stop chest compression more than 10 seconds, very important, number one. Number two, frequently stop chest compression, also not good. Okay, because we aim for chest compression fraction more than 80%. Okay, all right. So like this study showing that the importance of the chest compression more than 80%. But how we going to do it? Okay, now the question is that now bagaimana during the chest compression? So one of the suggestion is the pre-charging defibrillator. Okay, so usually what happened? Okay. Someone unconscious, okay, and then you hello, are you okay? No response. Then this patient is unresponsive, and you activate the code blue, and then simultaneously you check the breathing and pulse. You found out that patient has no breathing and patient has no pulse. Therefore, you start chest compressions. Okay, so you compress the T, then you ventilate to 30 chest compression to ventilation till the defib arrive. Okay, then you connect, you on, you select, and then analyze the rhythm, shock of rhythm, and you resume compressions, and then you start the set the volume, for example 200 joules for bivasic, put the gel, put the pedal, and then charging, and then all clear, and you shock the patient and resume compression. So this is what we usually do. So in other words, that if you look at this technique, we stop chest compression twice. Number one, for us to analyze the rhythm, and number two is to shock the patient. Okay, so the current recommendation is that we analyze and shock the patient at the same time. Okay, so how we going to do it? By performing, we call it pre-charging defibrillator. Okay, so means that when you when patient the defibrillator is already connected. Okay, so we immediately charge the defibrillators. Okay, so connect, on, select 200 joules. Okay, put the gels and put the pad wherever, so that hands hands off. Okay, hands off. Okay, look at the rhythm and clear, shock patient, and resume compression. Okay, so
my apologize, Prof. Yeah. The time 5 minutes left.
Oh, okay, right. Okay, thank you. Okay, so it means that rather than 2 times stopping the for defibrillation, we only stop 1. So by doing this, we improve the chest compression fractions. Okay, so all right, good. And next is defibrillations. What it mean by defibrillations? Okay, this is a question. Who want to answer this? Rapid defibrillations, according to AAS 2020, it means shock to be delivered within 5 minutes of the victim collapse. Agree or not? So jawapannya tidak agree. Yes, correct. Okay. So the recommendation is that once you have the you need to deliver the shock or the defibrillation within 4 minutes. Okay, rather than 5 minutes. Okay. B, shock to be delivered within 45 seconds of defibrillator arrival. The answer is yes. Okay, so once you have the defib machines, you need to administer the shock within 45 seconds of the defibrillator arrival. Okay, so the definition is change from early defibrillation become rapid defibrillation. Okay, so you need to administer within the four minutes, and then once you have it, immediately the focus will be the shocking the rhythm rather than the compressions. Okay, before defib is compressions. Once you have this defib, the defibrillation is the priority. Okay. Okay, I think adrenaline now is very clear. For those shockable rhythm, we administer after second shock. Then for non-shockable rhythm, as soon as possible. Okay, so the other changes is a post-cardiac arrest care. So this is the usual post-cardiac arrest care, Bu. Yang ini yang biasa. Once patient has ROAC, immediately you need to optimize the oxygenation, ventilation, circulation, and also the brain function by providing the temperature targeted management. But currently, we also need to consider about the seizures post-resusc care, because there are two types of seizures, non-convulsive and also the convulsive seizures. Therefore, I actually recommend for the continuous EEG monitoring, and then the providing the anti-epileptic if patient has a seizures. And the other one is that in order for us to improve further our management, it means that if you're not providing neuroprognostications, people we will be going on managing the patient, and that is not cost effective, whereby sometimes the patient may be suitable for we call it this tissue donations. Okay, so now if someone patient is ROC is comatose, okay, we need to perform the multimodal neuroprognostication minimum after 72 hours after patient has pneumotomia, and this is the guidelines that how we're going to do it, and then how we're going to diagnose the brain death. Okay, therefore we can stop the compressions. Okay, and last is when can you stop chest compressions. So basically nowadays with the availability of the ETCO2, with the ETCO2, actually the decision to stop chest compression become more objectively rather than based on the assumptions. Okay, unless you are very good in toxic, it's fair. But nowadays with the ETCO2, for example, like in this case, if you are providing these chest compressions and you are already addressing the reversible causes, okay, you're already managing the reversible causes, and then patient is medically is futile, the outcome is very poor, and then the asystole start from that, then you can use the ETCO2 to guide you when to stop the chest compressions. Okay, so when you find out that even by providing high quality chest compressions more than 20 minutes after a systole, the entitled CO2 persistently less than 20 millimeter mercury, then you can decide to terminate the resuscitations. Okay, I think by that I think I cover almost the whole important points in terms of the in hospital management, particularly in the sudden cardiac arrest patients, or when you are providing the resuscitation for the sudden cardiac arrest. So once again, please focus on witness arrest. Please focus with your emergency response team. Please focus on your high quality CPR. Okay, and then ensure that persistently providing high quality CPR. And number 3, early recognition, the shockable rhythm, and rapidly providing the defibrillations. Okay, I hope that by doing this, by improving all this, we can improve the outcome or survival of cardiac arrest patient in our hospital. Thank you very much for listening. Terima kasih banyak-banyak. Yes. Tak dengar, Bu? Ibu kena unmute.
Okay, thank you, Bro. My apologize, sudah tua, Bro.
Okay, sorry for taking a bit longer time.
Okay, Prof, you have 3 3 question. 1, 2,
Okay.
3, 4. Round
Oh,
4
okay.
question. Is it okay?
Okay. Boleh, boleh, Bu.
Okay. From Nita Nur Azizah. Okay. Should pediatric patient with acute kidney injury occur if there is a medical emergency? CPR and fluid resuscitation should be performed.
Oh, okay. Now, when you mention about the acute kidney injury, we need to make sure that what do you mean? Okay.
Yes,
That is very, very important, because when patient come to the emergency department, we're not sure whether it's already occurred or not. But of course, definitely that we know that acute kidney injuries can be because of the pre-renal, can be renal, and also the post-renals. Okay, so it's very, very important when for this patient that come to the emergency department, especially with the hypotension, for example, we need to ask ourselves whether it's a pre-renal or is because of the renal. In elderly, usually is post-renal need to be need to be considered. For example, like for elderly usually, or the elderly usually if I'm not sure, I just put the CBD and see whether there is a urine or not. If there is no urine, it means it's a acute kidney injuries. And if you're unable to get into your CBD, maybe the patient has an obstructive uropathy. Okay. Now, for those patients with pre-renal failure, okay, acute kidney injuries because of pre-renal issues, hypotension, then you need to manage the pre-renal issues. Okay, so if patient is hypotension, for example, patient is severe dehydration, then you need to give the fluids. Okay, then there is there is no fixed rule here. So what is the cause of the AKI? Is it pre-renal or is it because of the renal? Okay, so definitely if you confirm that this is because of the renal, you need to know also what is the cause of the renal. Is it because of the drugs? For example, sometimes drugs can cause the acute tubular necrosis, for example, especially have the rhabdomyolysis that could cause the AKI. So once again, AKI is a manifestations of major problems. You need to identify what is the major problems, and then you need to reverse this AKI so that they won't end up with the chronic renal failure.
Okay. Prof, my apologize, Prof. Can you stop your PPT, Prof?
Stop what?
Stop the PPT.
Oh, point. Oh, okay. Oh, stop. sorry.
Yes.
Okay, sorry. Okay. Oh,
okay.
Okay, sorry, Bu.
No, bro. We continue with the second question. Is does the code blue can apply to the emergency room, ICU, and operation theater?
Okay. Now the question is good question. Okay. So the answer is that it's about your manpower. Okay? It's about your manpower. Do you have enough manpower at your department? Okay, when we call it about manpower, we discuss in terms of capacity and also the capabilities. Okay, so if your department, your emergency department or your ICU, you have this capacity and capability, you do not need the code blue. Honestly, you know why you need the code blue, because you have a staff that can become the airway officer. You have a staff to give the drugs. You have a staff that can give the team leaders. Okay, but if you don't have this, definitely you need the code blue team. For example, like my department. Okay, though we are a department, but our staff is limited. We spare our red zone. Our red zone is mainly for the team-based management. It's only team-based management. Means if there is a red zone, we need to activate the team, because we need the team, because we don't have the manpower. So in patient cardiac arrest, even we also activate the code blue, because we need staff, number one. Number two, we need also the capable person. Okay, sometimes intubation is also not very easy. Sometimes patient is obese, so you may also need the anesthesia standby with you, for example. Okay, so the answer is this depends on your your capability and your capacities. If you have enough, means you have the trained personnel, you have the equipment. Okay, for example, at KPJ, if you got the code blue, emergency department has to bring the CPR mechanical device. ICU have to bring the video laryngoscope. So everybody have to bring the equipment to the site of the event. Okay, because not all wards, each ward they don't have this. Okay, even sometimes the defibrillator also share by the wings. Okay, it's not every place you have the defibrillator, so you can share. So when you sharing, you need a team. Therefore, you need the code blue or whatever you want. Okay, so that's the answer.
Okay. The third answer, Prof.
Yeah, yeah.
I just want to ask, what is the aberrance mean or imaging characteristic in the ECG interpretation? What is the difference between SVT with PSVT?
Okay, usually when the confusions of the broad complex tachycardia. Okay, when you see the broad complex tachycardias, so the confusion is that whether VT or SVT with aberrancies. Okay, bukan SVT aberrancy with SVT. So the confusion is SVT with aberrancy and also the VT. Why? Because the ECG looks similar. So, you see the white complex. Why you can call it SVT with aberrancies? Because the SVT has right bundle branch block. So when you have the bundle branch block, therefore your interventricular conduction delay, you will have the interventricular conduction delay. That's why it's become the problem. So if your patient is unconscious, unresponsive, no breathing, no pulse, if you still broad complex, just treat as a VT. Okay, just treat as VT. If you have patient with unstable tachyarrhythmias, meaning that patient has a heart rate more than 150s, and patient is altered mentation, patient has short of breath, patient has chest pain, patient has shock, patient has hypotension, and then when you look at the ECG is broad complex, doesn't matter SVT, the aberrancy or VT, you just synchronize cardioversions. But if your patient present to you with a stable tachyarrhythmias, okay, stable tachyarrhythmias, now what do you think about this? Okay, so some people, they make it easy. Any broad VT is a VT, doesn't matter. Any stable white complex is the VT. So treatment is amidrones, okay, amidrone infusion. But if you think that this patient is SVT with aberrancy, for example, in young patients, young patient or patient with a congenital heart disease, but okay, so the guidelines advocate to use of the adenosine in this case. So you can give adenosine 6 milligram, 12 milligram, 12 milligram. If it does not improve, then you give the amiodarone, and your diagnosis is VT. And at the end of the day, to properly differentiate between SVT, the aberrancy, and VT is electrophysiological study.
Okay. Would you like to answer the question for your topic yesterday, Bro?
Can. No.
Okay.
Can.
Ini agak panjang, Prof.
Okay.
She would like to know about your idea.
Oh, okay.
Okay. Dear Prof. Rasidi, what is Prof. Rasidi's opinion? If the emergency management system is standardized by WHO, is this necessary? And a simple example is the use of emergency telephone numbers. In Indonesia, using 119, 118, and others. And others country using 911, in Malaysia 999, or maybe other numbers. This is to prevent confusion, to activate the emergency code when we are visiting other countries. Maybe this kind of scientific meeting can initiate standardization of more complex emergency management system.
Okay,
gimana nih
wow,
pendapat?
very good. Okay, so there are two questions, and I'm going to answer the first questions. Yeah. So the first question is about standardization by the WHO. What I can say is this: you know best about your house. Maksudnya, you lagi tahu pasal rumah you. is WHO know about your house? No, they don't. You know better. Okay, so the WHO should not dictate your house. Okay, I'm not saying they are wrong. So, but at the end of the day, you know better about your capacities and your capabilities. You know your resources, your resource matrix. Okay, so whether you want to apply Anglo-American, you want to apply the Franco-German, you want hybrid, you decide. You decide. You as the Bandung population or the Indonesian population, you have to decide what is your best. There is no such thing as good one. Sometimes it's trial and error. I give you example. For example, how the Singapore try to improve the pre-hospital care. Now in Singapore, the pre-hospital care is not run by the Ministry of Health. Di Indonesia pun you can take who should run the pre-hospital care, whether it should run by the Minister of Health or it should run by others. In Singapore, the pre-hospital care is run by the civil defense. For example, in US, the pre-hospital is run by the transportation department. See, because it is about the budget, you know, it is something different. In Malaysia, it runs by the Minister of Health. That's why sometimes the Minister of Health cannot focus in hospital management and also the hospital management. But nowadays, that in Malaysia, that people start understanding about the importance of the pre-hospital management. Therefore, we have these private sectors come in. So now we have also the emergency physician that specialize in the pre-hospital care, try to merge this management. Okay, so it takes time. Even now we want to develop the call, the 999 call. When someone collapse, call this 99, and then we be able to deliver the message for them what to do. Okay, open the airway, something like that. So it's not it's a simple process. It's a long process, and there are many people that get involved. Okay, so but you need to sit down together with all the parties, because it's not only about manpower, it's about money. Money, it's about money, it's about the system, it's about the space. Ambulance bukannya murah, Bu, ya. Kalau ambulance yang kita panggil level A tu, yang ada dipanggil yang ada yang boleh buat telemedicine is very expensive, 1 million, Bu. Sekarang ni pula people talking about the infectious ambulance yang takut COVID, so it becomes more expensive. Okay, so I don't have the proper answers, but for me, you know better about your house. But if you think that your WHO recommendation is suitable with your house, then you go ahead. But if you think it's not suitable, you better stand up and fight for your country. Okay, because people can ask anything, but at the end of the day, you yang suffer. Okay, your budget or whatever. Okay, and then whether you want to do standalone, whether you want to combine with other people. So that's the reason also we have this one-stop centers. So we just manage ambulance that available, private one, NGO ambulance, GO ambulance, private ambulance. So we are sharing information, and then we come up with the training. Okay, go slowly, rather than you just want to follow other people. Okay, I still believe that custom made is better rather than we adopt people's. Okay, though it look impressive, but sometimes it's just not suitable. It's just like macam Aceh, Bu, ya. Orang Mak Saleh datang bawa burger. Orang Aceh mana tahu makan burger, Bu? Memang burger sedap. Saya pun suka makan burger, king burger. But if the people memang tak biasa makan burger, for example my father, Bu, my father tak makan burger, so you bagi burger pun dia tak boleh makan. Okay, because they do not know about our cultures, our system. Okay, so there's the first answers. The second answer tadi apa, Bu, ya? Aduh, dah banyak cakap lupa. Apa tadi? Standardization numbers, ya? Standardization numbers. Okay. Now, di Malaysia dulu, Bu, ya. Di Malaysia dulu kita numbers banyak, Bu, ya. Kita ada 994, kita ada 994 bomber, kita ada 999 MOH, kita ada 991 civil defense. You know what happened, Bu, ya? So, the problem is that the line, Bu, ya. So one day, Bu, saya nak cerita. This is a quite funny story, ya. So one day dekat this one state of Malaysia tu, Kota Baru tu, Kota Baru tu ada, there is a place called Teliput. And Kelantan, yeah. And then the Terengganu also there is a place named Teliput, yeah. So one day this a snake enter this Kelantan house lah, Teliput Kelantan house. So they call the 991. You know, when they call 991, the Terengganu Civil Defence take the phone, bu, tak tahu macam mana, bu, because the 991 dia sudah cross country. And then so they share the information, Teliput lah, okay lah, because both places ada Teliput. So this person yang dekat Teliput tu keep waiting for the civil defence, and this civil defence pergi ke Teliput, try to find the house, tak jumpa, bu. Why? Because this is the issues. When you use this number ni, so dia akan banyak numbers tu jadi banyak confusion. And the other thing is that sometimes the public need to call 994 pun call, 991 pun call, 999 pun call. So jadi problem. Okay. So therefore, Malaysia come up with this one numbers. We call this medical emergency response system, which is only 999. So meaning that when people call 999, so they go to the operators, and then from that operator will ask nak call siapa, nak pukul bomba ke, nak pukul polis ke, and then from that if they say that it's hospital, then we go to the one stop center. And that's one center that akan manage hantar ambulance from where. Okay. So, but certain things sometimes is good to be international. For example, disaster code. For example, okay, disaster code. Maksud apa ni di Western countries they use black. Yeah, they use black. Black mean death. Yeah. Di Malaysia kita guna putih, bu. I tak tahu di Indonesia gunakan putih ataupun hitam. But kita orang Muslim bila mati pakai putih. So this one kalau
hitam, bro.
You pun hitam juga, okay.
Iya. So, kalau bersedih pakai warna hitam.
Kami kalau mati is putih lah. So the problem kalau kami pakai putih, this Westerner come to assist us, they will get confused because they found out tak ada hitam. Or it's become putih. Okay. So in other words, that certain code sometimes is good to be internationalized, but sometimes certain codes is not necessary. Okay. So once again, you decide. You decide what is your best for your countries. Kalau you nak gunakan US punya, macam mana you call, how US want to help you. Okay, something like that. Because sometimes when the number tu sama, dia boleh macam cross reference, bu. So I don't know. Maybe you can ask the IT the issue about the cross reference. For example, kalau you use our number 99, I takut when you call when someone call, that 999 will go to Malaysia. I tak tahu macam mana. So there must be a reason behind it. But so far in Malaysia, we are happy using the 999.
Okay, Prof. One question.
Lagi.
Last.
Boleh.
She work in healthcare community, like klinik kesehatan.
Yeah.
Okay. It's far from hospital and apa, Prof? Jauh dari hospital, macam gitu. Okay. If you want to do code blue, do you have to be with a doctor? Because I work in a community health center. The doctor is not in the emergency room 24 hours a day. Thanks. Tak ada dokter 24 jam di sana, dokter.
Okay. I can say ni, kadang-kadang kalau apa macam ni, bu, pepatah kata kalau tiada akar, rotan pun berguna, bu, ya. Betul, bu, ya. Kadang-kadang kalau tak ada doktor, nurse pun boleh juga lah. Once again is how you perceive it, how you define the concept. Whether you can say that if you don't have certain things, you don't have to do it. Or what you say that though that you don't have, you still do it. Hopefully some percentage may survive. Boleh faham tak, bu, ya? Maksudnya kalau tiada tinggalkan. Itu satu konsep. Kalau tiada tinggalkan. Macam for example, tak ada doktor tak payah buat. Or yes, tak ada doctors but we still do. Because not all patients require ACLS. Not all patients require advanced cardiovascular support. maybe some of your some patient, maybe your patient just need the basic life support, meaning chest compress, ventilate, you shock, then they survive RAC, then you hantar. Okay, so but when we're talking about SLS, Bu, it's not belongs to doctors only. Okay, saya nak semua nursing sini faham, khusus SLS, khusus advanced cadre support is not only for doctors. Okay, SLS is for everybody. Everybody that want to improve themselves and then manage patients, they can join this program. Okay, and then saya sendiri cakap, Bu, kalau saya tak ada ACLS, ibu ada ACLS, when someone calls, ibu lead the group. It's not me that lead the group. It's why? Because you are trained. Okay, so it's a matter about the training, the training and then recognition lah. Kalau for example tadi nurse tadi tu dia rasa memang doktor tak ada, why not you, okay, memang minta doktor tak dapat, why don't you improve yourself, you show them that you going train, you dah lulus, and then you can go further advance, become the trainer, and then you ask lah, if someone collapse, boleh dah I jadi leader? At least Bu, you boleh recognize shock algorithm, boleh shock. Kalau tak ada pakai manual defibrillator, boleh pakai AED, automated external defibrillators, and then maybe ask, can I should be adrenaline? Okay, kalau dia kata okay sampai situ saja boleh buat, you try lah, maybe some of the patient will survive. Okay, so maksudnya kalau tak boleh buat semua, janganlah tinggal semua. Okay, okay, so tiada, itulah maksud saya, Bu, tiada akar, rotan pun.
Terbalik.
Ya,
tidak ada rotan akar pun.
Okey, tiada rotan akar pun. So kalau kita tak boleh selamatkan 10 orang, 1 orang 2 orang pun sudahlah, Bu. Itu yang penting. Rasulullah SAW bersabda dalam surah Al-Maidah ayat 32 ke 36, barang siapa menyelamatkan 1 nyawa, seolah-olah menyelamatkan seluruh nyawa manusia. Kalau kita tak mampu selamatkan 10, 1 pun jadilah. Itu pendapat saya, Bu,
Okay.
Tapi kita jangan duduk diam saja. Kalau if you know the weakness, don't quiet. We need to discuss this further. We need to tell other people so that your responsibilities will pass to other people. Okay? Because you know the deficiencies, you know something, but if people do not listen to you, you sudah lepas lah because you dah usaha. Tapi diorang tak bagi, so you tak boleh buat apa-apa. Okay?
Okay.
Kesian tu, kesian ni. Sama juga di Malaysia pun. Ya. Tapi di sini mungkin tak nak buat, tapi di Indonesia nak buat tapi tak boleh buat. Di sini boleh buat tapi tak nak buat. Tak ada, guru-guru aja, Bu.
The same problem. Okay, thank you, bro. I think it's the last question, and thank you for your attention in my webinar. Thank you so much. You are sharing knowledge and experience to us. Okay, bye-bye, Prof. Have a nice day.
Okay.
Waalaikumsalam warahmatullahi wabarakatuh. Oke, itu tadi adalah materi daripada Prof. Rasidi. Oh ya, ini summary daripada materi Prof. Rasidi. Summary-nya SCA adalah sudden cardiac arrest, sudden cardiac arrest. The meaning is someone who was collapsed. The meaning is no breathing, no pulse, no response. No, so we will do chest compressions. And in IHCA, yaitu intra-hospital cardiac arrest, survival rate around 20%. For factors is the important thing for us to evaluation of the patient. Early recognition, high quality chest compression, rhythm check, and defibrillation. And chain of survival use EHSA 2020 contain early recognition, activate of emergency response, high quality CPR, defibrillation, post cardiac arrest, and recovery. And high quality CPR is the meaning is push hard, push fast, and allow complete chest recoil, minimize interruption of compression, switch compression provider every 2 minutes and avoid excessive ventilation. Oke, saya rasa itu adalah daripada kesimpulan daripada materi Prof. Rasidi, yaitu SCA atau sudden cardiac arrest adalah orang yang kolaps, ya. Artinya apa? Di sana tidak ada breathing, tidak ada pulse, dan tidak ada respon. Oleh karena itu perlu dilakukan chest compression, ya. Menurut IHC intrahospital cardiac arrest, kalau di dalam hospital itu survive-nya lebih tinggi dibandingkan dengan OHCA atau out hospital cardiac arrest, yaitu sekitar 25% dapat tertolong. Kenapa? Karena ada 4 faktor yang penting dalam intrahospital, yaitu early recognition, yaitu kemudian high quality chest compression, rhythm check, dan ada defibrillation. Kemudian menurut yang digunakan sekarang kita adalah menggunakan AHA 2020, yaitu untuk melihat early recognition, activate of emergency response, high quality CPR, defibrillation, post cardiac arrest, dan recovery. Dan yang terpenting dalam high quality CPR adalah push hard, push fast, low complete chest recoil, minimize interruption, jadi meminimalkan interupsi dalam melakukan kompresi. Kemudian boleh switch yang melakukan kompresi itu setiap 2 menit, karena untuk menjaga high quality CPR. Jadi untuk menghindari kelelahan daripada perawat atau dokternya. Kemudian menghindari excessive ventilation. Ya, saya rasa itu inti daripada materi Prof. Rasidi tadi. Sekarang, no, we continue with master student will present about their thesis in literature review. Pak Yus, it's your time.
Good afternoon, happy international seminar participants. Introduce, my name is Nurafni Hasim. On this happy day, I will present the result of research I did with the title Determinants of Stunting in West Papua. This research is a systematic review resulting from a review of the journals we did. This research departs from the problem we encountered from searching for data presented by World Health Organization and organizations that are directly related to economic conditions that affect the nutritional status of a country. The data we can get from 2020 to 2021, and this data show that there is an urgency in the incidence of malnutrition in the world and Indonesia. The World Health Organization stated that 149 million children under 5 years of age worldwide are experiencing malnutrition, and 45 million of these children are too thin for their age. 45% of these children died from malnutrition. In 2021, according to the Global Nutrition Report, there is a 30.6% incidence of stunting for children under 5 years old in Asia, and 27.4% of children under 5 years of age experiencing stunting in Southeast Asia, meanwhile is in Indonesia. There are 30.2% of stunting incidents for children under 5 years of age. According to the Asian Development Bank in 2021, according to the organization, Indonesia is second worst country with the highest incidence of stunting in Southeast Asia. Currently, the WHO stipulate that the incidence of stunting in country should not exceed 20%. However, Indonesia stipulate that the incidence of stunting in all provinces and districts must not exceed 30%. In West Papua, the incidence of stunting is still very high, exceeding the figure recommended by the government and the World Health Organization. There are very high prevalence death of stunting, namely Arfak Regency, South Sorong Regency, Cembro Regency, Maibrat Regency, Raja Ampat Regency, and Teluk Wandama Regency. Arfak Mountains District in the district that has the highest stunting rate, with West Papua Province with 40,1% stunting incident, and the lowest district in Teluk Wandama District with 31%. However, this figure is still much higher than the recommendation of the Indonesian government and the World Health Organization. We know the stunting will cause a decrease in human quality in the future. Stunting can also describe the state of the economic status of a country, a province, or a district, because in some study, it is also state the incidence of stunting contributes to the incidence of death. Based on the described above, we think that the prevalence of stunting in each province, district, and city is different because various factors between these places might influence it. Papua and West Papua are provinces that experience lower human resource development compared to other areas in Indonesia. We want to know what factor influence the stunting incident in West Papua. As a start, we incident the result of research published previously in the last 5 years, only for 2017 to 2022, where we searched for journals in 5 databases available around the world that specifically discuss stunting in West Papua. The database we are Google Scholar, Base, Scopus, Web of Science, and PubMed. Your process consists of the application of software, FOSS-Viewer, Open Knowledge, maps, and connected papers. We use FOSS-Viewer and Open Knowledge maps to search and collect journal. Next, we connect the journal using the Point Connect Papers application. Next, we analyze this journal using PICO analysis technique. From the search result for this journal, we found 6 journals that specifically discuss stunting in West Papua. The results of the first study, namely from Brilliantita et al. To 2022, found that the factor associated with the incidence of stunting in West Papua were protein and fat intake, parental work, pocket money given by parent to school, carbohydrate intake, parent education, parents' income. Then Eldina Dina De Vries, 2021, explained that a mother's hate history of exclusive breastfeeding and birth weight have a higher probability of stunting in children. Nasrul 21A say that birth weight, egg group mother age, birth spacing, gestational age, mother's education, length, washing hand, immunization status, history of diarrhea, cigarette smoke, export, latent ownership have a significant contribution to the incidence of stunting. Widyastudi et al. Also found another things, namely access to clean water sources and insufficient knowledge about nutrition significant contribution to the incidence of stunting. Ningsi et al. Founded a history of infectious disease, exclusive breastfeeding, immunization status, and history of diarrhea. Also contributes to the incidence of stunting, and the last is the research result of Adianti et al., which state the knowledge of mother in the first 1,000 days of intervention in birth. Parents' education, mother height, father's BMI, place of delivery is very likely to contribute to the incidence of child stunting at less than 5 years. From the analysis of this journal, we try to conclude that their main factor cause stunting in West Papua. There are child factor, parental factor, and external factor. We mean external factor here are other factors that are not from human. Child factor related to stunting are history of experiencing infection disease, intake of carbohydrates, fats, and protein, and the immunization status obtained for the child. In addition, the history of the child ration exclusive breastfeeding is also a determining factor of stunting. On parental factor, such as body mass index, birth spacing, occupation, and income, as well as parental education, gestational age, and place of delivery, as well as mother's knowledge about the first 1,000 days of birth and what nutrition is given or consumed are essential for factors that contribute to stunting. In the children, on the external factor, according to the journal, latent ownership, frequent exposure to cigarette smoke, a healthy lifestyle, and the ability to access clean water significantly affect the incidence of stunting. Therefore, we are conducting a follow-up study on 6 districts in West Papua, which are reported to have the highest stunting incidence, to prove whether the factor also contribute to this incidence of stunting in the district. We hope there are new findings that might be a way to overcome stunting in the district. Thus, as a result of research, we hope that your study can contribute to the development of science, especially pediatric nursing science, and also become an initial reference point for fellow researchers to find a way out of this unfavorable situation. We ask for input from all your friends for the development of this scientific and valuable for the people of Indonesia. Thank you.
Enggak, Ibu Musri sudah Assalamualaikum Ibu Musri.
Universitas Jenderal Ahmad Yani Cimahi akan menjadi hybrid university, di mana mempertahankan kegiatan konvensional belajar mengajar, namun pada saat bersamaan menjadi open university yang memanfaatkan information communication technology dukungan dari Telkom Indonesia.
Dengan ini saya resmikan penerimaan mahasiswa baru Universitas Jenderal Ahmad Yani.
Okay, good afternoon, Dr. Aliana Dewi.
Good afternoon.
Okay, my apologies. It's late around 1 hour. Okay, my apologies, Doctor. Okay, now Dr. Eliana will present about update Code Blue and nursing services. Dr. Eliana is head of Hiperchi and nursing lecturer at Binawan University. Please, Doctor, it's your time.
Okay, thank you. Maybe I'll explain in Indonesia, okay?
Oh, boleh, mangga, Dokter.
Boleh, mangga. Oke, teman-teman, selamat siang. This the last maybe, the last presentation.
Yes.
Sorry, it's too late. Panitia, terima kasih. Saya dapat materi untuk share buat teman-teman tentang update Code Blue in Nursing Services. Ini bukan hal yang baru buat teman-teman. Begitu mungkin kita sedikit mereview apa yang biasa teman-teman lakukan di Saya saat ini sebagai Ketua Umum Hipersi dan saya bekerja di Binawan sebagai Dekan Fakultas Keperawatan dan Kebidanan. Silahkan nanti kalau mau kontak saya nanti ada minta sama panitia. Yang kita perhatikan sebenarnya kalau pada saat Code Blue, ini yang penting bagaimana kita bisa melakukan resusitasi dengan cepat, tepat, dan aman. Karena itu yang paling penting. Bagaimana resusitasi yang kita berikan pada pasien dengan jantung paru, ini yang bergantung pada intervensi yang benar-benar kritis, yang secepat-cepatnya harus dilakukan defibrilasi dan juga bantuan hidup lanjut yang akurat. Pelayanan ini yang memang harus tersedia untuk semua pasien selama 24 jam setiap hari. Makanya di setiap rumah sakit ada tim Code Blue yang didirikan di setiap unit. Karena kalau memang tim itulah nanti yang bergerak untuk di mana di areanya mereka akan ada penempatan yang memang dilakukan di rumah sakit. Nah, ini yang akan dibahas di Code Blue ini. Ada Code Blue, definisi dari Code Blue, alurnya seperti apa, dan resusitasi dari di troli emergency manajemennya seperti apa yang biasa dilakukan di rumah sakit. Nah, definisi dari Code Blue ini menurut Monangi et al. 2018, ini merupakan aktivasi sistem untuk kondisi gawat darurat yang terjadi di rumah sakit, bahkan juga mungkin di institusi kesehatan, di mana pasien bisa mengalami cardiopulmonary arrest yang perlu penanganan segera. Karena time itulah yang paling penting pada saat kita melakukan nanti CPR. Tadi sudah dijelaskan banyak oleh pembicara sebelumnya karena saya dengar juga gitu kan. Nah, untuk definisi yang lain, ini tanda atau sinyal yang digunakan oleh rumah sakit untuk memberitahu seorang yang membutuhkan tindakan resusitasi, yaitu pada pasien yang mengalami henti jantung atau henti nafas. Malah di beberapa rumah sakit mereka akan punya sirine. Jadi sirine itu setiap orang di rumah sakit tahu kalau sirine itu berbunyi, bahwa itu ada code blue yang dilakukan dan juga ada announcement yang akan dilakukan di rumah sakit. Ruang lingkupnya di seluruh lingkungan rumah sakit, bisa di IGD, rawat inap, kamar operasi, ruang intensif, rawat jalan, juga tempat-tempat pemeriksaan penunjang itu ada. Dan biasanya di rumah sakit mereka bagi berdasarkan zona, gitu kan. Tim yang mereka kelola itu beberapa rumah sakit itu ada zona yang apakah nanti yang sejalan, yang dekat, jadi mereka akan menempatkan orang-orangnya yang ada di sana. Nah, untuk tim Code Blue sendiri, ini suatu tim yang dibentuk oleh rumah sakit yang bertugas untuk merespon kondisi Code Blue di dalam area rumah sakit. Timnya terdiri dari siapa? Dari dokter dan perawat. Baik dokter maupun perawat, ini sudah terlatih dalam penanganan kondisi cardiac arrest, respiratory arrest. Jadi untuk pasien-pasien, semua perawat ataupun dokter, mereka biasanya udah punya sertifikat ACLS atau memang penanganan untuk resusitasi yang biasa yang sudah dilakukan. Semua udah mendapatkan pelatihan itu. Ini ada beberapa juga leadernya itu pasti ada dokter, baik dokter jaga atau PPDS gitu. Tergantung rumah sakit itu membentuk timnya seperti apa. Dan juga ada perawat nanti yang sebagai RW atau juga sebagai breathing, nanti yang kompresi siapa, yang defibrilasi siapa. Itu udah pembagian tugasnya itu sudah sangat jelas gitu. Dan juga ada yang kalau menurut Singh et al. Itu tim ini bisa terdiri dari 3 atau 4 anggota. Yang koordinatornya itu memang dokter gitu kan, dan juga dokter jaga dan juga 2 orang perawat. Nah, kalau kita lihat di gambar ini memang yang organisasi yang di rumah sakit untuk pelayanan gawat darurat yang sudah memang mereka settle. Di sini ada 4 orang, mereka paham siapa leadernya, siapa yang melakukan ARW, siapa yang melakukan operasi, ini mereka sudah bentuk dengan di dalam rumah sakit. Sebenarnya Code Blue itu dilakukan. Pasien yang terjadi ventricle fibrillatif, yang terjadi asistol, yang tension pneumotorak kalau dia ada VT, dan juga ada perdarahan gitu, perdarahan di gastrointestinal bleeding yang bisa mengakibatkan PEA pada pasien. Ini kasus-kasus yang biasa dilakukan pada pasien dengan Code Blue. Nah, penilaian apa saja yang biasa dilakukan? Sebenarnya di penilaian primary survey gitu kan, di IGD atau di keadaan gawat darurat, ini ada primary survey yang kita lihat di assessment ABCD, apa tindakan yang biasa dilakukan? Ini O2, IV, dan monitor yang dilakukan. Dan juga ada penilaian yang secondary survey, ini yang dilihat nanti riwayat, tanda vital, pemeriksaan fisik, tindakan treatment apa, ini tergantung nanti apa yang didapatkan. Sedangkan untuk Code Blue sendiri, yang akan dilihat yaitu irama dan nadinya seperti apa gitu. Tindakannya apa? CPR, defibrilasi, atau juga obat-obat epinefrin yang akan diberikan pada pasien. Nah, untuk primary survey ini yang memang benar-benar mengancam jiwa gitu, yang akan di-assess yaitu dari RW, baik itu kepatenan, sekresi, ataupun ada obstruksi gitu kan. Berarti yang harus dilihat ini untuk kita nanti minta bantuan. Sedangkan untuk pernafasan nanti dilihat dari RR, saturasi oksigen, suara nafas, deviasi trachea ada atau tidak gitu. Disinilah nanti akan dilihat apakah pasien itu membutuhkan oksigen ataukah pasien itu harus diintubasi kalau memang dia tidak ada nafas. Dan di sirkulasi nanti dilihat lagi heart rate, tekanan darah, perdarahan, dan juga suhu. Nah, ini tindakan yang bisa dilihat atau nanti pemberian cairan atau juga nanti pemberian obat-obatan yang akan diberikan. Nah, untuk di secondary survey ini pengkajian sistematis yang memang di asesmen yaitu apa? Sign simptomnya bagaimana? Ada alergi atau tidak? Medikasinya seperti apa? Medikasinya apa saja yang sudah diberikan? Pemeriksaan obat-obat yang diberikan yang lalu seperti apa? makanan yang terakhir yang dimakan itu bagaimana dan apa aja kejadian yang ada di pasien. Yang paling penting ini nanti dilihat tanda-tanda vital dan pengkajian head to toe ini yang dilakukan di secondary survey. Untuk yang biasa dilakukan, apakah dilakukan investigasi, diagnosa banding, dan obat-obat apa saja yang akan diberikan pada pasien pada dilakukan secondary survey. Nah, untuk di Code Blue, yang paling penting di Code Blue itu yaitu early CPR dan early defibrilasi. Karena ini paling penting karena keberhasilan. Setiap menit tanpa dilakukan CPR ataupun defibrilasi, ini bisa sampai 10%. Kalau kita lakukan survivalnya ini bisa sampai di 3 menit pertama ini bisa dilihat gitu kan. Nah, untuk alur dari Code Blue itu sendiri seperti apa? Sebenarnya dari alur Code Blue yang pertama pasti akan dilihat cek respon. Ada respon pasien atau tidak gitu kan. Ini tergantung nih ekstensi di negara kita itu beda-beda dengan negara lain. Padahal beberapa kongres untuk emergensi mereka sudah mau menetapkan kode-kode yang sama di semua negara, tapi itu belum ada goalnya karena tadi Prof sebelumnya memang saya pernah ikut di kongres mereka yang untuk emergensi itu belum ditetapkan apa sih kode nomor yang sama untuk semua negara kalau dalam keadaan emergensi. Nah, untuk tidak nafas atau tidak teraba dilihat nih kita pasti CPR itu 30:2. Untuk medis ini yang penting kita harus cek nadi, sedangkan untuk awam tidak perlu cek nadi. Itu karena apa? Yang sekarang ini kalau dulu kalau kita CPR itu kan orang nakes aja yang bisa. Kalau sekarang semua orang itu harus bisa BHD yang ada di lingkungan rumah sakit. Nah, yang paling penting apa? Kita harus panggil bantuan karena ini penting. Tidak mungkin kita melakukan tindakan tanpa ada saksi pada saat kita melakukan tindakan. Nah, untuk fungsi dari kita minta bantuan apa? Selain bantuan dan juga saksi itu penting. Terutama pada pasien-pasien yang sekarang kemarin COVID gitu kan. Alur COVID itu ada beda lagi. Apalagi yang harus kita jangan sekali-kali dilakukan mode-to-mode udah nggak boleh lagi. Dan ini juga harus ditutup pada saat kita melakukan pada pasien COVID. Dan juga dipastiin kalau pada pasien COVID yang kita lakukan kemarin itu harus kita benar-benar standar precaution kita, aman diri kita itu penting banget gitu. Karena itu berbeda. Ini yang paling penting yang harus kita lihat tanda yang kapan pasien itu akan dilakukan henti jantung, dilakukan kompresi kalau memang dia tidak ada nadi, dia harus dikompresi. Kalau dia tidak ada nafas, harus dicek dulu karotisnya ada atau tidak. Nah, ini yang paling penting untuk evaluasi RJP tiap 2 menit. Raba nadi karotis pada awam tidak perlu. Sedangkan ini untuk pada saat teknik pelaksanaan CPR, sebelum Oktober 2010 gitu kan, itu ABC, airway, breathing, lihat look, listen and feel, sirkulasi CPR dan defibrilasi. Tadi dari Prof pembicara sebelumnya dia udah jelaskan sangat jelas. Dan setelah tahun 2015 itu CAB sama defibrilasi. Nah, pada saat COVID mulai April 2020, ini yang paling penting yaitu safety. Safety dulu dan utamakan personal protective equipment. Jadi yang menolong itu harus pakai protektif terlebih dahulu. Tidak langsung melakukan CPR gitu. Nah, ini yang berbeda yang dilakukan pada pasca pandemi, saat pandemi. Nah, ini pada saat pandemi ini yang kita pakai nih equipment ini yang memang benar-benar yang harus kita lakukan. Kita pakai gown, pakai mask, pakai Google segala macam. Nah, ini alur sebenarnya, alur yang CPR yang dilakukan tadi saya lihat juga dokternya udah jelaskan dengan jelas. Yang paling ini pada saat COVID harus pakai personal protective equipment terlebih dahulu gitu kan. Kalau dia nanti ada ini udah dipakai, baru nanti lihat nggak respon, baru nanti kita lakukan CPR sampai nanti benar-benar kita lakukan CPR nanti tiap 30:2, tiap 2 menit nanti kita lihat respon gitu kan. Nanti disiapin juga nih AED kalau memang udah lihat, kalau dia nanti apakah perlu dilakukan shock ataukah tidak. Tergantung nanti irama nadinya seperti apa. Nah, yang pastikan sebenarnya harus yang paling penting yaitu pastikan keamanan penolong dan keamanan pasien. Itu yang paling penting. Dan untuk orang awam hanya melakukan CPR gitu. Nah, ini yang paling penting, lihat dulu danger, lingkungan seperti apa, responnya, minta tolong, sirkulasi ada atau tidak, airway pasien ada gangguan atau tidak, dan kita lakukan breathing. Nah, ini kasus-kasus yang kalau kita melakukan pada pasien-pasien dengan VF, gitu kan, VF, ini memang harus dilakukan pemberian defibrilasi, gitu kan, defibrilasi. Nah, dia ada pulse, dan juga dipastikan harus ada pulse-nya. Kalau misalkan dia tidak ada pulse, asistol, atau dia ada PEA, ini tidak akan dilakukan defibrilasi, tetapi dia akan dilakukan CPR. Nah, ini code blue algorithm yang memang dipakai, gitu kan. Ini untuk ada pulse VT atau VF, dilakukan shockable, lihat nanti, diberikan epinephrine, dilihat apakah perlu lagi dicek lagi 2 menit. Kalau dia asistol, berarti dia harus dilakukan CPR, nanti diberikan obat-obatan. Untuk pemberian defibrilasi, baik VT atau VF, ini 2 kali sebelum epinephrine diberikan. Pemberian epinephrine itu 1 mg akan diulang tiap 4 menit. Nah, sebenarnya yang paling ideal gitu kan, ini berdasarkan American Heart Association, memang paling ideal itu ada 6 posisi pada saat kita melakukan code blue. Yang pertama itu sebagai airway itu siapa, kompresi itu siapa, yang nanti melakukan defibrilasi siapa. Di sini ada leadernya dan juga ada orang medikasi yang akan memberikan nanti mempersiapkan obat-obat apa saja yang akan diberikan, dan ini ada timer. Ada orang yang melihat, ada petugas yang akan mengecek sudah berapa lama CPR itu dilakukan. Jadi ini posisi yang paling direkomendasikan oleh AHA untuk pada saat melakukan CPR gitu. Nah, untuk sistem transport itu penting. Selesai kita melakukan CPR berhasil, ini transportasi dari tempat kejadian akan dimasukkan ke ICU, itu benar-benar harus orang yang memang capable untuk melakukan itu. Nah, ini yang paling penting lagi nanti perawatan post cardiac arrest. Perawatan post cardiac arrest, manajemen cardiac arrest itu harus paham setiap perawat yang ada di ICU, itu terutama yang pasien yang sudah dilakukan berhasil setelah cardiac arrest, apa saja yang harus mereka lakukan. Manajemen cardiac arrest, suhu harus di bawah 36 derajat, minimal 24 jam, berarti harus dipasang itu blanket roll di pasien, diatur suhu tubuh pasien. MAP tidak boleh di bawah 70 mm Hg, berarti obat-obat vasoaktif akan diberikan pada pasien. Dan ini akan dikontrol supaya melihat nanti keberhasilan untuk pasien-pasien pasca cardiac arrest seperti apa. Tetapi lihat juga berapa lama cardiac arrest itu dilakukan, karena itu juga yang menentukan, faktor penentu pasien itu bisa berhasil melewati itu atau tidak. Nah, sekarang untuk di trolley management yang memang diatur, yang berdasarkan AHA, untuk equipment apa saja yang ditaruh di sana. Nah, ini yang dilihat nanti regulasi pengelolaan dari troli dan respon time. Karena ini paling penting yang harus diperhatikan. Nah, di regulasi ini troli itu harus minimal. Troli itu harus minimal memuat alat-alat airway, breathing, sirkulasi untuk basic sampai yang advance. Jadi itu yang harus dilihat. Penataan laci juga harus ragam, yang memuat baik airway, breathing, sirkulasi, obat-obat yang harus diberikan. Isi dan letak dari troli itu harus ditetapkan dan diperiksa secara berkala. Tempat penyimpanan troli, resusitasi juga harus mudah dijangkau. Alat dan obat yang ada di troli harus selalu segera diganti jika digunakan. Jadi pada saat itu sudah digunakan, kita harus cek, dimasukin kembali. Jangan nanti nunggu kalau ini nanti telat, karena namanya emergency kapanpun bisa terjadi. Nah, untuk regulasi juga harus jelas gitu. Regulasi harus jelas, ini juga karena tuntutan akreditasi. Bagaimana pengelolaan asuhan pasien tentang pelayanan resusitasi itu jelas banget. Penetapan daftar obat dan obat-obat emergensi yang berlaku di rumah sakit itu juga harus dilihat. Dan juga ada terkunci dengan sistem penomoran yang mudah dibuka di troli ini, yang mudah dibuka dan semua orang bisa paham. Malah kalau di di salah satu rumah sakit di Indonesia ini, kalau ada di ruang yang obat-obat yang high alert itu mereka ada alarmnya. Jadi kalau obat high alert itu ada yang buka, itu ketahuan siapa yang buka obat-obat high alert gitu kan. Nah, untuk kelengkapan troli dan nomor seri pengunci juga dicek secara berkala. Nah, ini harus dicek bersamaan dengan farmasi petugas ruangan gitu. Ada beberapa rumah sakit yang memang farmasinya ada di sana. Jadi kalau di rumah sakit yang memang mereka tersentral, maksudnya ICU, ICCU, OK, gitu mereka dalam satu floor, mereka akan ada orang farmasi di sana yang akan mengecek. Dan juga didokumentasikan semua proses dan juga harus dikontrol banget suhu, karena ada obat-obat yang memang dalam keadaan suhu itu nggak boleh, kalau dia nanti dikasih suhu yang ini rusak obatnya. Jadi itu memang harus dikontrol gitu kan. Dan daftar obat juga harus tercantum di troli beserta expire-nya kapan, itu harus dilihat. Alat dan obat harus siap pakai kapanpun dibutuhkan. Kalau dia dibagi menjadi zona, gitu kan? Kalau dia dibagi menjadi zona, oh yang ruang rawat di zona ini, ruang rawat inap di zona ini, untuk kamar-kamar intensif di zona yang mana? Kalau mereka dibagi menjadi zona, itu dalam satu koordinator zona itu harus punya troli emergensi sendiri untuk resusitasi. Dan respon time itu paling penting. Respon time itu kurang dari 5 menit. Gitu. Karena kalau dia udah lebih dari 5 menit, ya itu akan susah gitu kan. Jadi itu karena keberhasilan kita melakukan code blue itu yang paling penting, waktu yang harus dilihat. Nah, ini untuk penataan alat dan obat di troli. Yang di laci atas ini biasanya obat-obatan nih. Obat-obatan, penataan itu yang bisa dilihat obat-obat emergensi, dan ini ada ditulis obatnya di bagian atas untuk troli emergensi, dan ini ada list obat-obat yang ada gitu kan, yang ada di troli atas. Sedangkan di laci bawah, di laci nomor 1 ini ARW nih, ARW dengan berbagai macam ukuran gitu kan yang memang ada. Ini ada gagang laringoskop, introducer, pipa endotracheal, nomornya ada di sana. Ada kateter juga, ada siring, ada semua ini ada di laci nomor 1 dan itu ada listnya. Jadi setiap orang tahu di laci nomor 1 itu apa saja yang tersedia. Sedangkan untuk yang di laci nomor 2 atau di samping ini yang ada semuanya dibuat, ada dressing pack gitu kan, ada IV kanul, nomornya dari IV kanul atau IV kateter itu ada nomornya, siring dengan berbagai nomor, ada jarum di sana gitu kan, ada untuk kalau misalkan dia ada tabung darah untuk pemeriksaan darah, ada urin segala macam. Ini semua dressing ada di sana, sampai untuk pemeriksaan siring untuk analisa gas darah juga ada. Nah, untuk di laci nomor 3 ini yang untuk sirkulasi. Sirkulasi ada cairan. Gitu. Nah, ini di laci nomor 3 cairan semua ada di sana. Di laci nomor 3. Larutan IV semua dengan macam-macam yang kristaloid, koloid itu ada di sana semua. Nah, untuk yang laci 4 ini yang untuk breathing. Jadi ada ambu bag, untuk oksigen terapi, semua ada face mask gitu. Ini ada semua di laci nomor 4. Penataan ini yang memang dibuat, jadi semua orang-orang yang di rumah sakit tahu ini troli emergency isinya apa aja yang ada di sana. Nah, yang paling penting satu lagi apa? Defibrilator. Defibrilator ini harus dilakukan uji fungsi setiap hari. Harus dilakukan uji fungsi dan bukti uji fungsi itu harus dilampirkan. Jadi paham kalau ini defibrilator ini berfungsi. Kapanpun yang melakukan cek juga itu harus tanda tangan. Ini ready. Ini memang udah sesuai gitu kan. Dan fungsi ini tujuannya untuk menjamin kalau energi nanti berapa joule yang akan dikasih itu sesuai. Dan itu harus ada dilampirkan dengan satu pengecekan troli. Oh, ini 30 joule, udah ada tesnya, ini dilakukan. Dan letakkan SPO yang berkaitan dengan buku pengecekan di troli resusitasi. Jadi itu yang memang harus dilakukan dan dicek setiap saat. Jadi terutama di Kotbu ini memang alat orang-orang memang harus benar-benar ready di sana. Ini daftar pustakanya teman-teman, silahkan nanti bisa diambil gitu untuk daftar pustaka yang paling baru untuk American National Red Cross yang 2020. Oke, cukup sekian dari saya, paparan dari saya, share hari ini karena ini bukan hal yang baru buat teman-teman semua.
Oke, terima kasih Ibu. Saya rasa ini menjadi penyegaran bagi para audiens kita. Ibu, kita lanjutkan dengan pertanyaan, boleh?
Boleh, Bu. Boleh, Bu.
Ini Bu, ada
Boleh.
pertanyaan yang cukup menarik buat Dokter Aliana Dewi.
Boleh, Bu.
Dokter, ada pertanyaan. Kalau CPR bagi orang awam tidak boleh ngecek nadi, lalu dengan apa kita tahu kapan kita harus berhenti selain melihat ada tanda-tanda respon dari korban henti jantung? Begitu Bu,
Oke.
terima kasih.
Kalau orang awam kita nggak ngecek nadi. Jadi kalau dia toh nanti kita lakukan, dia dibangunkan, dia udah totonya nggak bangun segala macam, kita akan lakukan CPR untuk orang awam. Karena memang tidak diajarkan itu untuk orang awam. Di orang-orang kalau dulu kan memang yang bisa melakukan itu hanya, kalau sekarang sih memang diajarkan itu. Kalau nanti dia kapan dia ini kan dia akan bangun. Kalau dia udah respon dia akan bangun, gitu intinya. Kadang juga itu yang menjadi apa ya? Kalau di kita ini kan kalau di luar itu anak kecil aja udah diajarin gitu. Kalau di kita kan enggak. Maka yang ada sekarang ini yang orang-orang rumah sakit lah baru diajarin. Satpam, cleaning service, semua kan itu diajarin di rumah sakit. Jadi kapan dia berhenti ya dia akan bangun. Kalau dia udah ada respon dia akan bangun. Gitu.
Oh gitu. Oke, jadi bagi yang bertanya, jadi sampai pasiennya itu sadar seperti itu ya Bu ya, ya dokter ya. Oke. Dokter, ada pertanyaan berikutnya yaitu tentang apakah tim Code Blue itu standby khusus di ruang sendiri atau comot saja petugas sana sini saat dibutuhkan, begitu Bu pertanyaannya.
Gini, kalau di rumah sakit mereka pengalaman saya di rumah sakit kita punya tim Code Blue sendiri. Tim Code Blue itu memang siaga. Kalau di tempat saya memang dia ada di lantai 7 gitu kan. Bukannya comot dan itu memang dia memang diatur jaga gitu kan. Jadi bukan dicomot ntar dia datang. Kalau diatur comot kan susah gitu. Memang ada yang jaga itu untuk di dinas pagi itu siapa, di dinas sore itu siapa. Dan itu memang dilatih semuanya, di ready buat perawatnya maupun dokternya juga itu ada pelatihannya. Dan itu kalau di tempat saya mereka nggak boleh naik lift, harus lari. Dan dihitung waktunya berapa menit mereka akan sampai di tempat kejadian. Itu yang paling jauh di lantai berapa itu berapa menit mereka bisa mencapai itu.
Wah,
Itu mereka hitung
mantap
banget.
Bu. Mantap sekali. Ini next question dokter. Kalau harus ada dokter bagaimana dengan yang rawat inap? Biasanya kadang perawat sendiri yang langsung melakukan Code Blue. Takutnya kalau menunggu dokter jaganya datangnya malah tidak tertolong, pasiennya malah tidak tertolong. Bagaimana itu dokter?
Nah, kalau di ruang rawat inap, kalau kita perawat nih di ruang rawat inap, totonya pasien ARES kan kita nggak mungkin kan kita cek dulu benar nggak dia ARES kan gitu. Kalau kita di ruang rawat inap, kalau memang pas benar ARES kan kita minta tolong. Memang agak berbeda dengan rawat inap. Minta tolong temennya itu akan cari bantuan. Kita pada saat temen itu cari bantuan kita lakukan CPR gitu. Kadang memang di rawat inap itu dokter jaga kan keliling-keliling, nggak standby di satu tempat gitu. Kecuali kalau di rumah sakit itu ada tim Code Blue, tinggal pencet aja tim Code Blue mereka akan datang. Jadi sementara tim Code Blue itu belum datang, perawat boleh aja melakukan CPR, tapi dengan pastikan udah minta bantuan terlebih dahulu sebelum dia melakukan tindakan.
Oke, jadi begitu ya pertanyaan yang dijawab oleh Dokter Aliana. Next question dokter. From Asep Lahudin. Nah, izin bertanya, untuk pasien-pasien post kardiak arrest di IGD, kapan pasien tersebut bisa ditransfer ke ruang intensif? Kondisi apa saja syarat masuk untuk ruang intensif? Harus berapa lama pasien post kardiak arrest diobservasi di IGD?
Oke,
begitu,
sekarang gini, kalau kita post kardiak arrest nih, kan nggak mungkin di CPR kalau memang pasiennya udah benar-benar nggak ada nafas kan dia harus buru-buru diintubasi gitu kan, nggak mungkin di bagging terus kan gitu. Tetapi dilihat juga kalau misalkan udah lama di IGD 30 menit CPR, didorong masuk ke ICU, biasanya tuh pasien nggak bangun-bangun. Biasanya pasien nggak bangun-bangun.
Kelamaan tidurnya ya.
Oke, berhasil intubasi masuk. Jadi masuk ke ICU, nanti pas dibangunin nggak bangun itu pasien di ICU. Jadi waktu itu semakin lama kita melakukan CPR, semakin jelek untuk kondisi pasien. Kenapa seperti itu? Karena bisa saja pada saat kita melakukan CPR, recoil-nya nggak pas, gitu. Recoil nggak pas, oksigen yang masuk ke otak nggak pas, gitu, kurang gitu karena recoilnya belum recoilnya pas, udah digenjot. Itu yang jadi masalah.
Mungkin high
Gitu. Jadi
quality
bukannya
untuk
high quality. Jadi teman-teman yang melakukan, kadang sering sih dari IGD, wah udah bagus nih, udah diintubasi segala macam, dimasukin ke ICU, ntar nyampe di ICU bangun-bangun pasiennya.
itu yang dijelaskan oleh Prof tadi, high quality compression
Iya,
ya. Itu mungkin
benar.
dokter ya. Oke.
Iya betul.
Oke, dokter ini cukup banyak pertanyaan. Mungkin presentation dokter ini cukup menarik. Jadi ini banyak pertanyaan yang diajukan. Next question from Niati. Izin bertanya, kalau manajemen Code Blue di rumah sakit saya rasa tidak perlu dipermasalahkan karena alkes dan nakes sangat lengkap di sana. Tinggal bagaimana kesiapan petugas. Yang saya tanyakan, bagaimana kalau ada kegawat daruratan di tempat umum? Apakah tetap menunggu petugas kesehatan untuk menolongnya? Karena sejak adanya COVID, kejadian seperti ini sering terjadi, yaitu membiarkan korban sambil menunggu petugas datang. Alhasil korban tidak tertolong. Ini yang membedakan pertolongan pada zaman dulu dan zaman sekarang. Sangat berbeda. Begitu, Bu, pertanyaannya.
Oke. Betul. Karena gini, kalau zaman dulu memang kalau ada korban di mall segala macam, kita udah minta tolong, ada saksi, nanti kita kalau memang kita nakes kita langsung ngerjain. Ya kan? Kita langsung kerjain. Itu bisa nanti sampai tunggu bantuan datang. Tetapi memang sekarang ini yang diterapkan itu PPE-nya gitu. Bagaimana kita safety gitu. Jadi orang ini mohon maaf cenderung sekarang ini pasien ini COVID atau bukan. Kan gitu. Karena nggak yang sekarang ini kan malah gejala COVID yang sekarang ini nggak jelas. Gitu.
Tersamarkan ya.
Gejalanya nggak jelas. Jadi orang itu cenderung ya diri masing-masing. Jadi itu. Jadi yang karena gejala COVID yang ada saat ini samar sekali. Jadi kalau teman-teman yakin mau melakukan itu tanpa ada APD yang jelas, ya itu bisa dikerjakan, monggo silahkan gitu kan. Tapi memang saat ini banyak banget yang pingsan di jalan, tidak ada bantuan, itu banyak banget. Karena orang udah ketakutan duluan. Dan juga kita yang nakesnya sendiri juga kadang nggak mau melakukan itu kalau kita nggak bawa APD yang jelas. Karena yang sekarang ini memang standar safety dulu itu yang paling penting gitu.
Oke. Mungkin orang awam yang telah dilatih untuk CPR memungkinkan untuk menolong yang demikian itu, tak dokter?
Bisa. Kalau memang dia dilatih. Sekarang ini kan yang BHD ini semua orang diajarin BHD.
Iya, betul.
Ya, semua orang diajarin BHD. Kalau dia make sure dia bisa melakukan BHD, ya dia mampu, ya boleh-boleh saja gitu. Tetapi tetap harus ada saksi dulu sebelumnya. Jangan dia langsung ini minta bantuan orang, dia saksi, dia melakukan itu gitu. Ada saksinya terlebih. Meskipun kita nakes, kadang kan orang nggak tahu juga kalau di luar negeri itu kalau nggak ada saksi itu bahaya banget gitu. Meskipun kita orang nakes,
Bisa
kalau
dituduh
kita
ya?
melakukan sesuatu nggak ada saksi itu akan bahaya. Kita yang dituduh.
Oke.
Jadi itu yang paling penting sekarang ini gitu.
Oke. Ada dari Santosa. Dokter izin bertanya, kalau untuk valen sabi perlu atau tidak ada di troli emergensi, terutama untuk dewasa? Itu pertanyaannya, dokter.
Valen sabi
Iya, di sini
atau tidak ada di troli. Gini.
Iya.
Gini, sekarang gini, valensa enggak, sekarang tergantung di yang paling penting apa sih obat-obat Code Blue gitu. Epinephrine pasti penting, obat-obat SA itu pasti penting gitu kan. Yang obat paling penting untuk dia kalau di Code Blue itu yang cairan pasti penting, IV cat pasti penting, ETT pasti penting kan, Ambubek pasti penting. Kalau yang lainnya itu nanti bisa dilakukan setelah yang utama itu bisa yang utama itu ada gitu. Jadi bisa saja nanti setelah kita semuanya diatasin, kalau nanti butuh obat itu ya bisa saja disiapkan gitu.
Oke. Masih boleh menjawab pertanyaan, dokter?
Boleh. Boleh, silakan.
Oke, ini ada pertanyaan selanjutnya dari Muhammad Iqbal. Assalamualaikum, izin bertanya dokter, untuk pasien yang ARES di ruangan intensif, apakah tim Code Blue berlari ke ruang intensif atau cukup dokter jaga saja? Gitu.
Kalau di ruang ICU nggak butuh orang ini biasanya. Kalau kita di ICU otomatis kita nggak perlu tim Code Blue karena ada dokter jaganya sendiri di ICU gitu, perawatnya juga memang sudah terlatih di dalamnya. Biasanya kalau di tempat saya nggak ada tim Code Blue masuk ke ICU.
Oh, gitu. Karena di ICU sendiri pelatih Code Blue ya dokter.
Iya nggak ada tim Code Blue masuk ICU, nggak ada.
Oke. Next question dokter.
Boleh.
Dari Oktavina. Assalamualaikum dokter, izin bertanya kalau apakah tim Code Blue ada khusus buat pasien maternitas nggak dokter? Atau untuk umum Code Blue itu?
Kalau Code Blue semua pasien masuk. Nggak ada khusus maternitas. Semua pasien masuk, namanya Code Blue itu kan yang penting Code Blue, pasiennya VTVE, pasiennya ARES gitu kan, asistol itu kan Code Blue. Dia mau maternitas, mau anak, mau ini semua masuk.
Oh gitu. Jadi tidak pilih-pilih. Itu maternitas bukan. Tak boleh macam itu ya dokter ya. Oke. Ini mungkin apa dokter, kalau maternitas mungkin spesial untuk CPR-nya ya dokter, karena dia kan hamil mungkin gitu ya.
Oke.
Kemudian ini ada pertanyaan seterusnya dokter. Wah, banyak pertanyaan. Masih oke Kak dokter?
Boleh.
Masih
oke. Boleh.
Oke.
Boleh.
Dokter, sejauh mana legalitas kita untuk melaksanakan tindakan jika di tempat umum? Di Puskesmas Lendang, izin bertanya Bu, sejauh mana legalitas kita yang melaksanakan tindakan jika di tempat umum? Oh, ini dari Puskesmas Lendang, dokter.
Oke, sekarang gini, yang paling penting kalau dalam, kan di undang-undang ada, di undang-undang dalam keadaan emergensi, tenaga kesehatan yang terlatih boleh melakukan. Di undang-undang ada. Jadi kalau kita memang merasa memang kita tenaga kesehatan terlatih, boleh kita lakukan secara legalitas, tetapi harus ada saksi. Gitu. Harus ada saksi
ya dokter ya.
Harus ada saksi di tempat umum ya. Kita bisa bilang dokter aja, oh saya dokter, pasien ini saya dokter. Nanti yang ada saksi, yang saksinya cari bantuan, kan gitu. Boleh.
Oke.
Karena kita memang ahli di dalamnya gitu, maksudnya kita memang yakin, kita tenaga medis, pas di umum itu ada, memang kita bisa melakukan, yang penting ada nanti sebelum kita melakukan tindakan, udah ada orang yang memang kita melihat kita mau melakukan itu.
Oke. Next dokter. Pertanyaannya
boleh.
Banyak ini dokter, paling banyak kayaknya.
Boleh.
Ini dari Budi dokter.
Boleh.
Dia bertanya. Maaf. Dari Budi bertanya bahwa kita menemukan kardiak arrest dan kita curiga juga ada fraktur koste. Boleh CPR atau tidak, dokter?
Boleh.
Boleh. Pokoknya boleh.
Boleh. Itu mah soal dia fraktur atau apa itu belakangan.
Oh gitu, oke.
Gitu.
Jadi boleh ya Pak Budi bahwa
boleh,
orang
Pak,
fraktur.
Orang kita lagi CPR aja berasa iganya patah dilanjutin kok.
Oke. Seterusnya dokter. Dari Catur Wahyu. Oke. Untuk IGD, apa perlu Code Blue, dokter? Untuk gawat darurat.
IGD. Untuk IGD, kalau memang di IGD itu punya tim yang capable, di IGD yang mereka paham, ya nggak perlu dia ada code blue. Tapi kalau misalkan di IGD-nya sendiri tidak punya tim yang bisa melakukan code blue, ya boleh-boleh saja IGD itu ada tim code blue.
Oke, berarti.
Tapi sebenarnya kalau di IGD harusnya bisa ya. Karena perawat-perawat di IGD kan mereka udah punya BTCLS, ada ENIL, ada yang lain, punya pelatihan yang memang kegawat daruratan, mereka itu mampu harusnya. Jadi sebenarnya di IGD nggak perlu timnya juga nggak apa-apa kalau memang dia yakin semua perawatnya punya pelatihan itu. Tapi kalau yang baru-baru, yang baru lulus nyemplung di IGD sebenarnya baik IGD maupun ICU itu ada requirement, ada persyaratan perawat yang bisa ditempatkan di sana. Yang baru lulus itu nggak boleh di IGD sebenarnya, gitu kan? Karena mereka harus punya pelatihan-pelatihan yang memang kasus-kasus yang tidak terduga itu akan masuk di emergency. Mereka harus bisa mengakses dengan tepat gitu untuk pasien yang masuk ke emergency. Kalau yang baru mereka ditaruh di IGD, mereka nggak bisa akses, repot gitu kan? Jadi kalau di kita sebenarnya tidak ada perawat fresh graduate itu dimasukkan ke emergency ataupun ke ruang ICU.
Ruang-ruang intensif
mereka harus
ya?
di ruangan terlebih dahulu. Tidak ada yang fresh graduate masuk gitu.
Oke. Mereka
Nanti
perlu
bisa
belajar
meninggal
dulu.
semua itu pasien di IGD.
Oke. Selanjutnya dokter, apakah masih oke?
Ya.
Oke.
Masih oke.
Ini audiensnya semangat juga dokter, udah petang nih ya, tapi dia oke semua. Izin
Oke,
bertanya
silakan.
dokter, ada pembatasan penggunaan epinefrin saat resusitasi apa enggak itu dokter?
Pembatasan epinefrin?
Ya.
Epinefrin itu bisa diulang tiap 4 menit. 1 menit, 1 miligram ulang 4 menit. 1 miligram 4 menit. Tiap 4 menit bisa diulang. Sekarang gini, kalau dulu kan escalating dose, dulu itu 1 miligram naik 5 miligram naik 10 miligram dulu seperti itu. Kalau sekarang enggak, 1 miligram diulang 4 menit, 1 miligram diulang 4 menit. Pembatasan sekarang kalau misalkan mohon maaf, udah dikasih itu adrenalin sampai 20 ampul tapi enggak respon kan berarti emang kurang enggak bagus. Kan itu yang harus dilihat. Waktu itu harus dilihat pada saat kita melakukan resusitasi, RJP itu waktu kan penting. Makanya dilihat berapa lama sampai udah 30 menit lewat itu pasti prognose jelek.
Oke. Ya, Pak, jadi di setiap menit boleh diulang tadi ya kata dokter ya. Selanjutnya dokter. Ini dari Mayapada Hospital, yaitu Dirgayuza. Oke. Izin bertanya dokter, perawat boleh didelegasikan untuk intubasi apa enggak? Itu.
Oke. Sekarang gini teman-teman. Hati-hati dengan kata delegasi. Karena kalau delegasi itu nanti yang tanggung jawab teman-teman. Gitu. Tapi kalau kita dikasih mandat itu yang tanggung jawab dokter. Jadi hati-hati dengan kata delegasi. Sebaiknya kalau ada di SOP rumah sakit dibilang didelegasikan perawat melakukan ini mendingan dirubah menjadi mandat. Jadi teman-teman bisa melakukan intubasi tetapi nanti yang tanggung jawab dokternya. Bukan teman-teman. Tetapi harus dipastiin juga yang melakukan intubasi itu memang udah certified, udah punya sertifikat terlebih dahulu, udah punya pelatihan, udah segala macam, bukan coba-coba intubasi. Itu yang paling penting.
Oke, ya. Ternyata delegasi ini jadi panjang ceritanya ya dokter.
Iya.
Oke, selanjutnya dokter. Ini dari Sukabumi dokter, dari Adi Waluyo. Dia berkata, izin bertanya dokter, kalau sekarang kena cek nadi pasien kardiak itu maksimal 5 menit. Kalau dulu kok 10 menit? Gitu dokter. Pertanyaannya.
Waduh, bukan 5 menit. Salah. 5 sampai 10 detik. Bukan 5 menit. 5 menit udah tinggal dibungkus ntar pasiennya. 5 sampai 10 detik. Untuk mengecek arteri karotis. Mungkin salah ya, yang dari Sukabumi, Mas Adi, 5 sampai 10 detik, Mas. bukannya 5 sampai 10 menit.
Oke.
Koreksi.
Nah, seterusnya, dokter, ini dari Vivin Desi. Dia bertanya, setelah tindakan Code Blue, perlu form evaluasi Code Blue apa saja yang dinilai itu, dokter?
Oke, kalau pasien-pasien pasca CPR itu ada 5H, 5T yang harus diobservasi. Ada hipotermi enggak, hipotensi enggak, kan gitu. Hipokalemi gitu kan. Itu yang ada tension pneumotorak, ada trombus atau tidak gitu. Itu ada yang harus dilihat. Jadi itu form itu harus dilihat banget. Pasca CPR itu harus dilihat gitu. Itu harus banget dilihat. Kalau itu ada semua kan berarti totonya ada ini nih. Ada pneumotorak, berarti kan ada fraktur tuh kena tuh pasien kan gitu intinya.
Oke.
Jadi harus benar-benar dilihat.
Oke. Ada lagi yang bertanya, dokter, kalau memang di dalam parunya itu ada tumor, tetap boleh dilakukan CPR, dokter?
CPR?
Sudah
boleh.
Ditemukan?
Apapun tindakan CPR boleh dilakukan.
Oke ya, jadi ibu yang bertanya boleh meskipun di dalamnya ada tumor paru boleh ya. Oke, selanjutnya
Nggak jadi masalah.
dari Rumah Sakit Jantung Binawaloya, dari Ibu Erni Jasmita. Izin bertanya, dokter, apakah ada jurnal atau referensi tentang pemberian epinefrin pada pasien asistul atau PIE yang untuk pemberiannya langsung 2 ampul atau 20 mg tiap 4 menit? Nah, itu pertanyaannya.
Terus terang, saya belum dapat jurnal itu. Yang saya tahu jurnal yang terbaru sendiri di emergency itu 1 mg diulang tiap 4 menit. Kalau zaman dulu ya, zaman baheula gitu kan, zaman baheula sebelum ini kan dulu juga saya ngalamin tuh 1 mg, 5 mg, naik 10 mg dulu kayak gitu tuh. Tapi sekarang udah enggak. 1 mg diulang tiap 4 menit, 1 mg diulang 4 menit. Di AHA itu kayak gitu tuh. Yang untuk AHA yang 2020 juga seperti itu. Jadi nggak ada. Saya belum ketemu. Mungkin teman-teman nanti ketemu, saya boleh minta tuh kalau kayak gitu.
Boleh saling sharing.
Iya.
Oke, saya rasa itu pertanyaan yang terakhir, dokter. Saya rasa memang ini adalah meskipun dokter dapat yang terakhir, tapi atensinya daripada audiens sangat luar biasa, sehingga pertanyaan ke dokter Aliana Dewi juga cukup banyak. Terima kasih dokter atas presentasinya yang luar biasa. Mohon maaf lahir dan batin. Sampai ketemu lagi di lain waktu, dokter.
Oke, sama-sama. Mohon maaf semua. Mudah-mudahan sharing kita sore hari ini bermanfaat untuk semuanya.
Amin, amin. Terima kasih, dokter.
Oke, saya cukup sampai di sini, Bu.
Monggo. Boleh, dokter.
Oke. Saya izin, teman-teman, sukses semuanya. Salam sehat. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Oke. Next kita ke acara berikutnya, yaitu tentang presentasi untuk tesis para mahasiswa dari Master of Nursing Student from Unjani. Waktu saya berikan ke Pak Yuswandi. Silahkan, Pak.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Mental health problems, post-traumatic stress disorder or PTSD, anxiety, depression, post-earthquake in Indonesia, systematic review, and meta-analysis. Background. Earthquakes are ranked first among the deadliest natural disaster and have the greatest destructive effect among all natural disaster. The country of Indonesia, as classified as prone to geological disaster, especially earthquake disaster. Based on data, Central BMKG 2020 recorded earthquake events during the 11 years period of earthquake observation. Earthquakes have consistently been shown to be associated with problems psychosocial condition, post-traumatic stress disorder. After a disaster event, about 15 until 20% of the population will experience mild or moderate mental disorder, which refer to post-traumatic stress disorder, while 3 until 4% will experience severe disorders such as psychosis. Major depression and depression in Indonesia. The study reports that a survey of 136 Lombok earthquake survivors, PTSD factors can occur in all men and women in adulthood regarding work status, location of residence. Anxiety is a fear or worry about something that is not clear and is associated with feels of uncertainty and helplessness. Prolonged anxiety and stress that causes inhibition of activity and decreased physical quality and can cause depression. Based on the 2018 Basic Health Research or CASDAS data, more than 19 million people over the age of 15 experience mental and emotional disorders, and more than 12 million people over the age of 15 experience depression. First study to acknowledge to examine the prevalence and risks and protective factors associated with symptoms of PTSD, depression, anxiety, and other mental disorder among survivors of the 2012 and 2022 earthquakes in Indonesia. The results primarily showed a high prevalence of PTSD, depression, anxiety symptoms in all groups considered. Methods. The following study characteristic and outcome research were recorded: author names, years of publication, country where data was collected, date of collection, number of months post-earthquake, type of evaluation, use questionnaires, clinical interview, etc. Simple characteristic, prevalence of symptom of evaluated disorder or PTSD, risks and protective factors reported, and principal finding in the instance of missing or incomplete data. This is the table of the theories. You can see in this here. Then this is which is the journal that I analyze for my thesis. That's all. Thank you for the attention. Assalamualaikum warahmatullahi wabarakatuh.
Okay, next.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam
Good morning, ladies and gentlemen. First of all, let me introduce myself. My name is Harketi for University of General Ahmad Yani, West Java, Indonesia. On this opportunity, I would like to leave the presentations about the influence of hospital management, information systems, and nursing care on applications of observations in event previties. The influence of hospital management information systems and nursing care on application of observations and event previties. Because healthcare associated infections are in after abbreviated as highest are infections that occur in clients during treatments in hospital and other healthcare facilities. One form of applications is through service systems by utilizing information technology through the use of computer-based information system. Research boards. Knowing the effect of hospital management information systems and nursing care on the implementations of observations and previous events. Literature review. Number 1, titles. Comprehensions of the effect of electronics and people-based surveillance systems on the recordings and detection ability of osteoarthritis risk by nurses in hospitals. Author Simolon et al. 2019. Method. This type of research is quantitative research with quasi-design pre-test, post-test 2 groups with of total samplings of 239 nurses. Research. The difference in nurses' competitions before and after high surveillance trainings illustrations the significant influence on the highest recording and detection system before and after the application of electronics and paper-based. Literature reviews number 2, titles, Hospital Infections Control and Prevention System using Bootstraps. Author, Sanprayada et al. 2020. Method, analytic descriptive. Research. The results of the study shows several sections, namely implementations of infection prevention and control, which was form subtimes monitoring evaluations of infection preventions, collecting data on infection event and preventing infections, increasing knowledge about infection form, increasing knowledge about infections. Literature reviews number 3, titles, Implementations Electronic Basis, Healthcare Associated Infections, High Surveillance in Hospital. Author, Anna et al. 2022. Method, analytic descriptive. Research. The results of the study shows several sections, namely implementations of infection prevention and control, which was formed for subtimes monitoring evaluations of infection preventions, collecting data on infection event and preventing infections, increasing knowledge about infection format for increasing knowledge about infections. Well, that's all my presentations today. Thank you very much for your extensions. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Okay, next. Next student, Pak.
Good morning, everyone. My name is Ristoni Lasius. This morning, I would like to present to you my research entitled Family Caregiver Roles and Knowledge to Prevent Sequela Stroke. In 2018, there were about 5,809 stroke cases per day in Indonesia. Another resources says that about 328,000 deaths per year, or there are 900 deaths per day due to stroke in Indonesia. And in West Java alone, there are 52,511 cases per day happen per year, or equivalent to 6 cases per hour happen in West Java alone. every stroke patient has the potential for 3% to experience a squamous stroke within 30 days. And it increased 11% after a year and 39.2% within 10 years. So stroke patients in Indonesia are generally cared for by their families. The study shows 8 out of 10 stroke patients were cared for by their families. And family as a caregiver experience burden. The burden is emotional, disappointment, social isolations, and environment, social isolations, and general other general factors. Health promotion of the family caregivers is important to prevent sequela stroke, and their knowledge is very dependent on the health educations they receive while in hospital. The study conducted by the Uyghur and Erchi in 2019, entitled "The Effect of Home Care for Stroke Patients and Education of Caregivers on the Caregiver Burden and Quality of Life." The design of the study was experimental method with pretest and post-test control group, and the participants were 86. And the result of the study shows that home care provided for stroke patients and education of the caregivers decrease the burden and increase their quality of life. The second study by Zhao et al. In 2021, the title of the study is "Effect of Main Family Caregiver Anxiety and Depression on Mortality of the Patient with Moderate Severe Stroke." Whether the design of the study was a qualitative method with participant 819 caregivers. There were 249 males and 570 females. The result of the study is the family support. The support provided by the family caregivers have positive effect on the prognosis of the patient. The test study conducted by the Agianto and Nurtabut in 2018, which entitled "Role and Function of the Family in Care of the Patient with Stroke in Community," where the design of the study was a qualitative method with ethnographic designs, and there were 15 informants, and the result is daily care activities, spiritual activity, rehabilitation, and offering medicines and financial support. And the function of the family care patient is dependent on the family caregiver. From the 3 researches that I have just presented to you, it has a similarities, which is knowledge of the family as a caregiver has a positive effect on the positive attitude of the family in caring for the patient. The result of empowering families as a caregivers can improve the quality of life of stroke patient and reduce the family psychological and economic burden, and especially its very positive outcome to the patient. And as the conclusion, caregivers need to be prepared so that patient care and recovery goes very well, and caregivers need to be trained so that they are able to provide services or to provide care for the patients in very first level, so that we can prevent the sequela stroke. Okay, that's all about my presentation. That's all my presentation. Thank you and good day.
Okay, thank you all my lovely students, Master in Nursing, and all audience. The present today is end in 2 p.m. And I will make the time to Mrs. Murtiningsih as a MC. Thank you, Ibu Murtiningsih.
Merawat Indonesia, emban tugas mulia, mendampingi segenap insan untuk meningkatkan kesehatan, kembangkan terus profesi, tingkatkan terus potensi, profesional dan rendah hati, siap melayani dan berbakti. Membangun negeri tercinta, sehat sejahtera bangsaku. Siang malam sepanjang waktu, langkahmu selalu ditunggu. Tak membedakan umat, semua dilayani dengan cinta tulus dan dedikasi. Kau bawa talenta suci.
Thank you very much for Mrs. Musri as a moderator. And thank you to all the speaker of the international webinar today for delivery material about WS score and Code Blue update in nursing services. Thank you to Rumah Peka as a sponsor. Thank you to our student for presenting the result of the literature review of your thesis. And also, thank you very much for the audience for your kind attention to this webinar. Hopefully, you will get useful knowledge, especially for nursing practice. As a master of ceremony, I apologize if there are so many things that make you uncomfortable. Please fill in the last attendance and evaluation in the chat room. Goodbye to all audience. See you again at the next webinar. Best wishes. Thank you. Terima kasih semuanya. Bye-bye. Sampai jumpa lagi. Wassalamualaikum warahmatullahi wabarakatuh.
Warahmatullahi wabarakatuh.
Warahmatullahi wabarakatuh.
Alhamdulillahirabbil alamin.
Universitas Jenderal Ahmad Yani Cimahi akan menjadi hybrid university, di mana mempertahankan kegiatan konvensional belajar mengajar, namun pada saat bersamaan menjadi open university yang memanfaatkan information communication technology dukungan dari Telkom Indonesia.
Dengan ini saya resmikan penerimaan mahasiswa baru Universitas Jenderal Ahmad Yani.
you.